Hello, everyone. Can we settle down, please? Can we have our seats? Those outside, please, at the foyer, please, can you come inside? We're starting the program in the next few minutes. Thank you. Please, be seated, please. The program is going to start in the next few minutes. And we have an international speaker that is connecting all the way from Chennai, India. She will be joining us via Zoom in the next few minutes. So please settle down. Can you sit? If you are for this conference, kindly sit down. Settle in, come inside. Please, we want people to come inside so that we can start this program quickly. Please, if you are for this program, please come inside and sit. Thank you. Thank you.
I'll take now then. Okay. Please, can we settle down? The program is about to start. Please, can our ushers call those that are outside? We are behind schedule, please. Juma. Good morning, everyone. You're welcome to the 5th Annual General Meeting and Scientific Conference of the Association of Radiation and Clinical Oncologists of Nigeria, ACON. We're about to start the International Scientific Conference, and I want to call on the chairman of the local organizing committee in person of Dr. Bello Abubakar, who has, with his team, put together this whole program. We'll call Dr. Bello. Dr. Bello, please, can you come up to just give us a welcome speech? Thank you.
My dear esteemed participants, welcome. On behalf of the local organizing committee, I would like to express our sincere gratitude to all of you in your interest in participating in the 5th Annual Association of Radiation and Clinical Oncologists of Nigeria's Scientific Conference. We are delighted and looking forward to welcoming you to this event. It is our hope that the fifth annual ACON Scientific Conference will achieve its objective of providing new and groundbreaking knowledge from the cancer scientific community, which will be pivotal in moving the diagnosis, management, and the general care of cancer patients forward, thereby contributing to lowering the mortality of this scourge and improving the quality of their lives. This year's ACON Scientific Conference has been rebranded toward a more scientific perspective, even more so because in addition to our local specialists in the field of oncology, we are involving scientists from the diaspora. It is important to have a seamless merge in the care of patients, and we believe that gearing the conference toward a more scientific approach where key players in the oncology space are present will pave the way for a more holistic approach in cancer patients' care. The conference theme, Redefining Cancer Care in Nigeria, promises to be phenomenal and knowledge-infused event. We have carefully selected sub-themes on emerging trends in cancer care, which we believe will educate participants on new trends in cancer care and ultimately aid us in providing top-notch care to our patients, thereby improving their quality of life. The conference will also see major changes that will include, among others, the participation of sponsors in defining the scientific agenda of this meet. The launch of the Lancet Oncology Commission on Cancer in Sub-Saharan Africa, spearheaded by our ACON president, will feature prominently. The official launch will bring dignitaries, not only from the scientific community, but also political players and the press. There will also be precision medicine plenaries that will showcase cutting-edge radiation science, not only in cancer care, but also in non-malignant conditions with amazing results. Cancer research and outcomes, as well as gene therapies in cancer care, defining precision will also be discussed. As the world explores what nuclear medicine will provide in diagnosis and treatment of disease conditions, we shall also look at the scope and limitation of functional imaging as well as theranostics. Thus, we have partnered with renewed scientific institutions and professionals and carefully selected speakers from around the globe to give you a high quality discourse on the theme and provide exceptional learning experience to you, our esteemed guests. Finally, it is our hope that you will come out of this well-packaged conference satisfied with renewed vigor towards better cancer care. We wish you an enlightened outing and looking forward to hosting you today. Thank you and God bless. And with this, I would like to invite the president of the Association of Clinical and Radiation Oncologists of Nigeria to give her welcome remark. Dr. Amaka Lashibikon, please.
Good morning, distinguished colleagues and participants at this year's 5th Annual Scientific Conference and AGM, hosted by the Association of Radiation and Clinical Oncologists. The LOC chairman has said it all, and I will just briefly summarize in the interest of time. As we've heard, the theme of this year's conference is Redefining Cancer Care in Nigeria. During this event, we have packaged an exciting conference that focuses on upscaling the quality of cancer care in Nigeria through precision medicine. And we hope for stimulating discussions around oncofertility, psycho-oncology, and the need for the multidisciplinary team approach to provide holistic evidence-based care and we're also going to be looking at the emerging nuclear medicine and theranostics care in Nigeria. I am sure it is not news to everyone here that this service is now available in the country. The conference features an in-depth scientific program with both African and internationally renowned speakers, a fusion of the two, so that our discussions will be tailored to providing socio-culturally feasible and easily adaptable solutions that will enhance our care in Nigeria and indeed on the African continent. The agenda also includes symposia led by seasoned experts, and we'll also be having interactive sessions that will equip attendees with distinct tools that can be applied in innovative and resourceful ways to improve cancer along the entire cancer continuum. In addition, as has earlier been mentioned, we will have the launch of the Lancet Oncology Commission reports on cancer in sub-Saharan Africa. During this session, we expect the commissioners to present the key findings and recommendations of this 2.5-year report, fact-finding mission on the state of cancer in Africa, and providing solutions that have been seasoned and thought through by 52 expert commissioners drawn from both within Africa and indeed the global north. During this period as well, we expect for key stakeholders to brainstorm on identifying the current gaps and potential next steps to improve outcomes and strengthen the health system. In the past, we have often looked at healthcare systems and preferred fragmented approach. So during this system, we have brought key stakeholders from across diverse multi-sectorial disciplines to be able to provide a health systems approach to define the way we see and provide evidence-based cancer care to the good people of Nigeria. So to this end, we want to encourage you to bring your innovative ideas and contributions to bear as we hope for robust discussions throughout the conference. The meeting also offers an excellent opportunity for networking and building collaborations. Indeed, we are only, as scientists and researchers, we are only as good as our network. So please take opportunity. The scientists are drawn from all over the world, and as been said earlier on, they are seasoned experts in their own rights. To the LOC chairman and his dynamic team, I thank you on behalf of all of us for the great work that you have done in putting this together. This promises to be an outstanding conference, and we know it hasn't been an easy task, but you all have weathered the storms, and for this we say thank you. To all our participants that have traveled far and wide to be a part of this, thank you for the confidence that you have reposed in us to be able to deliver a world-class scientific meeting and to be able to prefer solutions to the teeming problems we face in the cancer ecosystem. On this note, I'd like to wish every one of us a very memorable ARCON conference. And on behalf of the EXCO and the BOT, I say welcome. Thank you very much.
Thank you very much. We'll be starting the scientific sessions now. And we would like to say we're streaming live on YouTube and on the ARCON website. Please, you can join us there. To moderate this session, I'll be calling on Dr. Emanuela Wanchukwu to do that. She will be introducing the speakers and calling them to have the sessions. Thank you.
Okay, so good morning, everybody, and you're all welcome to the start of the scientific conference. So we'll be making a slight change to the presentations. We'll start off with Dr. Sapna Nangia. She's the senior consultant radiation oncologist at the Apollo Proton Center in Chennai. And she'll be speaking to us online today, virtually, through, on the role of proton therapy in the management of head and neck cancers and other diseases. So this session is sponsored by the Apollo Cancer Institute, and we'll go over online. Dr. Sapna, are you there now?
I am. Thank you so much. Can you hear me? Can you hear me?
Yes, Dr. Sapna, we can hear you. Are you there now?
I am. May I start? Can you hear me?
Sapna, are you there now?
Can you hear me? Thank you so much.
Dr. Sapna, thank you.
Can you hear me? Can you hear me? May I start?
Yes, Dr. Sapna, we can hear you.
So good morning, everyone. I'm delighted to be here. I would, of course, have loved to be with you in person, like I was 2 months ago. And I'd like to especially thank Dr. Bello, Dr. Sagaya for this. I'm delighted to be here. I would, of course, have loved to be with you in person. Good morning, everyone. Like I was I'm delighted to be here. I'd like to especially I would, of course, have loved to. I think there is some disturbance on the line. Excuse me, are you able to hear me? Are you able to hear me? Excuse me, are you able to hear me?
Dr. Sapna, we can hear you. Can you hear me?
Excuse me, are you able to hear me?
Dr.
Are you
Sapna,
able to hear me?
we can hear you. Can you hear us?
Okay, wonderful. Then I'll start in that case. Greetings to everyone in Nigeria. I'd like to especially remember Dr. Bello, Dr. Sagaya, Dr. Ella, Dr. Papola, Dr. Zamita, Dr. IK, Dr. Alabi, and Dr. Ajikeri, whom I met when I was in Lagos and Abuja a couple of months ago. I will now put up my slides. Yeah. So my talk today is on the role of proton therapy for improving outcomes of cancer treatment and quality of survivorship, with a little bit of extra attention to head and neck cancers, but also discussing other malignancies.
Dr. Sapna, if you're on YouTube,
of course,
you need to
across the world, we are somewhat similar in the type of cancers that we see most often. Breast cancer being the most common cancer that we see all across the world almost. I see that in parts of Africa, of course, prostate cancer and cervical cancers are the most common cancers. However, then we have our own specific requirements and geographic distribution that is very typical to us. And across various sites, there are a number of indications for using radiation therapy. In CNS tumors, we would use them in about 95% of patients. In breast cancer, almost about 80% of patients. And across various common malignancies, there is a very strong requirement of radiation therapy. And as radiation therapists, what is it that we want for our patients? We want them to have longer lives free of cancer, and we also want them to have, our patients to have their quality of life intact. I see that I'm receiving a call from the organizers, and let me just take this to understand what the issue is. Hello? Yeah. Yes. No, I'm signed in from only one system. No. Okay. Let me just find out. So I should. Only I have signed in. Let me just find out otherwise.
Hello, Dr.
I can. Hello? I can hear you.
Okay, and then I think the feedback is sorted.
So can I suggest that in that case, I should sign out and sign in again? Would you like me to do that? In that case, please go ahead to your next talk and I will join in again.
Okay, so that's fine. We'll do just that. So let's go on with the next speaker. While we're trying to.
Yeah, let them go on to the next talk and I will join. Okay. Please let me know if there's any issue. Wonderful. So sorry about the technical glitch. And so coming back to what we as radiation oncologists want for our patients. So what do we want? We want them to have longer lives free of cancer. And we also want them to have their quality of life intact. And this is where we have to discuss what proton therapy can do for our patients. Some of the things that allow us to make our patients have longer lives free of cancer is dose escalation and exploitation of radiobiology. And when we talk about having their quality of life intact, we want to reduce the dose to normal structures, reduce the risk of second cancers, reduce the risk of growth retardation, and of cognitive impairment. So we are all, of course, familiar with modern radiation therapy techniques, which involve creating 3D volumes, making plans which may include inverse planning and image guidance. And all this is a given when we discuss proton therapy. What I'd like to mention here is that I have had a special interest in precision radiation oncology techniques and the business of reducing toxicity. And these are some of the works that me and my team have done, which have looked at optimal target delineation, the optimal usage of radiation techniques, as well as looking at novel OARs, which we may constrain to improve the outcomes of our patients, in this case, the hippocampus for buccoalveolar cancers, which is primarily an Indian disease. Now, coming to proton therapy. What is it that proton therapy allows us to do? Of course, this is an audience of radiation oncologists, and I don't really need to talk too much except to say that, well, photons attenuate irrespective, and that remains the same whether there is a tumor in the path or anything else. In contrast, protons stop at a predefined point, and this is called the Bragg peak. And we can see that some of the tumor, this cartoon representing the tumor, is still remaining and therefore a smaller energy, and another smaller energy that allows us to make us sweat out Bragg peak. And what happens with this Bragg peak is that it allows us, because we are being able to protect the tissues that lie distal to the tumor, it allows us to dose escalate in certain situations. It allows us to spare normal structures, allows us also to exploit radiobiology because this sudden deposition of energy leads to more double-strand DNA breaks as compared to photon radiation. And this is, at the present moment, what we are using in our country is the third generation of proton therapy machines, where we use a pencil beam scanning technique, which overcomes many of the issues that were there with the earlier techniques. So this is basically a pencil beam that is traveling layer by layer, delivering radiation conforming to the shape of the tumor. And this allows us to deliver the treatment without making compensators, and also allows us to spare the dose both distally as well as proximally. Earlier on, the proximal sparing was a bit of an issue. This is the Apollo Proton Cancer Center at Chennai, and I should say this is our privilege and also our responsibility of where we are, a very large tracts of the world, of the low and middle income group countries, which have not been served with proton therapy. And it is our responsibility also, not just our privilege, to share what are the benefits and to make this treatment accessible to others in low and middle income group countries. So it has been a longest journey from the time that the data was submitted to our Atomic Energy Research Board, regulatory board, sorry, to the time that the beam became on. It was a long journey, and it took 7 years before that could happen. Also because this was the first time that this was happening in our country, and the regulatory board really needed to be very, very sure about the regulatory part, and of course the installation itself is a big journey. Since then, of course, it's been not just been the proton journey that has been very, very gratifying, but it's also been the other parts that we have been able to develop, and that is one of them is the cancer management teams, and the constitution of the multidisciplinary board, and ensuring that every patient is going through the multidisciplinary board to make the system really robust for our patients. So, as I mentioned, modern radiation techniques involve image guidance, involve 6D confirmation of treatment, couches which are 6D enabled, and it has been very gratifying that that has been possible. So this is the proton gantry. We have 2 gantries and 1 fixed beam room, and these couches are enabled for everything that is now available in modern radiation techniques, such as cone beam CTs, KV X-rays, as well as image guidance, and a few other systems geared up towards pediatric populations, which allow us to create animation in the room, etc., to make it a little bit easier for our pediatric patients to undergo treatment. We also, it has been very, very interesting to use the race station treatment planning system for all the additional features that it has, as well as the fact that the Monte Carlo algorithm allows us to do more accurate, calculation than the earlier treatment algorithms. We are also very particular about peer reviewing each other's plans. Again, as I said, this is a sense of responsibility about what we are doing and the caution with which proton therapy must be used because of all its sensitivity to the beam path length and everything that is in it. So we have treated about 700 patients till date, and I will be sharing some of our experience. As expected, the pediatric patients constitute about 24% of the patients whom they have treated. And as we go along, it will become obvious why. So coming to the impact of proton therapy, what you see here, and I hope my pointer is visible, but what you see here is the proton therapy plan of a craniospinal irradiation patient. This is a photon therapy plan. And on your extreme right, what you see is a comparison of the 2 plans. So basically, this additional What you see on your right is the additional radiation that this child will receive if he or she receives photon-based radiation vis-a-vis proton-based radiation. The proton-based radiation stopping sharply at the vertebral level, eventually translating into a huge advantage for this child in terms of growth retardation and cancer, a second cancer, reduction in the risk of second cancers. Similarly, in the bottom panel, you see a comparison of a proton therapy plan versus a photon therapy plan when we are talking about sparing of the temporal lobes and sparing of the posterior fossa. It's quite self-explanatory to any radiation oncologist, and its impact on learning and cognition is, of course, very, very obvious. So what does this sparing translate into in terms of long-term impact? The sparing, you can see, is the reduction in the risk of second cancers. At 15 years risk, a patient treated with photon-based craniosspinal radiation would have a 45 times the risk of having second cancers, 20 times the risk of having a liver malignancy, 16 times the risk of having a lung malignancy, and that risk reduction reduces very significantly to about 3 times the risk. And that risk remains high in the photon group even 30 years after treatment, even when many other factors may now have come into play. Interestingly, one of the things where the risk reduction is also very applicable and is breast cancer. So we in India soon see a large number of triple negative breast cancers in young women. And we see a lot more younger population. What we see here is this is a photon plan versus a proton plan. And what we can see is the reduction. So all this dose that is spilling onto the opposite breast, to the lungs, to the flank, means that this, when given in young women, there will be a substantial risk of having second cancers. And this risk is very significantly reduced. This second cancer risk is very significantly reduced in young breast cancer women. Of course, there is an additional benefit of reduction in the risk of cardiac risk. And this cardiac risk, especially in women who are obese and diabetic, is something that we will be speaking about as we go along. This risk reduction in cardiac is manifested here by the risk reduction in the dose being received by the left anterior descending artery. So what is the second cancer risk reduction? So when we find that the percentage risk of second cancers, and we're looking at large-scale data from SEERS, from the SEER data, we find that there is a 30% risk of having second cancers after IMRT, slightly smaller after conventional radiation, naturally, because this low-dose spill is much higher in IMRT. But when we look at the risk after proton, there's very significantly less. So this is something that we have to bear in mind when we are looking at our young adolescent, young adults and adolescent tumors, and perhaps for everyone else. Interestingly, as you can see here, again, the risk reduction is across various subtypes, head and neck, prostate cancer. Surprisingly, prostate cancer, we see a very significant risk reduction in the risk of second cancers, favoring proton beam therapy. And that is for all cancers, as well as all cancers except prostate. We find that there is a significant risk reduction of second cancers. It becomes obvious when we look at this young man with a mucoepidermoid carcinoma. So this is a proton plan versus a photon plan. This is the 600 centigrade isodose in dark purple. Mauve is 30 gray isodose, that is, the 50% isodose, so 10% versus 50%. And we can see the comparison on the left of the frame is the proton therapy plan versus the proton therapy plan of a carcinoma cheek. Definitely for this young person, this young man in his early 20s, he was a medical student. We can see that this risk reduction is a very tangible gain. in this curable malignancy. Multiple young men with mucoepidermoid with very various salivary gland tumors. The bottom frames are the proton glands, the dark being 10% isodose, the green being the 30% isodose. In comparison, the proton glands are sparing very nicely. Interestingly, we do not normally think about second cancers when we talk about prostate cancer, but surprisingly, after after the cause of death in the CHIP trial, after prostate cancer, the second most common cause of death in the CHIP trial was second cancers. And what we have found is that after photon, about a quarter of prostate cancer patients go on to have second cancers. Excuse me. This is from some data in Japan. However, after particle therapy or surgery, that risk is substantially and significantly less. So, of course, in proton therapy, we want, besides second cancer risk, there is toxicity reduction. And because breast cancer is the most common cancer in Nigeria as well as in India, I would like to start with breast cancer. And the toxicity of concern here is radiation-related heart disease. We all know the impact of radiation on the various parts of the heart, pericardium, myocardium, and endocardium. And we also know about the risk of radiation-induced cardiac disease, which is about 7.4% for every gray increase in the mean heart dose. What happens with proton therapy? And this I'm looking at deep inspiratory breath hold versus proton therapy. We see the mean heart dose can be reduced from 3 to 4 gray in deep inspiratory breath hold to less than 1 gray for left-sided breast cancer tumors, left-sided patients with proton therapy. So this is how it happens. The top panel is the proton panel and bottom panel is the photon panel. You see the dose that is spilling over into the left anterior descending. 50% dose, 40% dose covering the left anterior descending and sparing. So interestingly, this is one of the most common applications of proton therapy at present in the United States. Breast cancer, not something that we normally think of. And this is, has been our experience. All the doses that you're seeing here, this is the 10 gray isodose, sparing the heart and sparing the left anterior descending. Various applications, chest wall, breast with simultaneous integrated boost, right side where we are treating the internal mammary lymph nodes and sparing the right coronary artery. So this is, we have already, a registry we are using. We treat hypofractionated, 15 fraction treatments. We have already enrolled about 15 patients on this registry trial. And these are the kind of doses, 0.57 mean dose to the heart that it is possible to achieve. Similarly, the lung doses, remarkably less as compared to a usual of about 10 to 12 gray. We are able to reduce the dose to about 6.5 gray, naturally reducing the risk of second cancers and also reducing the risk of radiation-induced heart disease. The cosmesis is satisfactory. This is at completion of treatment. Not too much skin reaction, as you can see. Most of it fades, and this is the same. This patient 1 year after treatment. We can see fairly satisfactory cosmesis with a little bit of less ptosis as compared to the contralateral side. Who are the patients who will benefit most? Young women, diabetics, smokers, obese people, hypertensive patients, ischemic heart disease, especially prior ischemic heart disease, and bilateral breast disease. As far as pediatric patients is concerned, I believe it is self-explanatory. So amongst the group 1 indications, of course, chordoma-chondrosarcomas, but one of the most common indications is pediatric tumors. What you're seeing is the consensus report from the Stockholm Pediatric Proton Therapy Conference. You can see for almost all sites, except perhaps Wilms tumor. There is a consensus amongst pediatric oncologists. This is a consensus that, for all sides, they believe low-grade glioma, optic pathway gliomas, except high-grade gliomas, germ cell tumors, medulloblastomas, ependymomas, craniopharyngiomas, pineal tumors, chondrosarcomas. There is a consensus that proton patients treated should be treated with proton rather than photons. What is the advantage besides second cancer risk reduction, besides growth retardation, is in brain tumors is the superior intellectual outcomes. And I'd like to thank Dr. Jalali, the neuro-oncologist and our medical director, for this slide, which is the data comparing 79 patients. This data is from, this is an original report, as you can see, multi-institutional, which we can see that in photon patients, there is a deterioration in the global IQ and in the perceptual reasoning, but in proton patients, we don't see this deterioration. Similarly, deterioration in working memory, which we don't see in photon patients. Similarly, we can see that there is a, with respect to growth hormone deficiency, we see that proton therapy is eventually more cost effective than growth hormone, growth hormone supplementation. Now, coming to my own area of interest, head and neck cancers, we see that in head and neck cancers, there are, a plethora of organs at risk, each of which impacts some or the other, quality of life measure, or sometimes some or the other very critical organs, such as retina, which would impact the visual pathway, cochlea, which would impact the hearing pathway, the DARS, which is basically looking at swallowing structures and therefore the risk of aspiration pneumonia. And I'll start first with nasopharynx, and this is one particular patient with a lesion involving the base of skull, going on to an intracranial spread. And I'd like to just show you a comparison of the IMPT plan versus the IMRT plan, and the percentage reduction. For example, a 40% reduction in the temporal lobe doses, a 60% reduction in the hippocampal doses, both of which would impact cognition, very relevant in young people who are working population or older people where we are talking about cognitive impairment because of age. Similarly, a reduction in the doses being received by various midline structures, which would impact in turn our ability to give chemotherapy to these patients. So again, you see a significant reduction, 28% reduction in the dose being received by the parotid, 29% reduction in the dose being received by the oral cavity, which would definitely reduce the risk of mucosal inflammation, and therefore improve the odds that this patient will be able to receive the full dose of chemotherapy. So this again is a comparison of a photon plan with a proton plan, and this is the additional sparing. So this much extra dose that a patient would receive with photon therapy is not received in proton therapy without any compromises, as you can see in the dose volume histogram. Similarly, in older people where sparing of the temporal lobe and hippocampal doses reduces the impact of radiation on the long-term quality of life. One of the regions where we found an excellent impact has been in the reduction of mucosal doses. And these you are seeing various patients, at the end of their treatment. And you can see in CA tongue our ability to spare the palate, CA tongue the ability to spare the palate and the cheek. In this patient with the CA PNS, maxillary sinus, the ability to spare the mucosa on the contralateral side. And again, in this patient being treated for tongue, cheek, and palate, the ability to spare the contralateral side. And this, I believe, is a remarkable impact of proton therapy. We've done some original work and, trying to get it published. What you're seeing here is doses to being received by the oral mucosa. So we very actively spare the oral mucosa. This is the spared oral mucosa. And we can reduce the dose, the mean dose, and the dose of various parameters, 32 gray volume, 39 gray volume, 45 gray volume. You can see almost a 50% reduction in the dose being received by the oral mucosa. And this, I believe, is really critical and really quite dramatic. This results in a reduction, 15% reduction in the doses being received, the normal tissue complication probability. There's various literature which tells us that patients who receive proton therapy for routine head and neck cancers, like oropharyngeal cancers, have a reduced requirement of opioids, have reduced risk of hospitalization, reduction in the risk of narcotic use, reduction in the risk of tube feeding. So this, I believe, is the huge gain in head and neck cancers. This is something that I wish to share with radiation oncologists, literally all over the globe, where I believe that this is going to be a game changer in head and neck radiation. I believe head and neck radiation is one of the most difficult for our patients. And any reduction in toxicity, anything that means less hospitalization, less end of treatment narcotic use is a very, very positive development. This is a comparison of uh, a proton therapy plan versus a proton therapy plan for carcinoma lung. I believe I do not really need to explain this in any great detail to a radiation oncology audience. This is important in patients who have compromised lungs, but also very relevant in patients who have non-compromised lungs. And I believe that the aggressiveness with which we are now treating lung cancers, be it early lung cancers, wherein SBRT has led to a whole new gamma treatment option being available for our patients, where durvalumab has opened up long-term survival options in patients with advanced stage disease. I believe that these reductions are very, very valuable. We do know that the survival in lung cancer patients is related to the dose being received by the heart. And what you can see in this is a substantial reduction in dose being received by the heart from 28 to 7.2 gray. Mean lung dose from 19 to 11.2 gray, V20 from 30 gray to 22 gray, which is really very, very desirable. For this, I'd like to acknowledge my colleague, Dr. Srinivas Chiripuri, who is a specialist in thoracic radiation therapy. Another very important, I believe, hepatocellular carcinoma, because of the hepatitis, epidemic in various parts of the world, also because of NASH, also, of course, because of alcoholic liver disease, continues to be a rising health problem. And what we need to understand is that in proton therapy, there is much less likelihood. As you can see in this plot here, after treatment, the worsening of the child's score is going to be much higher in photon treatments, vis-a-vis proton treatments, simply because the uninvolved liver is being spared much better with proton therapy, which allows us to treat patients with child's B disease, which allows us to treat patients with 10 centimeter large hepatocellular carcinomas, impacting, of course, as you see, the possibility of basically being able to treat patients with borderline livers, as well as give a higher dose to patients who have, who have, smaller tumors without perhaps risk of liver compromise. One area where we have randomized data is, of course, esophageal cancers. In esophageal cancers, there is this data which has come from UPenn, which tells us that the mean toxicity burden is significantly impacted by using proton beam therapy with a intensity modulated radiation therapy. We don't often speak of gynecological cancers and discuss proton therapy, but I'd like to just show you this dosimetric comparison, which makes it valuable in certain patients. For example, in one patient who we treated who had a genetic abnormality with bone marrow suppression, idiopathic bone marrow suppression, and the sparing of the bone marrow, as you can see in this situation, very, very substantial.
Dr. Sapna, you have 2 more minutes. So that you
Sorry, please.
2 more minutes.
How much time?
Thank you. 2 more minutes, please. Thank you.
Okay, sure. Right. So I'd like to show you this para-aortic comparison between patients with gynecological malignancy, photon versus proton. So this is in terms of toxicity reduction. Various applications. This is our own original work in prostate treatment from Dr. Srinivas Chinukuri. Again, reduction, as we can see, in the possibility of bladder and significantly reduced risk of fecal incontinence, bleeding, stool frequency, hematuria, dysuria, and urinary incontinence. Of course, we know about chondrosarcomas. We know, and I'd like to show you this, before and after picture of this chondrosarcoma patient treated in close proximity to the optic apparatus. Again, at our center. Another very interesting patient where we needed to treat somebody very close proximity to an already damaged eye. So already damaged eye with a very bad, you could say, very poor visual field assessment because of prior glaucoma. And this is the way we were able to draw up the radiation plan. And then finally, the post-treatment scan, as you can see, a substantial reduction in the chondrosarcoma lesion in a very critical location without any impairment of her visual pathway. Skull-based lesions are another side. This is some data that we have published. Skull-based adenoid cystic carcinomas are treated very well with proton therapy for some reason because of their radiobiology. Proton therapy, with its propensity for double-strand DNA breaks, is able, so you see a lot of before and after pictures, as you can see here, substantial benefit by doing proton therapy. And now we have gone on to treat about 15 patients with adenoid cystic carcinoma with very good outcomes. I would like to close with this very dramatic outcome in this patient. Adenoid cystic carcinoma encasing the optic nerve caused with proximity of the temporal lobes before and then sparing of even of the contralateral optic chiasm. We can see the absolutely dramatic reduction, rather disappearance, complete response. And this patient was not able to see earlier. We see a visual field assessment which was absent. In spite of the fact that her optic nerve was encased, she was able to recover her vision. Her vision remains intact 2 years after treatment, and this has indeed been a very gratifying sort of treatment. I'd like to close by acknowledging, of course, this is a before and after treatment of some inoperable head and neck cancers. As you can see, again, very dramatic outcomes, raising the hope that proton therapy, not enough numbers right now to say that very categorically, but definitely raising the hope. And now we have done a significant number of these patients raising the hope that even in inoperable head and neck cancers, proton therapy might offer a possibility.
Dr. Sapna?
I'd like to close by acknowledging the team at the Proton Center. So this is our team of physicists led by Dr. Dayanand Sharma and our very, very committed therapists. So what they say about raising a child, it takes a village to raise a child. Very much so, it takes a whole community to make a successful proton therapy program. And our results at this point of time have been very, very gratifying. We have a number of trials, a number of registries wherein we are documenting this so that something that is of relevance to our part of the world is available as evidence. And I'd like to thank you for your attention. And sorry, I'd like to just stop the share. I'm trying to stop share here.
Thank you. Thank you, Dr. Sapna, for a very excellent presentation. It was very enlightening. She has spoken to us about, the role of proton therapy, and I'm sure everybody did learn a thing or two about this. So since we are running out of time, we will not have any questions for you now. It's a pleasure for me to invite the next speaker, Dr. Shankar Vangipuram, who's a senior consultant, radiation oncology at the Apollo Cancer Institute in Chennai. He will be speaking to us today about shaped beam intracranial and spine radiosurgery, look beyond the scalpel. It's also another presentation that is sponsored by the Apollo Cancer Institute. Dr. Shankar?
So, are we live? Shall we go? Good. So, thank you so very much, Dr. Bello, once again for the invite. Honored and humbled. And at the outset, after listening the malignant stuff, let's swap the gears and look into a different world altogether. That's the benign and the functional world. So majority of my discussion over the next 45 minutes, Dr. Bello, that's the time allocated, I believe. Am I good? Okay, I'll wrap it earlier. No issues, sir. Okay, fine. So I would like to start by a adage from Hippocrates, rewinding probably a few centuries back. Physician must be able to tell the antecedents, know the present, foretell the future, and have two special objects in view with regards to disease, namely to do good and not to do harm. So radiotherapy has continuously evolved from conventional to hyperfractionation to extreme hyperfractionation, and that's precisely has given us a lot of advantages with regards to loss of work, the wages which is lost, the caregiving roles, and the longer healthcare spending. Now, when I think about radiosurgery, only one thing keeps on ringing repeatedly in my brain because the endpoint which we are seeking is complication. Now, the caveat here is this complication needs to be precisely focal. Therefore, the system calls for specific requirements. That system should be precise, accurate, with the precise and accurate target localization. The delivery system needs to be precise and accurate. And the most important thing is it needs to produce a very sharp dose follow-up. Now, over the next 40 minutes, what I'll be discussing and flying you through is the lessons which I've learned over 2,200 no scalpel radiosurgeries. Therefore, to understand what to do is just as important as knowing as how to do it. As I alluded to yesterday in my lecture, it's all about the extra margin that we give to the target, because a millimeter increase in the margin will almost escalate the doses to the normal tissues by 8 times. There are several commercial delivery platforms you see. which are available in the marketplace, which have enhanced our limits in playing the games of sub-millimeter accuracy with great confidence. Having said that, we need to understand that it is safety, 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 first and last, which is absolutely important for us to look into the results, what we are thinking about. To give you a broad indication, primary radiosurgery is basically based on the premise of the classic imaging findings of a known pathology. Here, it's absolutely mandatory to have a multidisciplinary approach incorporating the neurosurgeons, the neuroradiologists, interventional radiologists, and everybody who are there involved. Because here we don't have a pathologic evidence. Secondary radiosurgery is when you have a pathology in hand and we have a histologic report. When you are having a diagnostic dilemma, never ever contemplate radiosurgery. This is a very strong no. So with this particular background, let us look into what are the broad indications where I'm speaking, where we can apply this concept of radiosurgery. Many of you really know much about it, but the way how it is done to enhance the outcomes is precisely the crux of the discussion, what I will be making. The first, we'll start with the benign indications. So when I say benign indications, it's a vascular lesions that which we will be focusing first. Now, when in the vascular lesions, it's the arteriovenous malformations. I'm sure whatever I'm speaking, please understand, we are not competing with the neurosurgeons. Our efforts is to increase the capabilities of our contemporary specialists to deliver and deliberate good outcomes. Now, arteriovenous malformations, if it is deep-seated and if it is situated in the eloquent areas, these are the two classic indications where radiosurgery has to be used. Now, what this surgical doses of radiation does is it causes endothelial destruction, a platelet aggregation, and this will result in myofibroblast proliferation. Now, this myofibroblast at one point of time get replaced by fibroblasts, and this undergoes a hyaline degeneration and scar tissue, which essentially stabilizes the AVM and obliterates the lumina, the nidus. Now, you need to understand, when we are speaking about AVMs, aneurysms are also vascular lesions. Now, these myofibroblasts are not seen in the aneurysms. These are just the CSF expansions. Presence of myofibroblasts is absolute indication for us to use radiation in the intracranial space. Now, the most important thing which we need to know is DSA is the gold standard for defining the nidus in AVMs. Having said that, we are looking in two-dimensional planes, which is absolute farce. If you see many of the gamma knife technologies in the marketplace, they use the 2D angiographies, and the third dimension is missed out. Essentially, when you see the third dimension, that is where we start integrating the rotational angiography. And to just draw your attention to rotational angiography, 3D rotational angiography will ensure that we delineate the nidus absolutely precisely and in all the planes with perfection. Now, we are just enhancing our capabilities. We have defined the nidus properly. What we really need to worry about is the important functional areas of the brain. How do we fix it? Now, here is a place where we use diffusion tensor imaging and fMRI. Now, this is a patient who had a motor strip AVM. Just in front of the motor strip, in the premotor area near the superior frontal gyrus, you will find the Broca's area. Now, this Broca's area is something which is localized using fMRI, functional MRI. Now, equally important is the connection between the Broca's area and the vernix area, which is connected by arcuate fasciculus. The blue one which you see here, That is the arcuate fasciculus. So when you are shooting surgical doses of radiation, ladies and gentlemen, please do not shoot these areas, because these are the tumors, I would say lesions, which have which are benign. But these lesions, if let's say we are not using a Broca unoptimized plan, we are just kissing the borders of the Broca's area. You optimize this particular area by giving it some additional constraint, you can get it out. Now, let me just draw your attention to the arcade fasciculus, which connects the Broca's and the Wernicke's area. You can see in a DTI unoptimized plan, this, this is the area, which is the arcade fasciculus, which is totally in the high dose gradient. Now, if this arcade fasciculus is shot down and the patient has demyelination, say 10 or 15 years down the line, he is going into what is called as global aphasia, sensory and motor aphasia. So therefore, it's very important we protect the things, whatever are absolutely needed for the functionality of the patient. Now, let me just show you another patient where the lesion is at the motor strip. Now, here, sorry, in the premotor areas. Now, we are very important because in the premotor area, what we are worried about is the motor strip. So what we did is we localized the hand area, which is very close, and also inferiorly, this nidus was close to the arcuate fasciculus. You see, routinely, if it is done, the unoptimized plan, this is what you're finding. You're firing the hand area, and these patients will have long-term complications. So therefore, you localize the hand area and smash it off, you will have very good results. And the same patient, 2 years down the line, the nidus totally obliterated, which is documented by digital subtraction angiography. This was one kid who is probably like 8 years old, who had Weibel-Masson syndrome, where you find a deep thalamic AVM as well as a cerebellar AVM. Fortunately, this was one of the first patients where we have done the dual targeting using the advanced neuroimaging tools which are there with us. Again, as I said, the critical areas were predicted. So this is something which I have learned. You know, plasticity is something which we only listen and read in textbooks. But this is one patient who had a very large arteriovenous malformation in the frontal, temporal, parietal, large one. This was in the dominant lobe. So I was a little worried, how do I treat this patient? So we have run the fMRI studies, and you can see how beautifully the dominant lobe has swapped from the left side to the right side. So I have just shot down the full surgical doses of radiation onto this patient. This patient is doing absolutely fine. We have captured the 4D-MR of this patient, and you can see nidus is partly oblated. When you're treating lesions which are so large, you have to do it in two methodologies. Number one is a volume stage radiosurgery, and number two is the dose stage radiosurgery. Now, when you are speaking about volume stage radiosurgery, you need to essentially figure out how do we do everything needs to be coordinated with our vascular interventional neurosurgeon or interventional radiologist who does neuroscience applications. Now, there are specific strategies we employ where we define the vascular territory and smash it down, or we do dose stage radiosurgery. For example, this was one of the patients who had a large frontotemporal AVM. We have done dose stage radiosurgery, spaced 3 months apart, 2 to 3 months is what we look. And 18 months later, there was a complete nidus obliteration. A large corpus callosal AVM, as you can see, we have done volume stage radiosurgery, and this patient had a very good result. And same goes even with the sensory motor cortex. Please understand, all these patients by default undergo the advanced neuroimaging using fMRI and DTI. That's the default protocol which we use in our clinic. Now, many a times when you see large AVMs, we are in a big soup because our vascular neurosurgeons, they are pretty aggressive. They say, doctor, we want to go and embolize you and give you a small nidus. I just beg my vascular neurosurgeons not to err on that side, because when they place the onyx, which is the embolizing material, you cannot localize the nidus properly. In fact, there is enough evidence that if you embolize these patients prior to the intervention, these patients have a poorer obliteration rate. So once we smash off surgical doses of radiation, what we do for all the patients is 4D MR. Now, this 4D MR is really a wonderful tool that everyone needs to use because that gives us a pretty good idea about the velocity, the physiology things which are happening inside the nidus. And there are specific sequences that we capture in all these patients. Well, just let me swap the gears from the brain to the spine. When you're seeing lesions, the arteriovenous malformation, the typical glomus type 2 AVM, which you see in the arteriovenous malformations, you cannot embolize this. You cannot do surgery. We only need to burn it. And when you burn it, you have to ensure we do all the things in a most robust way. And this is the kind of results you're going to get. We have treated a good number of patients of dural arteriovenous fistulas. Now, when you are speaking about dural arteriovenous fistulas, if it is asymptomatic, you can just observe. You don't need to intervene. But when it is symptomatic, and if it is near the poor vascular access areas, that is the time you cannot do embolization. Like, for example, this was a patient who had a transverse sigmoid DAVF, embolized thrice. The vascular neurosurgeon has given up, and we went ahead and we have done radiosurgery for this patient. This is the pre-treatment scan. 24 months later, you can see the DAVF totally obliterated. The same goes even for cavernous sinus. In fact, I didn't include that particular area. This was it in another patient who had a spinal AVM. You can see how beautifully these responses are seen. So AVMs in the brain and spine, you can easily do these treatments. We have also treated few of the patients who have actually recurred after the surgery, initial surgery, the spinal epidural cavernomas. And you can see how beautifully the lesions kind of respond. Now, let me just swap the gears and enter into a different world of schwannomas. I mean, all of us know that vestibular schwannoma, if the goal of the outcome is to preserve the hearing or to preserve the facial nerve, the best possible tool is radiosurgery. And the dimensions essentially dictate the final outcomes which we are seeing. And you can see this only problem with radiation is there is a lag time which you see with regards to the final outcomes. And you can see typically it takes around 2 to 4 years. And for large lesions like this, we don't do radiosurgery, we do debulking and then chase it up with radiosurgery. This was one of the patients who actually we have suggested surgery because there was a brainstem deformation and the patient was taken intraoperatively. There was a massive bleed. The neurosurgeon called me from the OT and said, Shankar, I really can't do much in this patient. You need to manage with radiosurgery. And honestly, for this patient, we have done radiosurgery. And over a period of 3 years, patient is absolutely fine. Facial nerve is intact. Now, let me take you to non-acoustic schwannoma world, which is the trigeminal schwannoma, as you can see here, how beautifully they respond with staged radiosurgery. This was a patient who had abducent schwannoma. Just have a look at this small kid's left eye. She's not able to abduct it. We have shot down the schwannoma in the abducent cranial nerve. Immediately after the treatment, you can see how beautifully this kid has swapped the eye on the left side. This was a patient who had oculomotor schwannoma who presented, 4 years old kid, who presented with transient diplopia. And there was a left-sided ptosis. When we have done image, you can see how this patient had oculomotor schwannoma. We have done radiosurgery 4 weeks later. Look at the results, how beautifully this unfolds. The same even with the jugular schwannomas. You can't do surgery in these locations because the important cranial, basal cranial nerves are situated here Any surgery at this particular location will only add to the morbidity, and therefore the ideal strategy would be to go and shoot them down with surgical doses of radiation. We have done glomus tympanicum. When you have done glomus jugulare, why can't we do it in tympanicum? When it is a small tumor which is located in the middle ear, we can just go and fire it without much problem. And honestly, this patient was a gynecology HOD from one of the premier institutes of the country. She came all the way to Chennai and got the treatment done. She was offered surgery, permanent deafness. She's done with the treatment. We have done the latest vascular. You can see this brilliant perfusion, which you see there. That perfusion is not there. And this patient was done the scan yesterday in our center, the Advanced Neuroimaging Center, which we have. So, having said that, friends, you need to understand there are a good number of spinal schwannomas, recurrent schwannomas that we can treat with radiosurgery. Again, as I said, this is not per primum. In a post-op cases that we really need to figure out and shoot that down. The same goes even with neurofibroma, recurrent neurofibromas, recurrent schwannomas in the spinal cord, maybe one or two recurrences. The residuals are something which we are targeted with radiation. And the same goes even with meningiomas. This was one of the patients who had a meningioma, as you see there, near the seaweed level. This patient, this was an incidental meningioma that we have picked. The patient was perfectly asymptomatic. We went, fried it, and came back. The third important indication, as you see there, is the non-functioning pituitary adenomas. When it is functioning or non-functioning, you need to keep in mind any benign tumor that we are treating, the long-term control rate, the 10 or 15-year long-term control rates range between 98 to 99%. So you need to keep all this in your mind. So the third important supracellular indication is craniopharyngiomas. Honestly, yes, but again, the post-op residual or the post-op recurrences. These are the two classical scenarios. If you find a kid who is having supracellular tumor, don't rush to do radiosurgery. You have to get the surgery done. And for the post-op residual, we do radiosurgery. This was all the series of the patient that we have done. And coming to the miscellaneous options, as Dr. Sapna has alluded to, we do offer the patients chordoma and chondrosarcomas the option of protons, because proton is something which we know give us superior results. Having said that, for those patients who are kind of not affordable, CyberKnife is also a very good option. As you can see here, this is the pre-treatment and post-treatment, and we have a good number of patients whom we have treated on this particular stuff. We have also treated few patients of malignant patient. Not malignant is a very less volume that I do in my clinic. 80% of my load is benign and functional indications. But when we deal with brain mets, keep in mind, don't treat those asymptomatic brain mets. We don't treat asymptomatic brain mets which come from lung or breast. The medical oncologists have the enough targeted mutation therapies which are there. Having said that, you need to understand when these brain mets become symptomatic, when they are located in the motor cortex, somatosensory, visual, auditory, Broca's vernix, all these areas, once you find the lesions there, the lesions become symptomatic. So when you are speaking about brain mets symptomatic, it is always the battle between the control and the cognition. And essentially, you have different protocols there in place, right from solitary to sparing, hippocampal sparing to whole brain radiotherapy. Again, there are specified indications that we use. If you're dealing with a solitary brain metastasis in a patient who's having good performance status, we either offer surgery followed by cavity radiosurgery or upfront radiosurgery. The results are not much different if you take into the other parameters, because we have enough targeted medications there. It's for limited brain mets, we still offer radiosurgery. For multiple brain mets, in Europe and US, still the standard of care in radiosurgery, but in a country like India, and I'm sure even in Africa, we don't give we don't offer radio surgery. And what we offer is hippocampal sparing radiotherapy. This is one of the patient whom we have done, and then 24 months later, everything gets regress. And patients who are having radio-resistant histologies, that is the time when we are dealing with brain-only relapse, we do offer radiosurgery. Like what I have discussed with all of you yesterday, we see abscopal effects when we also target the brain. This was one of the patients who had colorectal malignancy with, with the liver and cerebellar mets. This patient was referred to me for whole brain radiotherapy. I discussed with the medical oncologist about the options which they were exploring, and we have shut down the brain with surgical doses of 27 gray times 3, and we have found the abscopal effects because this patient was later on put on immunotherapy. This was, once again, as I said yesterday, GI tumors, GU tumors, they are all cold tumors. They do not express the cancer antigens, and you can see the results there. Now, when you are trying to get this abscopal effects, there are several things which we need to keep in mind, which includes the dose fractionation, the type of radiation, the sequencing, and the treatment fill. Because of paucity of time, I do not want to go into the details, but I would be happy to take the questions. This was one of the patients who had intramedullary spinal mets, and you can see we have done cyberknife for this patient. But when we were doing, you can see we have done a 4D MR, and how beautifully this patient swallows. When the patient swallows, look at the spinal cord motion which is seen there. So we need to keep in mind these subtle nuances when we are shooting down lesions. The last one is one of my favorite indications is the functional indications. And one of the functional indications that I commonly treat in my clinic is the trigeminal radiosurgery. Please do not go home with the message that trigeminal radiosurgery is the state of art and the best kind of modality you can use. No, it's not like that. Whenever the patient is younger, we do offer microvascular decompression. It's only in those patients more than 60, 65 years with comorbid illness and who have urgent pain relief that we do this. This was, just look at this patient. This patient had microvascular decompression. Look at the pain stamp this patient has for the cutaneous triggers. Just a small wince. We have just went and placed a 82 gray shot on the on the trigeminal nerve, and you can see how beautifully the response is seen in this patient. We incorporate the CT DTI, diffusion tractography, in all these patients. And when you start incorporating diffusion tractography, trigeminal tractography specifically, you can see these responses for the oral triggers and the cutaneous triggers, oral triggers for the solid food, the cold food which they take. And we have a lot of success stories like that. Now you need to understand that these patients whom we are doing are elderly in age group. When you are speaking about the elderly age group, these are the patients who have brain atrophy. And when you look into the subtle nuances, even the intracranial structures exhibit a resonating frequency. As you can see here, how beautifully the central brain apparatus keeps moving with every cardiac systole. When you are starting with targeting the trigeminal nerve in the prepontine cistern, there is a small feathery flow that you see. And therefore, when you abbreviate and keep the time as low as possible, our targeting accuracy increases. That is the reason why we are able to deliver a very good result for all the patients whom we are treating. All the patients, as I said, we do trigeminal tractography for all these patients, and you can see we track the FA values, which is the fractional anisotropy values. And based on that, we'll realize what is the best option for the patient. The majority of the times, you don't find a peripheral neurovascular conflict. So therefore, we also look into the doses, the FA values. We do tractography of the entire brain apparatus, which is actually involved in the pain pathogenesis. And whenever you find the drop in the FA values, you do radiosurgery or MVD, the patient is going to fail at a later date. What we need to understand is the pain which you are seeing is actually modulated, perceived by different tracts in the brain. Now, these tracts also need to be analyzed through a sophisticated neuroimaging, what you call as diffusion cordosis imaging. DKI studies. When you do DKI studies, you have better understanding of all these patients. This was a patient who had hemifacial spasms. We have done dual targeting of the dress, the right dress, and the VCF bundle. Look at the response the patient had immediately after the treatment. So, ladies and gentlemen, we need to understand that these indications, if they are properly selected, we can deliver good results. The second important neuralgic pain that I deal in my clinic is a cluster headache, where we target the sphenopalatine ganglion and the glossopharyngeal neuralgia. Glossopharyngeal neuralgia, initially I was thinking, is a very rare disease. But honestly, we have seen a very good number of patients. These patients typically have pain in the ear whenever they eat. This patient whom you are seeing here, we have targeted the glossopharyngeal nerve at the pars nervosa of the glossopharyngeal foramen. The second important functional indication is epilepsy. When you're speaking about epilepsy, it is a mesial temporal epilepsy. And this radiosurgery, surgery is an important option, I would say. But again, it results in a significant neurocognitive compromise. So we do what is called as radiosurgical amygdalohypocampectomy, typically in young patients with high level of functioning and a good neuropsychologic scores. And all these patients, we do what you call a stereo EEG to finalize the epileptogenic substrate. And it's very important. And sometimes we use MEG also for these patients to ensure that the substrate which we are shooting down is properly the epileptogenic substrate. We need to keep in mind about the edema which happens after radiosurgery. We should not be worried about it. Just keep them on tapering doses of steroids. And if it doesn't respond, a course of bevacizumab over 4 weeks. And you can see how beautifully this edema responds. The onset of edema, the epilepsy stops. These patients of gelastic seizures, as you can see, EV hypothalamic hematomas, you have to shoot them down. And we have treated good number of AVMs, typically in the mesial temporal lobe with seizure predilection and also cavernomas, as you can see there, with radiosurgery and achieved a good seizure remission. The last one is the Lennox-Gastaut syndrome corpus callosotomy for generalized epilepsy. And you can see how beautifully the FDG uptake is not seen there. The third important functional indication is, as I said, the tremor. Many of these patients really can't see anything, these patients have very intense tremor. I'm not really sure how many have seen this, but they have real trouble in the quality of life. All these patients are offered deep brain stimulation, but it's precisely the financial toxicity is very high. So therefore, what we do is lesioning procedure. And when you're lesioning the thalamus, typically the VPL nucleus is something which is used. And this is one of the patients whom we have done the ventroposterolateral nucleus lesioning, pre-treatment and post-treatment. The tremor has subsided really very well. And when you're doing the lesioning of the thalamus, we need to also do a proper DTI. And that's very important because this DTI, the tracks which you localize there will take us to the target which we are shooting down. And post-treatment, you can see how beautifully the lesion, the tracks also can be obliterated. This is one of the patient, two of the patients, as you see there. These patients post-treatment do not have any neurologic deficit, but on MRI, you can see serial hypointense areas. Lastly, as I said yesterday, for severe cancer pain, we can also shoot down the hypophysectomy. And for behavioral disorders like OCD, we do bilateral double shot ventral capsulotomy, and you can see pre-treatment and post-treatment how beautifully it responds. Lastly, we have done one patient of depression with the subchoroidal tractotomy and anorexia nervosa cingulotomy. So in short, that's the kind of practice we can have. That's how radiation can be effectively utilized for a range of disorders you see in the clinic every day. With this particular intention, what I would like to say is the true potential is still unexplored. And what at least I have realized after 2 decades of my practice in radiosurgery is still the tip of iceberg. And just to draw your attention, Please, if anyone is interested more, welcome to Apollo Radiosurgery Fellowship Program. It's a 3 months intense program, which is structured program for international, for the domestic doctors. We have 1 year fellowship, and for international, it's a 3 months fellowship, and they are welcome. And the spot for all this is Mr. Amit. Amit, can you please stand up? He is one person with whom you can interact and probably facilitate the entire discussion on this fellowship program. Thank you so very much for your patient listening. So I believe it was a different world. It was a different world.
Thank you very much, Dr. Shankar Bangipuram. This was really, really exciting stuff. Like the thing you can do with radiation. Wow, 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 wow. We're going to go into the next session, which is a Roche sponsored session. So I'd like to invite the moderator for the Roche session to please come up stage immediately because we don't have time. Thank you.
Good morning, teachers, senior colleagues. Today I'm going to be standing on existing protocol and introducing to you a colleague based in the UAE. His name is Bahadir. Today we're going to be focusing on precision medicine, introducing that to the audience today, and he will be the one taking the first 15 minutes, and then we'll come up for a quick panel discussion with some of our guests in the room. Bahadir?
Thank you very much. I hope you can hear me.
Super.
So I'll share my slides to start with. So I have trust in the technology and the IT team that you're seeing the slides in full screen. So I'll start. Thank you very much. It's a privilege to speak here in front of this audience. I plan to finish within 15 minutes to deliver the speech of our personalized healthcare approach at Roche. And I'll touch upon the challenges and the opportunities with a couple of examples. So we're moving from treating diseases with one-size-fits-all strategy to giving each an individual patient the solutions that they need, which includes medicines and non-medicinal solutions. And PHC's or personalized healthcare edition here is to combine science, data, analytics, and technology to increase the solution in our disease understanding, and then develop more solutions such as screening algorithms, digital therapeutics, digital apps, in the end, improving patients' lives and also with lower cost to society. However, even now, in the world, only a fraction of humanity receives the best healthcare. And there are many reasons for that. The first is the amount of knowledge we receive is expanding, increasing exponentially. And I actually call it a tsunami of data. In the past, one medical doctor was supposed to know everything in the field of medicine. Now, a medical oncologist or a radiation oncologist needs to read more than 24 hours a day in order to be updated on everything in that oncology field, which is obviously impossible. Complexity in human biology is also staggering. In early 2000s, we used to see lung adenocarcinoma as one single disease. We now know that it's more than 20, 30 different diseases with different therapy options. But the complexity never stops. Knowing EGFR exon 19 deletion was straightforward, but now there are studies suggesting that you need to know if EGFR C797S mutation, which is a resistant mutation, is in the same allele or in a different allele with the T790M, because it impacts the treatments to be used. And this brings a different level of complexity in bioinformatics and also diagnostics. So with single biomarkers, everything was easier. You used to ask one question like, does this patient has, for instance, EML4 ALK fusion? The answer is either yes or no. With comprehensive genomic profiling, you're saying, show me all alterations this tumor has. And then you need to deal with that tsunami of information. Right side genomic profiling is extremely capable of answering that question, but only a minority of patients, as low as 10–15%, can have access to that. And the data is a resource for us to learn, right? So high clinical or high quality clinical trial data only represents 4% of patients that you see in real life practice. The rest is real world data, and we can't currently create powerful insights to change our clinical practice or regulatory decisions due to challenges such as infrastructure and interoperability. The other thing is healthcare systems are inefficient. Higher spending does not always translate into patient benefit. According to WHO, up to 40% of all healthcare spending is wasted, unfortunately. But we now actually have the technology to overcome all these challenges that I just mentioned. Digitalization changed many industries. Like look at Netflix, right? It changed how people watch television after 80 years. But the healthcare systems are behind because they were not built to address today's challenges that I mentioned, or they're not agile enough to take advantage of the digitalization. In today's patient journey, patients are not always diagnosed early enough. We treat with missing information. Access is not universal, and management of patients are not personalized. What we want to achieve is to use data and insights to connect each of those steps in the patient journey to improve two things. One is individual patient outcomes. The second is overall healthcare efficiency. And as Roche, we try to bring solutions that address this new patient journey. And there are already a couple of solutions available, but I'll give you two quick examples now. Hopefully you'll have time to go deeper with the teams in the field later on. First example actually is our partnership with Foundation Medicine, or FMI, on comprehensive genomic profiling. So Foundation Medicine offers an FDA-approved portfolio of genomic profiling tests to help guide treatment strategies for patients with advanced cancers by profiling the tumor for more than 300 genes and also complex biomarkers such as microsatellite instability, tumor mutational burden, loss of heterozygosity, etc. And in the end, it provides a personalized report. This approach allows us to have a higher resolution of the patient's diseases. With the Avenio tumor tissue CGP kit, which is also powered by Foundation Medicine, we aim to increase the access to that expertise through in-house testing in your labs. And there are also additional clinical decision tools to help collect and use the data and help physicians make an informed decision after a genomic profiling results. Just to give you an outcome, which was actually presented in last year's ASCO. So in lung cancer, even if you focus only on 4 biomarkers, ALK, BRAF, EGFR, and ROS1, with a hotspot next generation sequencing, such as an amplicon-based multi-gene panels that you see around. So you are missing at least 3 times more patients compared to Foundation Medicine's genomic profiling approach. So this is just an example, but by the way, this data was done by looking at a high quality regulatory grade real world data set, which actually brings me to my second example, is the partnership on real world data with the Flatiron Health, which is, Flatiron is a tech company focusing on generating clinical trial grade and regulatory grade curated data from electronic health records, real world records. Among many other use cases, there are so many use cases, but this example that you see on the slide shows how real world evidence can be used to accelerate patients' access to innovation. In very short words, it's a long process, but UK's reimbursement body NICE agreed to expand an immunotherapy atezolizumab's reimbursement based on real-world data from electronic medical records. A control arm from the randomized OAK trial was successfully simulated by real-world data, and then this long-term real-world control arm was compared with the atezolizumab arm from the trial, which in the end resulted in a wider reimbursement decision. And now patients who actually need atezolizumab have access to that in UK. This is actually a sign that a high-quality real-world data has the potential to complement clinical trials, assist regulatory reimbursement, and even clinical decision-making. I now have a short video, which was built 7 years ago, so I'll stop sharing. It shows our patient-centric approach, so I'll quickly share the video, hoping that you can hear it and see it.
The fight against cancer is entering a new and exciting phase. Researchers and physicians are beginning to understand cancer and each individual cancer patient in far greater detail. These advances are enabling a much more personalized approach to cancer treatment. Future cancer patients will experience a different personalized patient journey with the promise of significantly improved outcomes. Meet Linda. Linda is a 62-year-old former smoker with a family history of lung cancer. Linda's doctor sequences her genome to test for genetic predisposition to lung cancer. This test reveals that Linda's genes give her an elevated risk of lung cancer. Linda sees an oncologist who prescribes annual monitoring through liquid biopsy. This technique can detect traces of cancer in Linda's bloodstream and enable early cancer detection. Several years later, one of these liquid biopsy tests detects circulating tumor cells in Linda's blood, indicating the possible presence of lung cancer. Unfortunately, further testing confirms that Linda has stage 2 non-small cell lung cancer. Linda's oncologist orders several diagnostics of Linda's tumor, including multiplexing IHC and next-generation sequencing. IHC reveals an abnormal pattern of protein expression in the tumor's microenvironment, while NGS identifies several key genetic mutations. Linda's oncologist uses clinical decision support software, or CDS, to help select a personalized treatment plan for Linda. The CDS software compares Linda's profile, including her background, diagnosis, and molecular tumor profile, to a comprehensive archive of clinical literature and treatment guidelines in order to identify treatment options for Linda. Additionally, the CDS tool compares Linda's profile to a massive library of other cancer patients, finding patients with similar cancers and profiles and deriving insights from the treatments and outcomes of those patients. This sophisticated analysis identifies specific treatment options that Linda is most likely to benefit from given her unique cancer profile, as well as clinical trials to consider. Linda's oncologist carefully reviews these treatment options and their supporting evidence. She discusses these options with Linda, and together they agree on a treatment plan. Linda begins a treatment regime of 2 targeted agents that have shown efficacy in cancers similar to Linda's. Throughout her treatment, Linda's blood is tested using liquid biopsy to detect response to treatment or disease progression. These tests show a positive response, and ultimately, Linda's tumor shrinks and goes into remission, which means that today, Linda remains cancer-free and is living a healthy, happy life. Improvements in diagnostic technology, real-world data aggregation, and sophisticated clinical decision support enables us to create increasingly personalized treatments for cancer patients like Linda. Personalized treatment will help us ensure the best possible care for each patient. And that is progress in our fight against cancer.
Hope you were able to see it. I'll go back to my presentation now. I mean, this video was actually a very good example. It's still relevant, by the way, after 7 years, how patient lives will be impacted with some of the solutions that are being developed as of now. Some of them are already on the market. But I also, with this slide, wanted to add some more data on improved patient outcomes. It's going to be a bit busy, but please stay with me. So the first data that you see is a bit old. It's a meta-analysis of 570 phase 2 trials that involves more than 32,000 patients, which shows that when you apply personalized treatment approach, you can see a significant increase in the overall survival. This is also an interesting recent data of capmatinib for patients with MET exon 14 skipping mutations. These mutations were actually discovered as a potential sign by Foundation Medicine years ago. Further characterization was done, and the team worked with Pfizer and Novartis to develop medicines around that. And several years later, there is an effective targeted treatment on the market. This example, again, highlights how the genomic profiling that you are doing now will also impact patients' lives at a later point. Third example is a randomized trial from United States, which shows when you use combination of targeted therapies, which is not so common now, but it seems to will be common in the future. Based on genomic profiling results, you are able to improve patient lives significantly, as you can again see from the Kaplan-Meier curves. I go further down in the patient journey to the monitoring. Number 4 and 5, you'll see the potential prognostic impact of liquid biopsy to differentiate patients that may be salvaged from an unnecessary adjuvant treatment after surgery, based on the ctDNA results. And last but not least, you can see a web-based digital patient monitoring app's positive impact on overall survival, which is an extra 9 months, right? It's exciting. And patients, by the way, also had less hospitalization and less healthcare usage or healthcare resource usage with an app. It's interesting to see all these data. Research is still going on especially on the last 3 topics, but let me maybe sum up, because this is very complex. But right now, where we are is we are in a transformational moment to leverage the technology into the healthcare. Roche is developing personalized solutions, but on the other important thing that we're doing is to build partnerships with different stakeholders, including governments, physicians, other companies, to work together to enable this new and connected patient journey. And importantly, I know that you want to redefine the cancer care in Nigeria, which is a big take, but you eat an elephant one bite at a time, right? So all these changes doesn't require an immediate total reform of your healthcare. It can be done in a manageable and stepwise fashion. In oncology, the first step usually goes through implementing genomic profiling, then potentially to look into the feasibility of using the available real-world data, so you can start or create a learning healthcare system. This, in the end, will help development and implementation of those solutions, which can improve patient lives and even cost less to the society. With that, I'd like to end here. Thank you very much for your time. I think I'm going to hand over to the organizing team, maybe for some questions, I guess.
Thank you very much, Bahadir. So before we go on to the panel discussion, I'll make room for one question at least. One question, if there's any question in the room. So basically what we have just painted, picture I've just painted now is where oncology care is going. But I dare say that this is where oncology care is right now in other parts of the world. But this is where we're heading, even here in Nigeria. And so if there are no questions, let us backtrack a bit to where we are right now. And so that's why I'll be calling up a couple of a question. Oh, please. Dr. Omikule. Bahadir, are you still online?
Yes.
Okay.
Can you hear me?
Yes, I can hear you.
All right. So I would like to find out from you, and it's more like an advice for this audience, because right now we have in-house the stakeholder within the oncology space in Nigeria. And with all you said, a lot of those things appear to be high-valuing, right? And the truth of the case is it's going to really affect the patient outcome. And we want to get there in Nigeria, and Nigeria happens to be a very low-income country. What will now be your advice in terms of the stepwise approach for us to really, truly get there? What are the things that you think you can start with gradually, like you mentioned towards the end of your presentation, and we can slowly build on that over time so that we'll not be far away from the reality where the developed world are. Because life in the US, in Europe, should be the same thing with life in Africa, especially Nigeria. And we don't like seeing our patients dying the way they are currently. So what will be your advice to us moving to personalized health care for us in this part of the world? Thank you.
Thank you for the question. As far as I can hear, maybe quick recommendation, not from my end, but from what I have seen from different countries. So the important, so the countries who are able to achieve and bring better outcomes for their patients are the ones that start with the end in mind. And this comes from the outcomes. Where would you like your patients to be in? On the other hand, the countries who are successful also is the ones that are connecting the healthcare system shaping or healthcare system developing into their nation's pain points. Maybe I can give an example from, again, maybe will be Europe, but from Croatia. So what happened as a starting point from their end was they had the worst oncology outcomes within Europe, and that was their country priority as a country. So making oncology and digitalization, improving healthcare as a priority for the country, and connecting with that country priorities is the way to start. It's a big enabler. The other thing that I can mention would be to maybe like thinking the system as a whole. And this is really important, especially as a low-income country, low or middle-income countries. So when you think all the different pieces within the system separately, they do all have their own priorities. But when you implement a total change in the system or start that, some pieces of the puzzle will probably spend more. For instance, one part will spend maybe $1 million more, but the rest of the system will gain maybe $10-20 million. So looking at the system as a whole and making it as accepting as a priority for the whole system instead of individual pieces, that also has been quite successful in countries who are doing good in terms of implementing, and in the end, the patients are benefiting in those healthcare systems.
Thank you, very dear. We need to quickly move to the panel discussion right away because of time. So I'll call up to the stage two of our partners and stakeholders. Dr. Solomon Rotimi is an associate professor from Covenant University. Please welcome him upstage. Dr. Paul Jibrin, also an associate professor from University of Abuja, consultant pathologist. You're welcome, sir. And I'll also be calling up upstage Dr. Bola Oyedeji, medical director for Roche. A round of applause, please.
Good morning, everyone, and standing on existing protocol. Following Behadia's presentation, we just wanted to share with you quickly something that we've also started working on as Roche as a first step towards going on this journey that he has painted for us all. And for this, we're trying with our guests here, who are investigators, we try to do a retrospective study to analyze the molecular landscape of breast cancer patients in our country. And this was to identify actionable targets for molecular guided treatment for the patients. The primary objective of this study was to analyze, again, just like I said, the molecular landscape of breast cancer patients in Nigeria to identify actionable targets for molecular guided treatment strategies and compare these findings with data published already on population ancestry. The endpoint for this study was to generate real-world evidence into the genomic variation and diversity of breast cancer patients in Nigeria. And it was a retrospective study. Again, we just wanted to investigate the genomic characteristics and demographic data of banked FFPE blocks or tissue sections using the comprehensive genomic testing. The sample size was meant to be 300 archived FFPE blocks from 2 sites in Nigeria. We use Luth, and okay, so 3 sites. We use Luth, and then we use Covenant University and National Hospital. And the samples were shipped to the FMI lab in Pembroke in Germany for genomic analysis. So today we have Dr. Rotimi from Covenant University, and we have Dr. Jibrin from National Hospital. They were the investigators for this study, and we just wanted to hear their experience, just to share the experience of what this study was like for them.
Thank you very much. So maybe I'll start with Dr. Jibrin. What was your experience like? What were the learnings from this participating in this study as a principal investigator? What was that experience like for you?
My major experience or learning, yeah, I can say that the last word from the presenter, you bite elephant once at a time. I train as a doctor when we have only 5 centers doing histopathology services in the whole of the country. And when I finish my training, I work in a place where you literally give, after surgery, give the specimen to the patient, they take it away and go and bury it. So gradually, we now have pathology services everywhere. But the problem that we have is that we were not anticipating genomic study. We're just looking at the structural morphology and looking at its cancer. It is just beyond cancer. Even the oncology in the clinic you see, you know it's cancer. Now that we're talking about personalized medicine, what are the quality issues that we can take care of if we are going to do further study? We have not been doing that. Hardly will you see pathology is really neglected. It is from this study that I know that if you want to get a good quality DNA, you must take care of your FFPE. And after this study, I can tell you that in National Hospital, our archive is well ventilated with AC. But when you keep your specimen in a place where rat will eat and the temperature in Nigeria, and you want to send the sample outside for this, you are going to get nothing that will help you. So my learning is that we are actually coming gradually, and there is much for us to do, and we need to educate ourselves that it's not stopping with us, just making the diagnosis. Thank you.
So Dr. Rotimi, were there any surprise?
Yeah, thank you very much. It wasn't actually a surprise for me. You recall at the beginning of the study, I mentioned that we should be open to this because of our experience, my experience working on prostate cancer. And the other time Bola talked about that we wanted to work with 300 samples, I guess. We had a failure rate of over 70%. That is consistent with what we have seen before. So the failure rate means that from the molecular biologist or genomics perspective, it's not just enough to get the DNA or you say you have the sample. There is the QC that we usually do to know whether the DNA that you have is good enough for next generation sequencing. And I can basically explain it. What we do when we are doing next generation sequencing is that we chop the DNA chunk into small pieces of about 200 to 300 in base pair length. And that is the way we sequence it. and then we take the data into computer and we do bioinformatics analysis, reassemble the whole thing, and begin to read out the missing alphabet. What happens is that the fragments that you have, if you don't have up to that 200 base length, it fails QC right away. Because of what Dr. Jibrin talked about, and we talked about several things that go wrong, which we are trying to look for how to correct that. We have a high failure rate. Most of those DNA of samples that we have are already fragmented by the time we did the QC. And so what that happens is that yes, you collected the sample from the patient, yes, you have stored it, but you cannot generate any data you can't generate any interpretable data, absolutely. So that is the situation where we are now. And we need to talk about how do we move forward in addressing that kind of challenge.
All right. Thank you, Dr. Rotimi. And so maybe I'll go on to the next question and to ask, hearing what you've said now, what you've learned, and there were no surprises, just like you said. What can we start doing now to implement these learnings in our oncology practice?
Thank you very much. So what we need to do is we need to bring everybody that is involved together in a room. Okay, you have the pathology, the oncology, everybody that you think is involved in the whole pathway. So let's sit down together. This is what we need to achieve. This is the end goal. This is the reason why we can't achieve it now. Okay, so we can promise the patient heaven and whatever, say, we're going to do this genomic thing for you. But if we miss it out at this point, at the end of the day, we're going to fail. And so what do we need to do? And they are not difficult things to address. I mean, he talked about how you handle the sample. That shouldn't be difficult to change. Is it the solution that we're using that is difficult to get? How do we address this? And that is the direction I think we need to be. And I'm excited. Dr. Bello is the chair of this conference. I see Dr. Amakala Shibikon here. I believe the aortic president will be somewhere also in the audience. And it's not just localized to Nigeria. Okay? And I think we need this type of body, or including aortic, Nigeria Cancer Society, to sit together and say, we want to join the rest of the world in precision care, but we have this little to think problem. Let us talk about how we're going to address it.
Thank you, Dr. Rotimi. Dr. Jibrin, do you want to answer that question as well?
Well, I also believe that it starts from the attending physician. Surgical specimen, many things can go wrong from when you are collecting the sample. There's what is called cold ischemia. When a surgeon removes a specimen from a sample from a patient, and you are concerned about your patient, you just keep the sample there. Anything more than 1 hour before you fix it in the fixative, you are not going to get optimal quality of the protein and the DNA that you are talking about. And again, I have seen where samples are kept in saline and sent to us 24 hours after. So there is a need for us to now start interacting together. That comes the MDT. If we want to do further study, the surgeon, at least when I was training, before you do surgery, the operation list goes to the theaters, to everywhere. You know what you're expecting. So the surgeon are supposed to be aware of this cold ischemic time and the time it takes for you to transfer the sample to the pathology and the quality of fixative that you are using. Currently, if you want to achieve a very good high yield of DNA and protein in your tissue specimen, you don't use ordinary 10% formal saline. We're not using neutral buffer formalin. Is it available? Please interact with your surgeon, with your pathologist, so that they can give you this sample regularly, weekly or monthly. If not, all your effort will be wasted. Thank you very much.
Thank you very much. I'll just ask one more question. Maybe I'll start with Dr. Rotimi. What's the value, in your own opinion, of personalized healthcare in oncology or precision medicine in oncology, even in this part of the world?
Yeah, thank you very much. I think the speaker spoke about the value. As the value everywhere, the value that it has in the US, in Europe, the same value it has here, which is treating the disease for what it is. That is no longer an histology disease as it were, but a genomic disease. and you look at the new line of drugs coming out now, they're clearly, tissue agnostic, drugs that are coming out. And for us to move into that direction, we must quickly adopt precision, care. And I'll give an example, and I can talk more about that and I don't have a 30-minute talk tomorrow. You take, for example, tamoxifen, which is, typically administered to HR positive, breast cancer. It's an inactive drug, as it were. It's converted to endoxifen by cyclotropin 2DA, if I get it right. And so that enzyme is very important in the efficacy, determining the efficacy of the drug that you're administering. And so because of the polymorphism of that single enzyme, we could classify the patient into, fast metabolizer, intermediate metabolizer, and the slow metabolizer. And what is required to determine that is just ordinary PCR machine. And so there are low-hanging things that we can do in this country, and that doesn't even require NGS. And we all know now that one of the benefits accrued from COVID-19 pandemic is the proliferation of PCR machine everywhere. Okay, and so we need to talk about how can we bring that into our oncology care and begin to apply that low-level pharmacogenomics or pharmacogenetics as you have. And so think about the effect that we have, that you no longer then, dose that tamoxifen based on surface area or body weight alone, but then you have the genetic information of the patient that could help you determine how fast the free drug tamoxifen will be converted to the active drug, and then eventually affecting the clinical outcome of the patient. That's just a simple example.
Thank you. Dr. Jibrin.
Actually, along that line, with the breast, you know the group of breasts we call triple negative. And if you send a patient with triple negative to oncology, their treatment guideline and regime is the same. And triple negative is just a group. It's not just a single entity. If you don't calm down, they vary from patient to patient and classify them as simple as AR positive. So even people with triple negative, there are few percentage of them that are androgen receptor positive, and their response to treatment is very good. So if you don't calm down and start managing, investigating your patient as an individual, and you just classify them into a group, you will see a lot of treatment failure in some that you would think that maybe the diagnosis is wrong. We have to do more, and personalized medicine is the only way to go. In other places now, they are even doing tumor sensitivity, just like antibiotic sensitivity. You have to, whether it will respond to this chemotherapy you want to, you can do that before treatment. They are doing that, and there's nothing preventing us from doing it. I don't believe Nigeria is resource poor. We are a resource managed country. If we all agree together and get people that are involved in policy making, I think we can operate at the same level with others. Thank you very much.
Thank you very much, Dr. Jibrin. I mean, just to say that there was a time in this country when H&E was the standard of care, and then we moved the notch a little bit forward, and now immunohistochemistry became the standard of care. We are advocating to the audience in the room that there's another step forward, which is precision medicine, personalized medicine as the standard of care, both for diagnosis and for treatment, all in the bid to improve patients' outcome. I'll hand over to Dr. Oyedeji to round up.
All right, thank you. And thank you, Dr. Rotimi and Dr. Jibrin. We will just round up by saying, I think this was a very eye-opening study that we did. Of course, eventually we did close it. Dr. Rotimi spoke to the failure rate that we had in the study that did not enable us get the kind of data we wanted to get, but we will still publish this from what we've gotten when we're getting all of the analyses. And if you want more details on this, please feel free to reach out to us and we can share this. But I mean, in closing, it's just to say that this is the way to go. It looks like a lot, and it looks like, where do we start from? But I think, just like Behedia said, it's one step at a time. And what the focus now is, we go back into our clinics and now begin to, really pay attention to the kind of samples that we're getting, already beginning to see the patients as individuals and not just as, a disease entity walking into my room. And once we begin to think in that way, I think that one step at a time, we break down for each patient what their profile is. We will find ways of getting sustainable, we will find sustainable ways to begin to profile our patients to know what their genomic profile really is. And I believe that this is what we all need to do as a healthcare system. It's not just about rush, it's really everyone working together to make this happen. So we will engage further. And if there are any other questions, we have a stand at the back there where we can further these conversations. Thank you very much for listening.
So good morning once again. Thank you to Roche for that very exciting next generation sequencing. Molecular treatment is the way to go. So we agree with them that we have to upgrade the services that we provide. So the next session, it's Marcel Ruth Cancer Center sponsored session, but I think because we're behind on time, we're thinking that we can go out for tea break, come back with a tea break, and then we start the session because we won't want to go in between. So let me just yeah, so we'll have a 10-minute break to go pick up the tea break and come back. We will invite, please, the registered participants, please. We will want you to go first. Thank you very much. In the meantime, I also want to announce that, please, we have an Archon conference app available on iOS and on the Play Store. Please do well to download this app. It will, you can live stream and find out more about the speakers and the event from the app. Thank you. Hello, hello. Please, we have some announcements. Please, we asked for just the participants to go for tea break first and speakers so that they can come back into the hall. So please, we are requesting for those in the booths and technical staff to please hold on so that when we return, then you can go and have your lunch break. Please bear with us. Thank you. Hello, attention everyone. Please, we're calling all participants to please come back into the hall. We're about to start the next session. Hello, you can come in with your tea break. The next session is starting now. Thank you. Okay, we want to welcome everybody to please come back into the hall so that we can start the next session. Please come back in with your tea break. Please, can I have officials to go around to tell people to come back into the hall, please? Officials, please, can you tell people to come back into the hall? People want me to call names. Dr. Adewale. Dr. Adewale, what are we sharing? What are you sharing? Exactly. Okay, so it's still morning. Good morning, good morning, good morning, everyone. Welcome to the next session that we have for today. Today we'll be talking about precision medicine in cancer care. Looking at, radiotherapy at Marcel Road Cancer Center, looking at the journey so far. They would also be speaking to us about their LINAC-based stereotactic radiotherapy, treatment planning for stereotactic radiotherapy, and also let us know how to refer patients to Marcel Road for radiotherapy. So this session is sponsored by Marcel Road Cancer Center and Specialist Hospital in Lagos. And we will be inviting their speakers to probably come up stage so that that will make a smooth transitioning from one speaker to the other. So I'd like to invite Dr. Modupe Elebute Odunsi to please come with her team. Dr. Adedamola Omogbeni, Dr. Michael Akpochafo, and Dr. Olaya Popola. And let's give them a round of applause as they come up. Thank you. IT, are we ready with their slides? Oh, yours is with you? Yes, I'm going out to go and pull them out. So please, let's settle down, settle down. It's going to be a very interesting session. It promises to be an interesting one. So please sit down and let's start.
Good morning, everybody.
Thank you very much for having us at this plenary session. In particular, I want to thank Professor Bello, who has been, I think, almost, with his incredible team to put this program together. Can you hear me? Because it was a bit strange. Can you hear me? Yes. Okay. All right. My name is Dr. Elebute Odunsi. I'm a hemato-oncologist by training. I trained and worked in the UK for almost 40 years. Came back to Lagos about 3 years ago to set up Marcel Ruth Cancer Center and Specialist Hospital. I remember giving a talk at ARCON last year, which I think was the first ARCON meeting after a number of years, particularly due to the COVID pandemic. And interestingly, the topic at the time was, how do we move cancer care forward in Nigeria? And I was asked to come and speak on implementation to being operational. I want to say I'm extremely excited because in this last 12 months, there's been a number of other centers who have now become operational. When we had this meeting last year, we were maybe the new kid on the block. Since then, we have had the Asi Uko Hospital Center in Calabar, which was the dream of an incredible man, General Asi Uko, who unfortunately did not live to see his dream materialize, but from somebody who's not even in the medical field, was incredible the amount of effort and strength and commitment he put into starting that center, which is now operational. Obviously, Mikio has come to the table with a PET CT scan. So in a period of 12 months, we have actually begun. Why is it gone off? I know. I wanted to refer to the thing behind me. That's okay. Yes, thank you. I want to say that I think that we have begun to redefine cancer care in Nigeria. That is the theme for today, okay? And I think all of us need to come to this session with that in mind. The efforts that we're making to improve cancer care in Nigeria. And it's incredibly important that we realize why we need to do that. There's a number of reasons. One is we are able to treat our own patients in our country so that they can have their relatives, their people, their support systems around them. All of us here who treat cancer patients know exactly why that is so important. So we do have that onus to try and do this. Secondly, unless we're kidding ourselves, we're slowly watching the Naira go to 1,000 to the dollar, all right? So when we get there and maybe get past it, our patients are going to find it difficult to afford care in country, talk less of outside the country. So I would like to implore everybody here, our role now is to try and develop and improve and redefine cancer care in Nigeria for Nigerians. My first slide, please. Thank you. So that's a photograph of Marcel Ruth. I know some of you have come to visit. Certainly when we had the ARCON meeting last time, a number of oncologists came to visit us, which was very, very good. We're still there. We're still working. It's still, maintenance. Everybody kept saying, are you sure you're going to maintain it? Are you going to show? But we're doing a good job. And is this working? What do I need to do? It's not moving. I did. I know, but it's not moving. Oh, does it go here as well on the front? Is this working or should I do it manually? I'm happy to do either. Nope. Can I use this to make it go? No. Apologies. Technology.
It's not going. No. I was given the wrong. Oh, it's okay. Right, fine. Painful. We'll get there. Okay. So when we discussed last year, it was trying to discuss the fact that the original thoughts about putting this together started as far back as 2012. And throughout that process of conceptualizing what we wanted to do, to planning, to trying to find the funding, which is, I think, a whole lecture for a whole day, working with the legal framework, working with all the different parties, the people who are going to supply your equipment, the contractors, the building, the equipping. And we got to 2019 and we were slightly behind the curve that we hoped for, but we did become operational in 2019. And since then, we have managed to staff the center, and we're working very, very hard to ensure that we are working to what we hope are the good qualities of standards that we want to be looking after patients in. And what I'm going to try and discuss with you is what we are doing right now. So this is the building. We've got 3 buildings on the premises. And the one that's highlighted in yellow in the middle is the one that probably interests most people here, which is the bunker for the radiotherapy machine. So that's what it looks like indoors. And we have a virtual video on our website for those of you who haven't been or who haven't seen it. What we tried to do was to develop it in a way that didn't come across like hospital, because as we know, cancer patients are very anxious, very worried. So we tried to develop an area and a system that made it look more sort of nicer, with lots of colors, and we're looking at research that this actually helps to promote healing. So the vision is to deliver high standards of care, such like you would find if you went abroad anyway, to our patients in the country, in surroundings that promote healing. We've got a senior management team, myself as co-founder and CEO, Dr. Omogwe, who is sitting behind me, who is our director of radiation therapy and radiology. Dr. Omogwe is still based in Washington, DC. And in fact, I have to say, we have to applaud him later on. It's taken him 2 days to get to Abuja to be at this meeting. Just to show you the commitment that we have to oncology in country. This slide, basically the message is that we're very senior led. We're very senior, very consultant led. Hello? Hello? What did I do? Touch it. Hello? Okay, it's all very sensitive here this morning. I should stand still. So we're very consultant-led. There's myself, and as I said, I trained in the UK at the Royal Marsden. I worked as a consultant at King's College Hospital and St. George's Hospital. I did a lot of research and drug development and teaching. Dr. Mogwe is still based in the US. Our director of nursing did her oncology nursing in Emory Hospital in Atlanta and worked there for over 30 years. We've got 2 senior matrons, one who has spent 30 years in the radiotherapy sector, and one who's worked in general medicine and ICU, all for over 30 years. So we're very, very senior led. And even in pharmacy, we have an oncology pharmacist, and we've got family medicine physicians as well. And this is important. This was really important to me, that, you know, we are not going to provide care for our patients without the expertise across the board. And I think this is apparent that is quite important. I'm really struggling with this. Okay, so our services are, as you would expect, in a comprehensive cancer center. And recently we were awarded pioneer status by the federal government as being the only true comprehensive cancer center, which means a center that's able to deliver everything from diagnosis, screening, to all the facets of treatment, including surgery, chemotherapy, and radiotherapy in the private sector in Nigeria. We have a number of obviously state-of-the-art equipment. So we have a 64-slice CT SIM, one or two in the country. And obviously we have a TrueBeam linear accelerator, which we all refer to as our baby. It's the only one in West Africa, and obviously able to do some of the very high-tech work that was presented earlier. So like I said, surroundings very, very intentional in providing the right surroundings for our patients. This is our chemotherapy day unit, where patients require have care. Our mammogram, and this is our theaters. We've got 2 modular theaters on site. And at the moment, we're now reaching over 100 surgery that we've done since we became operational. The TrueBeam we've mentioned, and essentially this case study is not to read it out to you, but is to show that now the majority of our patients come from diagnosis, or we're picking up his people at screening. So for example, we had a 42-year-old gentleman. It's gone off completely now. IT, okay, came for screening with his wife, and we ended up picking up a stage 3 renal cell carcinoma. So we're picking up new patients with breast cancer, which is great from our point of view, because now we're actually beginning to pick up patients a bit earlier. How have we grown since I came to Archon last year? Certainly when I came, I think when we started in November 2020, there were 5 staff members and myself. We now have almost 80 members of staff, 50 of whom are clinical. We have a very robust tumor board, and I think this is really crucial. And I think there's now, am I missing something? There's now a lot of research to show that cancer centers really do need either multidisciplinary team meetings or tumor boards to ensure going on. Well, it's very difficult to go on when you see people running behind you, because I want to leave the stage. You can say go on because you're sitting there, right? I was oh, you see, there you go. And they're telling me to go on, right? You know, I'm gonna have to leap off the stage. Is it okay? All right. Anyway, we have a tumor board. And apart from all the specialists that I've discussed with you that are full-time in our building, we're also joined every week by our radiologist who's based in the UK, and 4 other oncologists who are based in the US, Toronto, who all come together with us to ensure that we're managing patients in the right way. And I think this is something that we're very proud of. In the last year and a half, we've seen almost 2,000 patients, new patients, and we've seen almost just over 1,000 cancer oncology patients. The growth has been phenomenal since we launched. We're seeing over 400 patients a month, and we're seeing at least 100 new cases every month, and that has been static since we actually launched last April. Our patients come from all over the country. It's incredible. So like on Thursday, we had a lady who drove all the way from Zaria to Kano before she flew to Lagos, where people are driving from, you know, Lokoja, all over the country. But interestingly, we're also seeing an increasing number of patients who are coming back from abroad. Initially, they were coming back because they've been told that, you know, there was no hope, just go back. But now we have people who are actually going, having their diagnoses made, and then they're learning that actually there's a center in the country that can treat them, and they're coming back for their treatments, even at an early stage, which is very, very gratifying. And with the surgery, like I said, we've done over 100 cases, and we're doing very complex surgery now. So this was a gentleman with a pituitary tumor who had it done in a non-invasive manner because we have a very special microscope to remove it in a transsphenoidal way without having to open his skull. But we're doing lots of different surgery. Now, I was listening to the session on precision medicine, which I think is really, really interesting. And I do think that if we're going to redefine or push forward cancer care in Nigeria, yes, we've got to also work with that scheme. And we're already working towards that. So very quickly, we realized that we're going to be a center that's going to be collecting a lot of cases in one place. So we're already collecting blood and saliva samples from our patients with proper informed consent and storing them in a -80-degree freezer. We're going to be looking at family studies because in our hands, quite a lot of the patients seem to have a positive family history. Up to about 30 to 40% of our patients have a positive family history. We're collecting samples, and we're going to be doing some genetic studies and genomics on them in the near future. We all know that early detection saves lives, and that we as a body of oncologists have a role to try and ensure that we make this diagnosis earlier so that we can treat our patients properly. So we have launched a number of screening systems, and particularly one which has become very popular, which we call Swift screening. And basically we do the screening for patients in under 1 hour, and it costs less than 100,000 naira. Both for women and for men. And lastly, and I'm extremely proud of this because out of our center has developed a patient support group that the patients themselves started sitting around waiting for radiotherapy. And they now have almost just over 100 patients as part of that support group. This last week, we had Prostate Cancer Awareness Day, and there were 50 men who came to the talks. We had an educational day. Dr. Mogwai and Dr. Akinola, who's a urologist, spoke. And for me, it was incredible because when I first came back, this whole stigma about cancer was so huge. People were even trying to tell me to take the word cancer out of the name of the hospital. And fast forward to 1 year, we now have people who are coming to the center, not just as patients, but also actually sharing their experiences, supporting other patients, and being part of this system, which I think going forward, and in line with what UICC has given us for the next 2 or 3 years, the theme of closing that cancer gap by removing the stigma, we're already seeing that in a space of 18 months. So I'm sure that going forwards, this will become something that's very, very important. These are just photographs from the educational day. And the gentleman in the black is a prostate cancer survivor, engineer Ibe, who worked in oil and gas, and he's leading, like I said, over 100 people at the moment from all over the country. They have an exco, they have reps from every geopolitical zone. It really has been incredible. We're very proud that we won Most Outstanding Oncology Center of the Year at the this year's Nigeria Healthcare Excellence Awards. And actually, the reason for mentioning that, it was initially I was like, well, I'm not an awards kind of person, but the amount of work, the sheer grit, the sheer commitment, the sheer, coming to the table to deliver this excellent standards of care by every single member of our team. So when we get testimonials from patients, they go, oh my gosh, from your gate, even your security men, help me get in, help me push the wheelchair, to the very, very specialized team, and beyond, in between, everybody works so hard to try and make sure that we deliver great care. So for that, I'm extremely glad that we were given that. What are our future plans? So I have a thank you to say to Professor Adenik Pekun from the University College Hospital of Ibadan, who has encouraged us to think about becoming a training center for the oncologists who have already passed their part 1 and are ready to do their part 2, because they will have the experience on the radiotherapy machine. And very recently, they've come and do their very thorough accreditation. And I think we're going to be doing this from next year, which would be fantastic, so that, again, we need to think about improving infrastructure, but we also need to think about increasing the training in the country as we face this brain drain problem. That is a big issue for us. We're in the process of negotiations with a number of other places where we're going to put in satellite radiotherapy machines so that we end up with this vision of having a hub in VI, but scope with other radiotherapy machines in other parts of the country. But having already put down this very well established, very high standard of care backed by a great multidisciplinary team, we will be able to deliver very good clinical care to patients across the country. That's what we need to do to redefine cancer care in the country. And we also are going to expand on our site next door so that we also have more in terms of the offerings for our patients. And my biggest dream is that we will also set up our own stem cell transplant unit, not just for sickle cell patients, but other cancer patients. Thank you very much for listening. And so I think, I think I was very good with the time because I was fighting with the technology. But anyway, we got there. But may I just introduce Dr. Damola Omogbe, who is a clinical radiation oncologist who trained in Sam Lagos, he's Ibadan. You can imagine there's always a discussion about which was the best medical school. But anyway, and he's based in Washington, D.C., and he's going to be talking to you about precision medicine in oncology care by talking about what the TrueBeam linear accelerator can do in terms of stereotactic treatments for cancer patients. Thank you.
I guess it is still morning. Forgive me, my voice might be raspy. As you've already heard, it's taken me a couple of days to get here. Excuse me. So I oversee radiotherapy over at the Marcel Ruth Cancer Center. I'm a US trained radiation oncologist, but I'm going to take off my US hat. I'm going to wear my Nigerian hat for today's talk. Some of the other speakers have actually given some very elaborate and detailed presentations about what it is that linear accelerators can do and what proton machines can do. But stereotactic radiotherapy or radiosurgery is really in its infancy in this country. And so I think we need to kind of like reel ourselves backwards and sort of like decide or understand what it is that we can do, where we're going and where we currently are. So before we even get to the stereotactic radiotherapy and what have you, I'm going to just say a few things about whole brain radiation. But stereotactic radiotherapy, for those who are in the field and who are in the know, kind of was brought about by Dr. Lars Lexell back in the 50s. He was a Swedish neurosurgeon, and what he was trying to do was develop means of treating benign conditions in a non-surgical fashion. So to some people, he would be seen as the grandfather of radiosurgery. What he came up with, the Lexell Gamma Knife system, the name Gamma Knife still rings true today. A lot of people will tell you, I want Gamma Knife treatment, but the underpinning technology, the stereotactic radiotherapy or the stereotaxis of it is what ties all of these systems together. So whether it's CyberKnife, Gamma Knife, a TrueBeam, whatever it may be, it is basically stereotaxis. The Gamma Knife itself is something, and I'll show you pictures later, that actually has had a cobalt unit, or it was a cobalt unit that had 60 cobalt sources, 201 of them, which would come at different angles. And so you would use that to achieve the kind of beam shaping or beam arrangement that you needed to treat any intracranial lesion. But now we have the stereotactic radiosurgery or the stereotactic body radiotherapy treatments that can treat not only intracranial, but also extracranial lesions. And as you've seen from some of the pictures from earlier on, these beams can be multiple. These beams are can be very small, very tiny. They're very tightly contoured, and the rapid fall off is what allows us to be able to deliver treatments in areas that are critical without sort of like creating damage to these areas. So specifically, we're just going to be talking about brain metastases today. And as we know, they can be found in up to 40% of cancer patients. And if you break that down, the majority of them come from breast, lung, gastrointestinal, genitourinary cancers. In other environments, melanoma is another reason for brain metastases, but that isn't necessarily true in this environment. Excuse me. The team, and again, this talk is really sort of trying to bring us back to what it is that you need to actually get a radiosurgery program off the ground. The team is going to consist of the individuals that you see listed here. Obviously, the neurosurgeon is probably where this whole thing begins, because patients are going to show up on a neurosurgeon's doorstep with symptoms of a brain metastasis, or if they have a scan, the neurosurgeon is probably the first person they're going to go to. But in our hands, we need to have a medical physics team that is very capable of the kinds of treatments that we need. Obviously, we need the radiation therapists who are going to be the ones that actually operate the machine. It's all fine and dandy if you have this machine, but if you haven't got people who can work on it and work on it safely, then what's the point? Then you have the radiation oncologist, and you also have the nursing staff. So please don't forget, your nursing staff are just as critical as the surgeons. For brain metastases, there are sort of 3, maybe 4 major paradigms in terms of how they can be treated, depending on the number, depending on location, depending on their size. There's surgical resection, there's whole brain radiation, obviously, and stereotactic radiosurgery. This is a busy slide, but basically it's just going through these options in terms of when to use certain options. So if you're thinking about surgical resection, you're probably looking at 4 or fewer lesions. These could be lesions that are causing cerebral edema or a mass effect. Those are the ones that you're going to want to go in there and sort of decompress, especially if it's in or close to eloquent areas. Stereotactic radiotherapy or stereotactic radiosurgery, you can also use for up to 4 lesions. There are techniques and there is software that's coming out that can actually treat more than that number of lesions. And I'll show a few pictures of some multiple lesions later on. Whole brain radiotherapy, if you have more than 4 lesions, again, if you have really large lesions, that's ultimately what you're going to do. Or if the patient's performance status is really poor or their quality of life is poor, you're not looking to extend life per se, you're looking to just control symptoms in as quick or in as short a time as possible. And then, as I think has also been alluded to earlier, we now have various sorts of therapies, medical therapies, be them targeted treatments or immunotherapy, that are also kind of like now incorporated into how you treat patients that have brain metastases. So just to show how, I guess, current stereotactic radiotherapy is, the NCC guidelines, which is something that a lot of us in the States use, and again, I said I wasn't going to use my American hat, but we do use this during our MDTs. It just gives you support for what it is that you're doing in terms of using radiosurgery. And it kind of gives you some guidelines as to whether you should be looking at whole brain, whether you should be looking at surgical resection, or whether you should be looking at stereotactic radiotherapy. For people who may or may not be in the know, it gives you an idea of how many treatments and what dose per treatment or per fraction that you can use. What are the disadvantages? Actually, your hand was covering that, so I don't know how many minutes I had, so I'm not gonna. So what are the disadvantages of whole brain radiation? And this is kind of like just to set the table as to why we now do radiosurgery. There is neurocognitive deficit, or there can be a neurocognitive deficit from when you treat the entire brain. When we didn't have the technology, whole brain radiation was kind of like the default position. Somebody came to you with a single brain metastasis and you gave them whole brain radiation. We no longer have to do that. Some of the other side effects are somnolence. So you have patients who are just very sleepy because they've had whole brain radiation. They're very tired, and it can actually impact quality of life. So when we can, we really should be moving away from whole brain radiation. Some sort of data to support what can happen with whole brain radiation. Not to say that it doesn't have a place. Yes, it does. It is going to reduce failure within the brain, but it doesn't extend survival, and it does not necessarily improve quality of life. And as I said earlier, there are neurocognitive deficits. And so like there's these 4 or 5 studies just went on to show that the neurocognition as a result of radiotherapy was either the same or worse. So again, you need to be very selective in whom you're going to offer whole brain radiation to. For those of us that have been in the field long enough, you may remember when Patchell's study came out back in the 90s. And this was really what pushed whole brain radiation into people's conscious of what to do when people came to you with brain metastases. The two groups were surgery and radiation, which is kind of a misnomer because you would have thought that the surgery group only got surgery, and that's not exactly what happened. What happened was the surgery group actually had the lesion resected and then they had radiation. The radiation group only had a biopsy and then they had radiation. But the point is, if you look at the, I think the second line here, if you look at the numbers that are in brackets, those are percentages. 52% of the people in the radiation group actually developed failure after the treatment. So the tumor hadn't been resected, they got radiation and it failed. But the tumor being resected and then getting radiation, significantly fewer patients actually failed within the brain. So that's where whole brain radiation kind of came into it. So talking about the machines that we can use, this is a linear accelerator variant. I know my variant buddy is here, but they have really exciting names. We got Edge, you got Vital Beam, you got True Beam, but essentially they can do the same thing. They can all do the same thing, which is deliver radiation treatments in an extremely precise manner. That's just showing that the machine itself can rotate however many degrees that you need it to. And this piece of equipment here is the actual treatment table. Now, this is what really helps when it comes to treating patients with stereotactic radiotherapy. This is what's called a 6 degree of freedom couch, meaning it can go up and down like that. So it can select pitch down or pitch up. It can roll and it can also yaw. So you can vary the position of the couch to get the position that you need to actually get the treatments in. We typically would prefer not to rotate this couch in any one direction more than 1 to 2 degrees. If you do anything more than that, you really are not treating the way you should. I think the slides have stopped. So this is an example of one of the sorts of masks that can be used. This is a kind of a clamshell. It has 2 pieces to it and it's very, very rigid because of the level of accuracy that is required to deliver these treatments, talking about sub-millimeters. And I think one of the earlier speakers who mentioned here the functional, like trigeminal neuralgias and that sort of thing, you're looking at really tiny targets. And so you really don't have the give that you would if you were treating a whole brain, obviously. So this is very important if you're going to be doing radiosurgery treatments. So just referring back to the Lexel system or the Gamma Knife system. So the picture on the left just shows the frame that was typically used for the Gamma Knife treatments. This is a box that has fiducials in it. Those fiducials are points of reference to help you know your X, Y, and Z axes. And then the Gamma Knife unit itself, as I mentioned before, 201 different beams can be focused on any one lesion at any time to be able to give you the precise conformal treatment that is required. How do we decide who should get radiosurgery? I think some of the basic things you have to do are obviously a CT of the brain, which is where this all begins. But I think what's most important is you need to get an MRI of the brain. That can help you see how many lesions you're dealing with, where they are actually located. Is there any edema? Is there a mass effect? And the better sequences to use are the T1 weighted with GAD or the FLAIR. If you have MR spectroscopy, that obviously is more helpful because it can help you distinguish between a malignant and a non-malignant process. And this is just a quick slide just showing you what an MRI can show you versus what a CT can show you. So the images at the bottom of the CT doesn't look like as though there's anything going on in there. But if you look at the images at the top, this patient actually has 4, maybe 5 metastatic lesions. So again, it's really crucial if you're going to be treating brain metastases that you get an MR of good quality and of the right sequences. Slides have stopped. So it's just some general guidelines in terms of what you should be doing when you're looking at stereotactic radiosurgery. By definition, SRS, stereotactic radiosurgery, is 1 fraction. If you're giving 2 to 5 fractions, you can either call it stereotactic radiotherapy or fractionated SRS. we've said a number of times that these beams are pretty conformal. We have dose sort of ranges that we can use anywhere from 15 to 24 gray, depending on the size of the lesion. And also, what we also have are, I guess, tables that tell us where we are in terms of the dose that's going to any one area that is going to actually get you into trouble. And the kinds of things that can happen are radionecrosis, where you can actually damage the brain because you've given too much to too large of an area, or leptomeningeal disease, which can occur anywhere from 6 to 15% of the time. So these are the things that you kind of like have to look for in the background in terms of your patient selection and what kind of treatments that you actually offer the patients. Again, these are dosimetric constraints, and so these are the main things that you'll be looking for, trying to avoid the radionecrosis, cranial neuropathy, hearing loss, making sure that you're avoiding the optic pathway or the cochlea. But you want to try and stick within these organ at risk constraints. So I just wanted to show really briefly two cases of metastatic disease, kind of like in the different ways of presentation. So the first one is a 59-year-old female whom I first saw about 7, 8 years ago. And I mean, for somebody to present with brain metastases, you look at them and it's like, 6, maybe 9 months, but this lady's actually survived a good almost 10 years now. And when I first saw her, we treated her with whole brain radiation, but then she then comes back like 3 or 4 years later with 2 isolated metastases. And at this point, we started using radiosurgery to treat the lesions. And so you can see these lesions are kind of like isolated. The sort of yellow circle that you see around are the arcs that we use for the treatment. She came back a further time now with more lesions in the brain, and we retreated her, not the same lesions, but to these new lesions. But the point I'm trying to make here is that just don't discard a patient who has brain metastases as someone who may not potentially survive more than a year. This lady, as I said, is going strong 8 years later. The other thing, and that's just another profile of how she was treated to this particular area. Another thing is this particular patient, this is a gentleman who had metastatic lung cancer and had adrenal metastases as well as a metastasis to the pons. And typically, we are very skittish about treating the pons because obviously the autonomic functions that it controls. But if you can identify very clearly where your lesion is, and you have a really robust physics team, you can get away with treating these patients and treating them safely. And what you need to do is be wary of the dose on the periphery of what you actually contour. So this gentleman, for that lesion, he had several other lesions, but I just highlighted the pons lesion. The dose prescribed is 14 gray, but you want to make sure that the dose on the periphery is no more than 12. If you can't do that safely, then you should be looking at fractionated stereotactic radiotherapy, not just the one treatment, just to stay safe and minimize radiation necrosis. You need to work very closely with your physics team to come up with your own comfort level in terms of what the constraints are for your normal structures. And so this is a table that we use to make sure that we are not overdosing any areas that are unaffected and are obviously important. And this just a few pictures showing the pons treatment. So this gentleman actually had 5 different fields, or 5 arcs, I should say. And this is just in one particular direction. Basically, you want to take a cone beam CT at the very beginning with the patient in an AP perspective. You can make your shifts once you've done the cone beam, and then from there on, you can actually deliver the treatments. Between each arc, and actually sometimes during an arc, if you want to be extra careful, you probably should do another cone beam as well, just to be sure that nothing has shifted during the time. So just to round up, for those of us in the room who might be interested, this is a recent meta-analysis that looked at surgical resection versus stereotactic radiotherapy. And the conclusion was, if you were looking at a limited number of brain metastases, say 4 or fewer, it was better in terms of local control with radiotherapy than when you actually when you actually treated these patients by surgical resection. But I think the key is how to select the patients and make sure that you select the right patients before you actually decide which of these treatments it is that you're actually going to offer the patient. So just to summarize, as I just said, very careful patient selection. using dexamethasone as coverage during a stereotactic radiotherapy, depending on how many lesions you're treating, how large they are. And this is one of the areas where the nurses come in, because they need to make sure that your patients are on the right medications, the right doses, and what kind of symptoms are they having as a result of either the medication or the treatment. I mentioned at the beginning, reserving whole brain radiotherapy for patients with a somewhat sort of attenuated performance status. Memantine, which is a drug which is often used for dementia patients, is typically recommended if you are going to use or going to deliver whole brain radiotherapy, in terms of sort of minimizing or at least reducing the neurocognitive deficits that you have. But I think, as we have heard already, the big thing here, the big push here, is to involve everybody. So it should be a multidisciplinary decision in terms of what kinds of treatments you will be offering. And that final slide was just another picture of where it is that we do all of these treatments. So thank you for your time. So now I'm going to have Dr. Mike Apochafo come to the podium. He's our senior or chief medical physicist. He's going to talk about the physics aspect of what we do.
Good morning, everyone. All protocols observed. Okay, I'm Dr. Michael Akoshafo. I'm the chief medical physicist at Master Root Cancer Center. So just to follow up on what my director has discussed, which is on stereotactic radiosurgery or radiotherapy, as the case may be, I will be discussing the treatment planning aspect and also the machine requirement or physics requirement for you to be able to start a stereotactic radiosurgery or radiotherapy. This would be the outline of my discussion. Okay. So most of my discussion will be based on TrueBeam. Obviously, you can do stereotactic radiosurgery with other types of machines, such as the Gamma knife, the Cyber knife, and all that. But I'll be paying more attention to the machine that we have, which is the TrueBeam, and its requirement that allows you to do this particular type of treatments. Stereotactic radiotherapy or radiosurgery that has been defined has to do with delivery of high dose to either the brain or the body using, if you are using small fractionation regime, that would be like, that's a stereotactic radiotherapy. But when you use a single dose or a single delivery of a high dose, you're talking about the stereotactic radiosurgery. They are almost the same thing, just a little bit of different. One has to do with fractionation and the other has to do with just once of delivery. Okay, so for the TrueBeam, some of the features that makes it very good for delivery of this treatment involves the real-time imaging, which it has. The KV, the MV, the KV-CBCT, the MV-CBCT, the MLC leaves, very important. It's good to have MLC leaves that are very small to be able to deliver those type of small treatments. So for TrueBeam, we have about 120 millennium MLC leaves. And then the couch rotation is also very important. For the conventional linear accelerator, what you have is a 4-degree rotation couch, but for the TrueBeam, you have a 6-degree of freedom rotation couch that has both the pitch and roll rotation, which take care of the smaller fields per se, when we talk about in terms of millimeters. And then the RPM gating camera that helps you to monitor your tumor motion and movement. That's also very important. So talking about the RPM monitor, usually this comes with the Varian system. They actually install it in the city, so you can take 4D cities with it, so that with that you can plan your stereotactic targets using, taking care of the motion, the motion movement of any organs. However, you can also do other ways of suppressing your tumor using devices like the abdominal compression devices like this. You can be able to suppress your the motion movement of your tumor. And then the immobilization devices is quite different from that of the conventional treatments. With the conventional head and neck treatments, you have immobilizational devices that are not as strong and stiff as compared to that of the stereotactic. The stereotactic ones are quite different and quite strong, manufactured by different companies that gives this, but you really need to have it because you don't want any movement during the treatment. You want the patient to be very stable. You want reproducibility to be at the highest level and the precision to be very high, because we are talking about treating of 2 centimeter, less than 2 centimeter tumors. When you're talking about that, you have to be very precise, and that's where getting the right mask is important. And then for the dosimetry or physics requirements, you have to condition your treatment planning system to be able to do stereotactic radiotherapy. You cannot just use the same normal commissioning for conventional treatment to do stereotactic radiotherapy. For you to do that, you have to do measurements that are under 2 centimeters. Because you are looking at treating much smaller tumors, you have to then do measurements, because at small fields, there is a problem of loss of charge particle equilibrium. If you use the normal ionization chambers that are used for measurement, so you will require some specific ionization chambers, like the pinpoint ionization chamber, that are very good for measurement of small field dosimetry. And there are protocols for that. We have the TRS 485 and which is the technical report series produced by the IAEA, and the American protocols. The British also have theirs. So you have to follow those protocols for measurement for stereotactic surgery. So you have to recommission your treatment planning system for it to be able to do stereotactic plannings. So these are just some measurements we did when we were commissioning our treatment planning system, having in mind that we are going to do stereotactic surgery in the future. So we're able to take measurements with smaller fields, do some calculation using our treatment planning, and then we're able to compare the measured doses to those calculated and to get a quite precise accuracy, such that we know that our system can actually do stereotactic surgery. This is very, very important before you embark on this journey. And then one of the most important things about stereotactic surgery, like I have said before, is the setup. The setup is very important, the precision. You have to be very rigid to ensure that there is no movement, because you are talking about smaller targets, and any miss of those targets between the CT reference image and the verification image at the treatment point, you will have a very high damage to organ at risk. So the setup is very, very important. So that leads us to use of images. So CT images is not enough. Just like my director mentioned, MRI, PET CT, every image that can give you a very good, clear tumor, what you want to see, is very, very important. But we know that the CT image is the most important because it has a Hounsfield unit which allows you to do those calculations in the treatment planning. However, you have to fuse this CT image with the MRI image or the PET image for you to be able to have a very good delineation of your targets. So for stereotactic radiotherapy, you could do a single target planning or multiple targets planning, as the case may be. Like if you have a multiple metastasis of the brain, you can actually do a plan for that, or you can do for a single one if that's the one you want to treat. And for this case, the target delineation is very, very important. It's strictly protocol based. You have to stick to the protocols. And then for those prescriptions, there is also protocols that are for this. We have the ICRU 91, which gives a very good prescription regime for stereotactic radiosurgery. For the treatment planning, mostly it's based on rapid arc or VMAT, as the case may be. You have to look at the arc geometry selection. You have to select your arc based on the region of where you have your target. If your target is on the left side, you have to select an arc that it's on the left side. And if your target is on the right side, you have to select an arc that's on the right side because you are trying to avoid any dose getting to organ at risk as much as possible. So you have to select the right arc. And then for additional clinical goals, okay, for ease of planning, what we've done in our center is to implement what we call the clinical goals. So the clinical goals contains your constraints. So your constraints tells you the dose to organ at risk and the dose you want to give to your target. So with those constraints, as you are planning, you'll be able to see that, okay, if my brain stem is getting this, my lens is getting this, my this, and then you can then restrict the doses to those organ at risk to the limit that you have set out using the protocols. So that is a very good way of helping with your plans by implementing clinical protocols, such as your clinical goals. The optimizer environment for Indian optimizer environment, which if you take a look where you are going to actually put in your numbers, telling the dose to different organ at risk and the dose to your target, you have to be very, very specific and very, very clear on what you want to give using the clinical protocols that you have set in place. For example, RTOG gives you a very good protocols that gives you doses to your organ at risk and the doses to your target. So with that, you are able to set, okay, I want this, the brainstem must not exceed this, the lens must not exceed this, the eyes must not exceed this, brachial plexus must not exceed this and that, and then you set up all this. And then with your clinical goals, you are able to see this real life that, okay, you are not going beyond the tolerance dose to those organs. And usually for stereotactic planners, the tolerances are quite very severe and very low, very high compared to where the conventional treatments that you do, because you are talking about giving a very high dose to a very small spot. So you have to be very, very, very high in terms of precision. And then for your dose calculation algorithm, usually you will, so usually the AAA is very good. We have both the AAA and the Accurus. Accurus is almost an algorithm that is formed out of the AAA. It's a bit faster, but you can actually use any of them to do your dose calculation. For normalization, well, it depends on the quality of your plan. If your plan has a very good quality, you might just decide to use no normalization and make the plans like that. But if you feel like your plans still require normalization, then you can go to, okay, target main. You can use your target main as your normalization, or you can use some other normalization. The goal of the plan is to ensure that you have a plan that meets all the goals, all the clinical goals that you have set out at the beginning of your plan. And once the plan is ready, a second physicist will then take a look, review the plan. And once the plan is reviewed and it's passed, the plan will now be passed to the oncologist to review. And once the oncologist review the plan, so it's a multidisciplinary treatment process. Once the oncologist look at the plan and the plan is okay, using the protocols and all that, the plan will then be returned back to the physicist to follow up on the process. So for the treatment, before the treatment can happen for stereotactic, you have to be the QA is very, very, like I said, is very, very precise compared to the conventional ones. So we have the patient-specific quality assurance. So for the patient-specific quality assurance, you can either use Phantom or use the EPID, which is the electronic portal imaging system. So for both cases, you have to set your requirement to be very high. For the conventional one, we can accept 97% accuracy. But for stereotactic, we will be looking at 99%, 100% passage of the plan. And if that does not happen, you have to go back and review your plan for it to pass, to meet up those accuracy level. And then for position of the patient, which is very important on the day of the treatment of the patient, the physicists have to be on ground, the oncologists have to be on ground, as well as the therapist who is actually doing the work of the treatment of the patient in terms of positioning. So once the patient is well positioned using the stereotactic head mount and everything is set, the verification image will then be taken. Once the verification image is taken, the oncologist will have to take a look at the image and approve the verification image before the patient is actually treated. This is very, very, very important because you have to be sure that it is the image that you have from your reference city image at the first day of simulation that you also have. The mesh is also very, very important. We are talking about millimeter meshes now. So anything beyond a certain level of millimeters will not be acceptable. The therapists have to go in, reposition the patient, ensure that you meet the necessary requirement before the actual treatment is delivered. And once this treatment is delivered, we can also go back to our delivered treatment and then check other aspects of the treatment, such as from offline review. The oncology can check if the shifts are okay, if everything is fine. Physicists can do their weekly chart check, where they check every process of the treatment that has been carried out before the patient go for the next treatment, in order to ensure that everything that has been done from the first treatment is accurate and is as planned. Once you've done this, you know that your treatment is fine. So for stereotactic radiotherapy, that as I said, is a multidisciplinary team. Everybody is involved. Everybody has to do their aspect because, like they say, the chain is as strong as the weakest link. So if there is any part of the team that is weak, you will have problems delivering these types of treatment. These are my references. Thank you.
Good afternoon. My name is Olaya Kokwala from Marseille Route. I'll be talking briefly. Thank you, sir. I'll be talking briefly on how to refer patients to Marseille Route. First and foremost, I want to appreciate all our colleagues locally and in the diaspora that have been referring patients to us. Just like Dr. Oditi said earlier on, that our center won the most outstanding cancer care center in Nigeria just this year. This has been done. Thank you. This cannot be done without your support. Really appreciate you for being there for us. Thank you. And I will just say that referring patient to us at Marseille Route is simple. And it's just like when you are referring to any other colleague. Basically, with every referral, there's some information there. But before referring patient to us as Marseille Route at all, particularly if that patient is coming outside of Lagos or outside of Nigeria, we appreciate if you contact us or inform us beforehand about that patient, so that whatever it is to ensure a successful stay of that patient with us, while with us for our treatment will be put in place. And when we are referring a patient to us, in the referral letter, we expect the basic things, the relevant history, examination, and all the likes. But oftentimes, aside from the referral letter that is given to that patient, we appreciate if other relevant medical records necessary for proper treatment of that patient is actually given or also come along with that patient. For instance, as simple as the CD imaging of that patient is very, very important to us, because for the fact that the patient is referred to us with the referral letter doesn't just mean that we just take that patient like that and start treating the patient. We also want to ensure that whatsoever it is said about that patient in his record is actually seen according to what the report or in the imaging that patient has brought to us. On some occasions, we have seen a lot of difference between what is in the CD imaging of that patient and what is actually reported about that imaging. And that just changed the entire scenario in terms of treatment of that patient. And also, aside from the imaging or CD, sometimes we have a lot of issues in this country in regards to histology reports. Sometimes when a patient is sent to us without clear-cut histologic diagnosis, we appreciate if that patient is coming, he comes either with the original tissue or at least with the tissue block, so that we can have an evaluation of that imaging, of that tissue block, so that we can assist that patient knowing exactly what is wrong with that patient before implementing the treatment. And After we have done with every and treating that patient, we prepare a medical report and send along and send that patient back to the referring physician. And just like what Dr. Lucy and Dr. Damola said earlier on, we know where we are coming from, we know where we are, and we know where we are going. When it comes to cancer center in Nigeria, at Maserut, we are an outlier. And anytime we send a patient to us, we appreciate it. And we also want a feedback about that patient's treatment. Thank you.
Hello? Okay. Please let's give the Masaru team a round of applause for this very interesting session. It has been very enlightening. So we would have, I think 5 minutes for question and answers session. So do we have questions? Okay, Dr. Bello. Okay, yes, please, can someone come take the
Let me sincerely congratulate the Master Ruth team for job well done and for what you are doing to change the narrative and redefine cancer care in Nigeria. My question is to my very good friend, the radiation oncologist. Do you do hippocampal sparing in Master Roots for your patients that are undergoing whole brain radiation to reduce the cognitive dysfunction? Thank you.
Oh, okay. Is it working?
Yeah, they go on. Power button. There's a power button.
Right. Can you hear me?
Yeah.
Yeah, thank you for that question. Unfortunately, a lot of the patients that come that require whole brain radiation have lesions that are either involving or very close to the hippocampus. And so if you spare the hippocampus, you're effectively not treating what you need to treat. But if patients do come that don't have lesions in that vicinity, then yes.
Okay, thank you. Any other questions or comments? Okay. At the back.
Where are the ushers?
No, there's an usher that is going to.
Okay, please, if you have a question or comment, please just raise your hand so that we know the numbers that we have. Okay,
Thank
1,
you.
2, 3. Okay.
Thank you for
And that's what we
this
can do.
very wonderful presentation. My name is Charles Ugwai. I'm a chief consultant neurosurgeon, National Hospital.
Okay.
And
He's also our NMA chairperson for
yeah,
FCT.
let's
Thank
leave
you.
politics now. Yes, I am also the head of academic neurosurgery, National Hospital, Abuja.
Okay.
So I'm asking this question because sometimes we are faced with a challenge with brainstem tumors, specifically brainstem gliomas. I want to know if you have experience, if you have received this category of patients, and also in the same line, patients with deep-seated brain tumors, gliomas, such as in the periventricular region, the thalamus basal ganglia. Oftentimes, these areas are not very attractive to the neurosurgeon, except you work with a navigation system. And I know that you practice in Lagos. How do you manage these patients? Sometimes some surgeons will just say, go to the radiation oncologist. They have not given you a tissue diagnosis. So what has been your experience? And what have you done with those group of patients? And what is your advice generally to the neurosurgical community in Nigeria and West Africa? Thank you.
Thank you.
So I think do we want to take all the questions and then we answer?
It's probably better to answer them, otherwise we forget.
Okay.
That quickly.
Okay, so
I'm going
let's
to
allow him.
Yes, thank you very much. That's a very good question. I'm going to do from a more general point of view in terms of referrals. To say that actually we are being referred quite a number of head and neck cases and quite a number of, in fact, deep-seated tumors. That's why we elected to buy the special microscope that we have. And I'm sure you know Dr. Biodun Ogungo in Abuja, right? Who was we were in medical school together. Unfortunately, it took quite a while to get this microscope through customs and into the country. At the time, we actually had 4 cases waiting, but we had to let 1 or 2 of them go elsewhere because it was taking so long. But since then, we've done some surgery at Marcel Ruth, but also in terms of looking at the more directed radiotherapy. I'm going to let Dr. Mogwai talk to you about that, because it's not just about the skills, it's about having the, the specific equipment that we need, which we're investing in, but none of these things are easy to get into the country, as I'm sure you're aware. Yeah.
So yeah, that is a very interesting question. It does present sort of practical challenges and real world challenges in terms of what you can do and the limitations of what you can do. And so, yes, those patients can be treated, but there are caveats. And I will say that, first of all, the brain, as with any other structure in the human body, as most of the radiation oncologists in the room know, have levels of tolerance. And so there's only but so much radiation that you can deliver without then leading to a treatment-related side effect or a complication. For the most part, you can get away with giving a reasonable dose to those sensitive structures in the brainstem. Whether it will cure the patient versus whether it will control the patient, that's a situation depending on the size of the lesion and the exact location of the lesion. And the other point that you raised, which is also a real world situation, and that is treating without a tissue diagnosis. Not to be flippant, but most radiation oncologists will tell you no meet, no treat. But in these kinds of situations, you have to look at the radiological information that you have, as much of it as you can obtain. You need to look at the patient themselves, and the patient needs to buy into the treatment. The patient will now have to be counseled and educated as to the most likely situation that they're facing and what may happen if you don't proceed with treatment versus what the risks are of proceeding with treatment. And once you can counsel the patient, the final decision is going to be that patient's decision. If they will sign an informed consent to say, yes, we're prepared to proceed with the treatment as is, then we will treat as if we know what we're doing in terms of the malignancy and that. And again, sort of like sparing what we can and ensuring that we don't use the treatment to induce further problems. So it's a true real world challenge, but there are ways to get around it.
Can I just say quickly, sorry, before you ask another question, that also when you refer these cases to us, because they're quite complex, you can join the MDT, you can join our tumor board meeting and be part of that discussion, because we also value that the referring surgeon in particular or physician is part of the tumor board decision.
Okay, thank you very much for your explanations. Very quite understood. Let me just follow it up with some sort of information. If you run into such situations, which has a very overbearing medical legal implication sometimes, exposing a patient to chemotherapy, radiotherapy with no clear tissue diagnosis. We need to explore all the options available. I'm happy to inform you that here in Abuja, I work with some private hospitals. The Wellington Neurosurgery Center has a neuronavigation system. With that system, we have published papers of biopsy of brainstem lesions, transcerebellar biopsy of brainstem lesions. Our oncologists here, they are not as liberal as some in other places. They always insist on tissue diagnosis, and they will bear us witness that we have been able to give them tissue diagnosis from brainstem lesions. Similarly, we have also been able to give them tissue diagnosis from deep brain lesions, like in the thalamus, like in the basal ganglia.
Yeah.
And as a matter of fact, with the navigation system, it has been quite rewarding accessing previously difficult to access lesions. Let me say something about operating microscope. Yes, we have operating microscope all over the place, but the use of operating microscope in accessing lesions, especially lesions that are deep, it's very, very limited. Operating microscope will become easier for you to use if it's a tissue lesion, you're already looking at it, you're already seeing it. Yes, but it's difficult to make a very deep dissection to the brain without unacceptable collateral damages to the brain. Thank you so much.
Thank you very
Thank
much.
you very much, Dr. Ogwai. Okay.
I just want
Dr.
to add on
Sridhar.
what, yeah, I'm Dr. Sridhar. So from India, HCG. So we have CyberKnife and
I can't hear you.
hello.
Sorry.
The mic is on actually. Like
Yes,
Yeah.
it's on.
it's okay. So I'm Dr. Sridhar. In continuation of both the people what they discussed. So I want to add on 2 points. Yes, as a radiation oncologist, we for brainstem glioma, it's not necessary. We do a multiple, that is radiological investigation is good enough to consider for the treatment. But now we are looking for more in brainstem glioma. I'm very happy to see that somebody is doing a biopsy, which is very, very important in brainstem gliomas now, because brainstem gliomas is a different type of pathology. We are looking for a molecular aspects, and there are definitive targets available. So that's very good. As long as histopathology is able to achieve, molecular diagnostic is very important. I really appreciate that. That's number one. Number two, coming back to what we saw, that same input, same output. In case of brain tumors, in high-grade gliomas or brainstem gliomas, we have a standard treatment of 50 to 56 gray or 60 gray, and followed by temozolomide. So we know that it is 12 to 14 months is the survival. So we have modified, actually I'm going to put in my slides, in high-grade GBMs especially, so increasing the dose to the target by extra boost with the CyberKnife, going radiobiologically to 100 equivalents, biological equivalents, we have doubled the survival. So it comes to 28 to 32 months. Same in case of brainstem gliomas. There's a little bit modification in terms of increasing the temozolomide to 1 year, with or without bevacizumab has changed. I would like to talk to you outside the discussion. We can have more discussion. Thank you.
Thank you very much. Okay, I know 2 people had their hands up. We are running short of time. Dr. Bello, can you override? What do we do? Because it's bringing a whole lot of discussions, and can we continue?
Yeah. There's a lady who had a
Yes,
Stella.
we have one question there and another one
There's a lady.
here, and my oh,
Thank you. I think they can always meet the team afterward, but let's take 2 more patients. For the sake of time, please. Thank you. So 2 more patients, 2 more
questions. Okay, all right.
Please.
Thank you, Dr. Bello.
If we make them brief,
Yes, I will
we
be
can do
very
that.
brief. Once again, thanks for the opportunity. I want to bring in what we used to do early days when Abuja machine breaks down and you move all the patients from Abuja to Zaria.
Okay.
And we do cost sharing.
Where does he work?
Breakdown of equipment will always happen. And I think we should begin to think of how, if Abuja breaks down and Masale Route is using similar machine, instead of waiting for 2 weeks, 3 weeks to fix Abuja machine, is there a way we can move the patient and block to a center where the same equipment is being used, where all those things. So I think this is the next level I want us to begin to think in collaboration amongst all centers, because machine will surely break down. But it is not acceptable because machine breaks down, patient have to wait for the machine to be fixed. It's just a point I want to throw into the open here, hoping that in the long run, we will look at our cost sharing. We help, especially when we have centers in the private sector that are not fully maximized in terms of patient load. And we cannot keep patients waiting for machine to be fixed under the government cover. Thank you very much.
Thank you very much.
It's a really good point, actually, and it's something that we're already beginning to address. So in the last few weeks, we've actually in the process of signing MOUs with a number of hospitals so that when they have a problem in terms of access of care, that they can send patients to us. So if that's something that you want to have a discussion about, we're very happy to have a discussion. I think we are already trialing it with 2 centers and it's working very, very well. And in particular, I think it's benefiting the indigent patients who would not normally be able to access care. So it's a really good point. I think we have to come to this with an innovative and practical mind, because as we are all trying to establish cancer centers across the country, which is fantastic, we've also got to be very practical. And I'm going to be honest, even in our sector, you know, the maintenance costs of these machines runs into tens of millions of naira per quarter. That's the issue. And as I said before, we know where the naira is going against the dollar. So, you know, it's going to continue to be a big issue. You know, it's a really, really good point. And I think that we need to collaborate because our vision is not just to be able to treat patients who could afford it or who could leave the country. The vision is to be able to ensure that patients get access to treatment, but get access to treatment at the top quality as though they had left the country. That's what we're trying to do. So we are signing MOUs at the moment with a number of hospitals, and I think that's the way forward. Thank you.
Yes, thank you very much.
I think there was one
There
more
was a
question.
lady-
There was a lady
the
in the
lady
front who had a question.
She's been putting her hand up.
Thank you very much. My name is Dr. Bolaji Latif Salako. I want to commend the team from Marcel Root, and I would like to put my friend like Dr. Popola when he said that we should refer patients to their center. My concern is that majority of our patients, they are indigent patients. I don't know, maybe he's talking about a patient with a big pocket or any patient that we can just send to them. Apart from that, is there any mechanism or grant concerning indigent patients as part of a social and corporate responsibility? And if you don't mind, can you tell us if there's a financial implication if you send patient to your center? Thank you very much.
Thank you. I think we can listen to Dr. Alabi's question and then they would address, and that's it. Thank you.
Thank you very much. So my question is to the radiation oncologist. I'm Adewumi Alabi. I'm a clinical and radiation oncologist at Luth. So I want to know what your experience is with our patients here in terms of offering stereotactic radiotherapy, because many of our patients actually come with more than 4 metastatic lesions, multiple metastatic lesions. I want to know the experience with Marcel Root. And sometimes when these patients come with less than 4 lesions and you actually want to give them SRS, you discover that they are back in a few months' time with another lesion. And then now they have to pay because from my experience, the patient has to pay again for treatment. So many a times the oncologist is left to make a decision. Should I just give whole brain radiotherapy? Because this patient may come back again and may not have the money for radiotherapy. So I just want your opinion on that. And secondly, how soon after an SRS will you want to offer radiation again if the patient needs to have one? Thank you.
So I'll take the second question first. I think it depends on if it's a recurrence in the same lesion or if it's a different area. If it's in the same region, I would be very reluctant to re-irradiate. That has a lot of implications. And if that's the only area where there's disease, I would refer to neurosurgeons. Let the neurosurgeons take a look and see if this is something that is resectable. If it's a different area, then you can treat it de novo on the assumption that there is minimal or no overlap between what you did treat and what you're getting ready to treat afresh. Then to your first question, as we all know, I mean, it's the elephant in the room, the financial implications of treatment. If a patient has more than 4 lesions, you're probably going to want to offer them whole brain radiation, and as much as you can, give them memantine or something to kind of minimize the neurocognitive deficits that they have. If everything is, if you ignore the financial situation, then you really want to just treat those lesions with stereotactic radiotherapy. If on the other hand, you've given them whole brain and then one lesion continues to grow or a completely different area shows new lesion, then the idea would be to offer radiosurgery or fractionated stereotactic therapy to that area. But unfortunately, you know, we have to sort of play within the rules, and the costs of all of this, both on the patient and on the provider, are things that you cannot ignore. So you just have to find a balance some way that you can do the best for the patient.
All right, and I think to the last question, to the question about funding for indigent patients. So first of all, I want to say, although people seem to think that because we're based in Victoria Island, we're not actually more expensive than the other centers around. That's the first thing. Secondly, having recently gotten our pioneer status from the government for being this comprehensive cancer center, we are allowed some leeway in terms of CSR, but the way we're planning to do it, and this trial that we're doing is working very well, is for the referral center to have a system where you vet these patients according to your criteria. Because as you know, otherwise what's going to happen is everybody's going to try and play, you know, they can't afford treatment. And if we do that, then none of us will be in business in a few years' time, whether we like it or not, because we have to run the machines, and that comes with salaries, but also in terms of maintenance costs for the machine. So very, very willing to have a conversation about increasing access to care, but it has to be done in a way where, and this model is done in other places. I mean, it's done in India, it's done in South Africa, and so on. But you have to have a team that looks at the patients and their socioeconomic status and ensure that they are really need to have that level of care. I hope that's been very useful. We've really enjoyed being here. Thank you very much for having us.
Thank you very much to the Master Root team. We are really glad to have you here today. And over to you, Dr. Tessie.
Thank you so much, Dr. Wanchuku, for moderating this session. And we thank all the participants and for listening and contributing robustly to this session. We're starting the next session, and I want to call on Dr. Shagaya and Dr. B. Olutunde as the moderators for the next session. Dr. Shagaya.
Good afternoon, everyone. We've had quite an enjoyable morning. I've learned a few things, and I'm looking forward to learning a lot more. So without much ado, I'd like to introduce the next presentation. This is going to be a virtual presentation, but this is going to be, the next presentation is a virtual one. I'm introducing Dr. Omolola Salako. She's a consultant clinical and radiation oncologist with the University of Lagos, and also the CEO of Sebekli Cancer Care and Support Center. She's going to be presenting healthcare innovations. Dr. Salako, can you hear me? Is she there?
Loud and clear. Can you hear me?
Yes, I can hear you. So,
okay,
Dr. Salako, you have the floor. We're running behind time, so please let's be sensitive on your time.
Yes, I'm aware. I believe we are behind by 30 minutes, and I think the timekeeper should be more accurate so that other speakers don't suffer for time misused previously. So it's really a pleasure to be with you all. My name is Dr. Omolola Salako. I would have loved to be in Abuja, but due to a personal emergency, I'm here in Lagos, but I'm following very, very closely what's happening. And today I'll talk to you about healthcare innovation, in particular to cancer care. And it's a topic we all know about. We are all innovating, whether we acknowledge it or not, whether we know it or not. Innovation is not about building a new product, it's about improving the system, especially in Nigeria here, where we have a lot of issues, a lot of challenges. The first assignment I would want us to actually take home is to think around how can we improve patient care. And there are many ways we can do this. Today, I'm speaking as the CEO of Oncopadi, which is a digital health innovation company that empowers confident cancer care decisions made by patients, clinicians, and leading healthcare companies. And over the past 5 years, we've developed several interesting products. Some have failed and some are quite successful. The first was the mobile and web app, and you can find the Oncopadi mobile app on Google and Play Store. We've gone on to develop a tool where if you insert your age, your gender, it will come up with important information on which screening test you should do and where the nearby cancer screening center is. And this is being powered by machine learning. And then we've developed the Oncopadi ARC. ARC stands for Accelerating Access to Remote Cancer Care. Previous speakers have.
Please, could you put, you're not sharing your slides. Can you put it on slide share so we can follow?
I'm sharing my
Just put it on slide share so we can flip through as you go. We have just the first slide. That's what we can see.
Oh my, I'm on the third slide. Okay, let me stop sharing. Stop sharing. And I'll share again. Can you see the second slide?
Still first slide. Yes, now. Okay, okay.
Okay, fantastic. All right.
Okay, now we're.
So at Oncopadi, I'd explained the mobile and web app, the OncoScreen tool, and the virtual tumor board, which is the Oncopadi app. Now we know that there's some cancer hospitals that don't have certain cancer specialists because we have a shortage of cancer specialists that cuts across oncologists, surgeons, and so on and so forth. And so we've developed this virtual tumor board for hospitals where they can submit their cases, discuss their cases, and you can be sure that the complete cancer care team will be made available. Our idea of innovation at Oncopadi is around taking cancer care to patients, to their homes, to the states that don't have oncologists or don't have certain cancer specialists. And there's a popular quote by Steve Jobs that reads, "Innovation is the ability to see change as an opportunity, not a threat." So in your hospital or in your lab, wherever you are caring for cancer patients, what is the change that you see? And what can you do about it? There are certain questions you have to respond to begin to innovate for cancer care. I shared this map of Nigeria last year, ACON 2021, and it shows the distribution of oncologists as at 2021. The areas in gray just tells you that there are simply no oncologists there. But if you come down here, you'll see that Lagos State has about 21 clinical oncologists, followed by Oyo State, 11 oncologists, and Abuja, about 10 oncologists. Now, how do we innovate cancer care around these places? How do we talk about multidisciplinary tumor boards in 18 states that don't have oncologists? How can we ensure that we have a complete cancer care team? As difficult as the situation is, it's also relatively simple. And I would like to challenge the status quo, that why is it that one oncologist sits in one hospital and sees only patients in that hospital? Can we begin to think around having one oncologist serve 4 states in Nigeria, and this oncologist should be incentivized? So Dr. Salako, for example, is based in Lagos, but nothing stops me from consulting or giving 4 hours of my time a week, and I'm paid per hour. And so this is a question for the private, for the public sector, but we have to rethink how we incentivize cancer specialists. Should we have one oncologist in one hospital, or should we think beyond one hospital or one state? And there are many frameworks when we are design thinking, our ideas, our solutions, and I would not bore you with that. But I would like to talk about the patient-reported outcome study app, which is an app that received a grant from Conquer Cancer Foundation and ASCO just about 2 years ago. And we're conducting a research in the College of Medicine, University of Lagos, where I teach and do my research. And our hypothesis was, if we empower cancer patients with a tool, a digital tool, right from their home, would it improve their quality of life when it comes to side effects? We had a qualitative study with the healthcare professionals and also with cancer patients. And we then, took all of the learnings from this focus group discussion, the qualitative study, to develop this study app. And on the app, patients sign up. We inform them about the study. They consent to the study. They are onboarded on the study, and immediately from anywhere they can actually report their side effects. They can log in the type of treatment they are receiving, and they can update all of their disease characteristics with the support of the study personnel or the study navigator. And there's also a patient education aspect to the app. Now, it's a mixed method study where we had the qualitative study and quantitative study, and we have completed the pilot study where we recruited 133 study participants on radical radiotherapy, and some of them had chemoradiation. 50 of our participants were breast cancer patients, 32 were head and neck, and about 50 were pelvic cancer cases, ranging from rectal cancer to prostate cancer. And in terms of utilization of the app, we realized that more than 70%, about 75% of our patients were reporting their side effects on a daily basis. And to us, this is what we call personalized cancer care. It's not just about genomics, it's also about taking care to meet the patient's personal needs. Cancer patients are stooling 5 times a day at home, and sometimes they don't know what to do, as simple as ORS solution, and then they don't know how to report their side effects. But at the end of the study, of the pilot study, we have an average of 200 side effects being reported daily across the 133 participants. And at the end of the pilot study, we have more than 5,000 side effect entries, which is real world data that is helping us understand the side effect profile of cancer patients receiving radical radiotherapy. You can imagine what we are now going to do with the data. We want to develop a clinical algorithm that helps us identify the patients who are at high risk of developing side effects, the ones we can intervene very quickly. And this is something that is getting us excited because we're partnering with the robotics unit at the University of Lagos to develop the first prescriptive app for cancer patients in Nigeria. And I must acknowledge the efforts of my colleagues. I'm speaking on their behalf on this study, Dr. Adegboyega, Dr. Joseph, Dr. Habib, and the many other professionals who have been ensuring that we meet the goals of our study. Now, when cancer patients come on the app, they can report their side effects immediately, and a healthcare professional is monitoring the side effects and can respond with relevant patient. Sorry? Okay, can respond with relevant patient. All right. Can respond with relevant patient education materials. There's a live chat system in which patients get self-care tips. And most importantly, for the patients who have moderate to severe side effects, we give them an alert to visit the clinic, see their doctor on that day, and also inform their clinical oncologist that this patient is probably going to drop out of treatment because of the severity of their side effects. If you look at the picture on the right, you'll see this is, I believe, a female pelvic cancer patient who in our medical language is having proctitis, for example, or tenesmus. But at the beginning of the study, we created a very simple patient language format in which tenesmus means changes in the anus. Frequency or urgency or dysuria means difficulty in urinating. So it's really important to get the patient's feedback whenever you are innovating. And right in the middle of the study, we did ask some of the patients what they like about the app and what they don't like about the app. And now I'm sharing what they like about the app. Some other time I'll tell you what they don't like about the app. And I think I'll just focus on the second feedback, which is the side effects are real. It opens you to the treatment you are about to go into and helps your daily routine and follows you up. And I think this is critical for every cancer center, where we have to develop mechanisms in which all cancer patients understand the side effects they are going to experience so that we reduce treatment dropout. And then this is our virtual tumor board at Olabisi Onabanjo University Teaching Hospital. Aside the virtual tumor board, which is a software, we also run virtual cancer clinics where cancer patients present to the hub physically and an oncologist presents virtually. I'll share a video with you, which is a collaboration between several partners, several oncologists, developing a season of 14 episodes on cancer patient education, which is also very useful to healthcare professionals. We're grateful to all of our partners and our sister cancer clinic, Pearl Oncology, which has just been set up in the last 2 years. But very quickly, we have launched in established hospitals like the Navy Hospital in Ojo, Arjolat Hospital in Bagada. We're not just delivering cancer care in our Lekki office, we are actually ensuring that more cancer communities, rural, urban, have access to cancer care. On that note, I'll say thank you. And please, if the media team can play the short video. I believe I'm on time, 10 minutes out of 20.
Definitely. Thank you so much, Dr. Salako, for being fantastic with time. She's still there? Okay. Dr. Salako, thank you so much for keeping with time. That was really nice of you and really sensitive. Now, we've been talking all morning and there's something that we've been mentioning which is really new to the cancer space in Nigeria.
Increases.
Which is basically the PET-CT. Everyone who's come up here at some point has mentioned something about the PET-CT. It's my singular pleasure to introduce Dr. Adeoluwa Adeniji, who is a consultant clinical and radiation oncologist, and also the Chief Medical Director of Mikio Cancer Center in Lagos. If you look at the brochure, it's actually, we've shuffled it a bit, but that was because we wanted it to go in a sequence where it would start with him. Sorry about that. Because Dr. Salacosta actually has, she finished ahead of time and she has a video that she wants to be played. It was meant to be played earlier, and I assumed that since she was online, we won't have to watch the video. So, Dr. Adeniji, you have another 8 minutes, and then you'll be up. So let's watch Dr. Salako's video, and then.
What causes cancer? What increases a person's chance of developing cancer? That's a very complex question. But the good news is that science and research has identified certain things that can increase a person's chance of developing cancer. So leading causes of cancer are heavy consumption of alcohol, smoking, and smoking in all its forms, from snuff to the cigar, to the pipe, to the shisha. Anything that contains tobacco is a risk factor for developing cancer. It doesn't matter how it is inhaled or ingested. And this is because tobacco contains several components and chemicals that are known to cause cancer. Another leading risk factor for developing cancer is the type of food you eat. Diets low in vegetable fiber, diets high in fat can increase your risk of developing cancer. Certain viruses and infectious agents can increase your risk of developing cancer. HIV, known as human immunodeficiency virus, hepatitis B virus, and human papilloma virus are viruses that are commonly associated with certain types of cancers. Like HIV, for example, causes Kaposi sarcoma, a skin cancer that is common in the HIV population. Human papilloma virus is 99% present in cervical cancers. Human papilloma virus is a virus that is transmitted during sexual intercourse, and it persists on a woman's cervix for 10 to 20 years and can cause cervical cancer. Hepatitis B virus can be transmitted through sexual intercourse, blood transfusion, exchange of needles, mother to child, and it is known to cause liver cancer.
On your journey to fighting cancer are a team of healthcare professionals whose job is to provide optimal outcomes for you. Although every individual is treated based on presentation, in doing so, they follow a set of guidelines. These guidelines are evidence-based management tips that help inform the decisions on what combination of treatment options will be best and suitable for you on your presentation. In breast cancer, for instance, early presentation is very important to achieving cure. The other factors like the stage at presentation, the grade of the disease, the subtypes of the tumor, the patient's age, comorbidities like hypertension, diabetes, the menopausal status, whether premenopausal or postmenopausal, presence of inherited breast cancer gene like BRCA1 and BRCA2 will determine the prognosis, and the best treatment plan will be based on this. Now let's walk you through the journey of cancer treatments. The first modality of treatment is surgery. Surgery is the removal of cancer cells together with a small margin of healthy tissues around it. This is aimed at removing the visible tumor, the nearby axillary lymph nodes, usually under the armpits. This will be sent to the lab to know the subtype of the breast cancer, the grade, and to determine the prognosis, also the stage. In summary, surgical goal is to remove the visible cancer cells in the breast and also to evaluate the lymph nodes that be harvested. Second modality of cancer treatment is chemotherapy. Chemotherapy agents are drugs used to treat cancer cells. They target rapidly dividing cancer cells to kill them and stop further growth. How is it used? Chemotherapy can be given as a neoadjuvant therapy and can also be adjuvant. Neoadjuvant is given before surgery or any other form of treatment, and adjuvant is given after. Another major modality of cancer treatment is radiotherapy.
Radiotherapy is a type of cancer treatment that uses high-energy X-rays to kill cancer cells or to slow down their growth. It does this by damaging their DNA. Radiotherapy is important because many people who are living with cancer will require radiation at some point during their cancer treatment journey, either for radical treatment or for palliation of symptoms. There are two main types of radiotherapy. There's what we call external beam radiotherapy, and then there's internal radiotherapy, which is what we call brachytherapy. Under external beam radiotherapy, there's proton treatment, there's photon, which is the common thing that people call external beam radiotherapy, and there's electron therapy. External beam radiotherapy is called external because the radiation, the ionizing radiation, comes from a machine that is outside the body, that is large, sometimes can be a little bit frightening, but once you get comfortable, you realize that it's just a machine that looks like a CT scanner, really. It directs the ionizing radiation from outside the body into the body to treat the tumor. And it works by damaging the DNA of the cell that it hits. And by doing that, it prevents the cell from replicating and from growing. Brachytherapy, on the other hand, is what we call internal radiation. And what happens is that we bring the source of radiation very close to the tumor, usually inside the body, sometimes outside, for example, on the skin. But most of the time it is internal. So for example, with gynecological cancers like cancer of the cervix, the endometrium, with breast cancer, with prostate cancer, we bring the source of the radiation into the body right next to the organ or even inside the organ we're trying to treat, and it delivers its radiation right there. The premise of brachytherapy is that we're really trying to protect other organs that are nearby. So brachytherapy, the source delivers all of its radiation in a very, very short distance. So we're able to get a very high concentrated dose into the organ we're trying to treat without affecting other organs that are in the body. External beam radiotherapy can be used to treat almost every type of cancer. And at some point in the cancer treatment journey, most people or many people will require external beam radiation for something or the other. For example, with breast cancer, after surgery, give radiation to the chest wall or sometimes to the whole breast, if it was a partial surgery that was done to prevent a recurrence, because data has shown that radiation will prevent recurrence in these cases. And most time, children, adults, men, women, radiation, external beam radiation at some point is often needed in the journey of treatment.
Thank you very much, Dr. Salako. The basics of cancer care cannot be overemphasized. Thank you so much. In going forward, I would like to go into the next session, which is being sponsored by Micure Cancer Center. And I'd like to introduce Dr. Adeoluwa Adeniji. I think now you're ready. He's a consultant consultant clinical and radiation oncologist and the chief medical director of Micure Cancer Center. Today, he's going to be presenting the PET-CT Changing Oncology Experience in Nigeria and West Africa. Thank you. You're welcome. We are definitely redefining cancer care. Going to introduce all of them. Sometimes you have all the up there. You get it? Oh, okay. Yes. So, okay, so, all right. So let me just have the whole Micure team come up and then I'll introduce them one at a time. You already have met Dr. Adeniji. The next person is Dr. Adekunle. Should I try? Okay, make one. That's a mouthful. He's a public health and family medicine specialist at Micure Cancer Center. And then I have Mr. Forhad Hussein, who's the manager of the cyclotron and the PET-CT Micure Cancer Center. So this is the Micure team we have on the floor. Let me have Dr. Adeniji come and start.
Thank you very much for that. I want to say a special evening to everyone. I would like to stand on the already existing protocol with due respect for the BOT chairman, professors, and distinguished participants. I want to appreciate this platform to be able to present what we do at Micure Cancer Center. We are offering a lot, and I love the theme of this year ACON conference, Redefining Cancer Care in Nigeria. And that's exactly what we stand for at Micure Cancer Center. So thank you for this. So a quick one. Can we start from the beginning? The first slide, please. with full screen, please. Okay, thank you very much. So I'm Dr. Adeolu Adeniji, the present Chief Medical Director of Mikio Cancer Center. So okay, so I'll be talking about PET-CT changing oncology experience in Nigeria and West Africa. We are having a lot of feedback, about what we do at Mikio Cancer Center. And one of them is PET-CT. For a long time, West Africa didn't have anything like PET-CT. We did our best and our trainers did their best also. Many of our patients had to travel out of Nigeria, spending a lot of money, traveling to South Africa, Egypt, and then later on Kenya. Then before then, it used to be United Kingdom, US, Canada, and they spent a lot of money. And so that's actually limited what we could do because we all know the importance of PET-CT scan because we are professionals. So we waited for a long time, we didn't have that. But at this point, it's not responding. Maybe you may have to change the slides for me then. Okay, so we waited for a long time. Next one quickly, so that we can work with the time we have. Now it is here. So we don't need to go far away anymore. We have the first PET-CT with cyclotron because there's a difference between having PET-CT scanner without cyclotron. You can get FDG18 and then get PET-CT scanner and find a way to, to do that to attend to patient. But this time around, we have cyclotron available and it's fully functional at Mikio Cancer Center for the first time in the history of West Africa. And that is a big win for Nigeria, big win for West Africa, and big win for the entire world of oncology. So I am so glad to stand on the platform of Mikio at ACON 2022 conference to announce that our patients don't need to travel anymore. They don't need to spend a lot of money, and we can get these things done right here in the city of Lagos, Nigeria. Thank you. Yeah. So what is the overview of PET-CT? I know the nuclear medicine physician in the house understand this better, but we know that PET-CT is very useful for oncology practice in diagnosis, staging, monitoring, treatment, and follow-up care. It's also useful in some cases of infection and cardiology. For example, they say 2% of application of PET-CT can be useful in infection, while 1% in cardiology. But 97% obviously has its application in oncology. And then it's good for optimum treatment decision and possible radiotherapy contouring. That's the next thing we are talking about now. Okay, let's move on, please. Okay, so at Mikio Cancer Center, we have this. Just keep moving on. I have some effects there, so transition and also animations. So we have the latest, no, please, let's go back. Just walk with me, please. So we have the latest Discovery PET-CT scanner from GE. It was manufactured in 2021. Anywhere in the world of Africa or even in the entire world, the latest scanner is with Mikio Cancer Center. And of course, we have cyclotron and skilled professionals. So at Mikio, we have cancer care with PET-CT. We don't just treat. We also want to see what is the accurate stage from the beginning. And then a purpose-built 6th-floor oncology center, multidisciplinary team, both within and outside Nigeria. And we have full patient support and excellent services. And a lot of our patients can attest to that next. And that's what we call comprehensive cancer center. And what is the cost implication? Very much affordable. We know that the cost of PET-CT may not be readily available for people to pick from or to spend. But as much as possible, we have a special program at Mikio Cancer Center, which has to do with affordability. And I'm sure everyone in this auditorium would like to know about that. So Dr. Kunle is going to talk about that when we get there. The next, please. Next. So what do we do with detailed, with appointment? We book ahead. Clients don't walk into Mikio Cancer Center to say, oh, we want to do PET-CT. Like we've had very, very few people like that. No, we have to book ahead. And then the client has to be referred by physician, and also patient has to be prepared ahead of time with the necessary information, and then other appropriate guidance will come in, and full support is available for all the services we do and all the inquiries that may be needed. So recently we launched something fantastic. We call it the PET CT-based medical oncology services with treatment in a spacious and lovely environment, which you're going to see. Can we see that picture, please? For example, you're looking at our chemotherapy suite, very spacious, beautiful, with a screen to each of the clients, each of the patients. So they don't share screen, the sound system is there, and then the medical team attends to them as needed. Next quickly, please. So testimonials, a lot of patients love the services, the environment, and all the innovations that we apply at all levels at McCure Cancer Center. Oncologists are very happy to make good clinical decisions without any doubt. We've had a lot of feedback from oncologists that said, oh, because of PET-CT, I knew this patient would not require adjuvant treatment. And then I said, oh, there was something in the lungs. I wasn't sure. I was going to give chemotherapy. But after the PET-CT scan, I knew it was actually a benign. And some of them found out that what was in the lungs was not even malignant at all. It was probably fungal infection or bacterial infection. And you can imagine if that patient had taken chemotherapy or any other treatment. So coming soon, we have radiation facilities that will be coming very soon. Brachytherapy is going to arrive at McCure Cancer Center. Then Linacs also, True Beam and Vital Beam. Then laparoscopic and minimally invasive operating theater will be up and running very soon. And as we speak, we are already, rounding off the construction of fully equipped admission wards with 65 beds. Next, please. So I want us to watch this video. It's less than a minute. And let's see what we have at McCure Cancer Center. No, please, can you go back and play the video, please? Yeah, search for the play button, please. It's there. Move your cursor. Yeah. Please, can we quickly watch the video so we can save some time? Okay. There's a play button below. You just need to click on it. Yes. Thank you very much for that. Can we go to the next slide, please? Next slide, please. So you can visit us physically to have a tour of the Oncology Center, and then you can also visit us, visit our website, mecurebeatmycancer.com. Next slide, please. So special appreciation to our team of nuclear medicine physicians in Nigeria for always supporting us, the ACON members. I'm glad to be part of this amazing group of professionals. And of course, our capable LOC for 2022 ACON conference. Thank you. And lastly, the sponsors of 2022 ACON conference. So on this note, I want to say a big thank you. So I would like to call on Dr. Adekunle Megbuwawan to be able to take us through the slides that talk about affordability, MICURE pathway. Can we please welcome him? Thank you.
Good afternoon, everyone. Let me stand on the existing protocol. My name is Dr. Kunle Megbuwawan. The moderator couldn't pronounce my name. It's Megbuwawan. When I become the president of Nigeria, you will learn it by force. I'll start by saying that medicine is science. Healing is an art, but healthcare is business. Medicine is science. Healing is an art, but healthcare is business. So at MICURE Healthcare Limited, we are not just looking at the science of medicine. We are also very key at the healing aspect, bringing to form the act of healing. And then we look at it from a business point of view. It must be profitable. So what is the MICURE pathway to affordable cancer care in Nigeria? Just help me. It's not responding. Okay. Now, there are basic things that we ask for, or basic questions that normally come up. We have the demand side of healthcare, and we have the finance, the supply side of healthcare. Seated here are majorly people in the supply chain, people that are the professionals, the oncologists, the physicians, the surgeons that provide the service for the patient. But at the other spectrum is the demand, the patients that need the healthcare itself. But we look at the disease burden of our nation. One of the things we keep saying or we keep hearing is that the prevalence of cancer in Nigeria is increasing, the incidence is increasing, the mortality is increasing. In fact, cancer is now a global emergency. Worse still is that Nigeria is going through an epidemic transition. We are not just plagued with the infectious disease, which we've not been able to tackle. Chronic disease like cancer is also increasing in its own time. Now we say, why are cancer patients not getting the help that they need? Despite the fact that cancer centers are being built, we have quite a number that is rising up now. MICURE just built a 6-story bunker that can treat so many cancer patients. And so also in various centers, we have cancer treatment centers rising up. But we keep hearing that the health-seeking behavior of our people is bad or is low. The healthcare seeking behavior is also poor. Health service utilization, these are synonyms. Health-seeking behavior, healthcare seeking behavior. How do they go to hospital? Health service utilization, health access. So there's a barrier between the supply side and the demand. And what is the major barrier? It is money. It is cost. Healthcare is expensive. We cannot overestimate that. We cannot talk much about that. Setting up a cancer center, MICURE Cancer Center, a $40 million project is huge financing. So we came up with a theory of change. If we ameliorate the critical barrier to access to health service need of the people, we shall be able to increase their health service utilization, because cost of care is a major barrier and reason why people do not seek and access the type of health care that they need. If we can ameliorate. So cost is the number one factor, the social determinant of health. The number one thing is the cost therein. So most of us as clinicians, we are used to the clinical diagnosis of disease, which is, oh, you take the history, you do the examination, and you create a treatment plan, or you do your laboratory and radiological investigation and you create a treatment plan. However, in public health is a different ballgame. We're not just looking at clinical diagnosis, we're also talking about behavioral diagnosis. Not just behavioral diagnosis, what is the behavioral intervention? What is the behavior that this patient is behaving that is leading to this disease? The previous presenter spoke about different things that causes cancers, different behaviors, smoking shisha. So these are the behaviors that is leading to cancer. So we are saying now, not just the behavioral diagnosis, but the behavioral intervention. What behavior do we want the cancer patient to be behaving? Now, we now went further to say there's educational diagnosis. In public health, there are a lot of theories that have been propounded that can change things. And we're not just looking at this theory, what are the strategies? Strategies you can put in place that can now bring about this change. So that exactly is what we did at MICURE. We look at various theories, health belief model. What is the belief system of the people? A lot of people believe, or what they believe and perceive, they believe that they can't get cancer. They believe that getting cancer, getting the disease has severe consequences. So if the belief is that they can get the disease, or getting the disease has severe consequence, or taking action will reduce the severity, then they will visit the hospital. Then that the treatment benefit is greater than the cost of care, then they will visit the hospital. But if they believe that, oh, the cost of a treatment plan for cancer to do a radiotherapy session is close to $1 million, and chemo, and you are spending about 2 million. How many of Nigerians can afford 2 million on care? So if they believe that the treatment benefit is greater than the cost, then we look at what is their ability to pay. What is the willingness of our people to pay? People don't have that ability, even though they are willing, but they can't afford. So we looked at all these theories and we brought about a conceptual framework that when we bring the demand and the supply together and we create a third factor, we call them the angel sponsors. The angel sponsors. So we link the demand, which is the patient that has the cancer, the NGOs that are trying to raise funds and care for the cancer patient, and the supply, which is the professionals and the machine that is going to treat them. And we look at the cost and we say, let's bring the angel sponsors to them. So we ask, who are these angel sponsors? Based on theories, we know that Nigerians are communal in nature. We are our brother's keeper. When cancer happens to a family member, we don't leave that person alone. Everybody wants to care for him. Everybody wants to support him. So we say, okay, why not bring the friends, the families, the classmates of this patient that has cancer, even the doctor that is managing this patient? Why not bring everybody together to support this patient so that he can fight and beat cancer? So we come up with the MICURE 2080 Beat My Cancer program. It's designed around the communal nature of Africans and is a balance of funds will be raised through angel sponsor. What we said is that, look, patients should just look for just 20%. If the cost of PET-CT plus chemo is going to be about 2 million, just look for 20% of that cost. In fact, we brought it so lower, we said just look for 200,000. With 200,000 naira, if you open your bronchial, you see it there. With 200,000 naira, you can walk into MICURE and get a PET-CT done. Not just a PET-CT, you can come into that center and get a full cancer treatment done. Because why? We are leveraging on the angel sponsors. Who are these angels? You are the angels. We are the angels. So we looked at these angels. Why will an angel support you? Why will an angel support the cancer patient? Still going back to public health theories, we know that if we'll ensure that the person that is providing certain amount of money for the treatment of a cancer patient, if he knows that there is something in it for him, he will be committed to give care to that person. Somebody spoke about cost sharing. This is part of it. That for everybody, if you can just donate just 15,000 naira, to support a cancer patient in his treatment. Just 15,000 naira every month for 6 months. That is 90,000 naira. You can use that same amount, that same fund, to care for yourself or your family at Micure Healthcare Limited. That means that most of us, we advocate for annual health screening. You want to use 90,000, 100,000, 150,000 to go and do an annual health screening. But there's a cancer patient that is suffering, who cannot afford the cost of care. And we are saying, use that 15,000 every month in 6 months, which becomes 90,000. That same amount of money is still yours. It's still available to you to do your annual health screening. So it spoke to organizations that want to do health screening, health check, treatment for our staff. Instead of just spending that money, use it to support the cancer patient. So the cancer patient actually has no obligation to the person that is sponsoring. In actual fact, the cancer patient is helping you. So we are not just looking at the tertiary intervention of cancer treatment, we are also addressing the primary intervention, which is screening, which is early detection. Now, this is the only way the disease burden, the prevalence of cancer in Nigeria can be addressed. If we begin to support those people who are unfortunate enough to have been diagnosed with cancer, that by donating just 15,000 every month, we also use that same amount to get ourselves screened. You may be the donor, you may not be the one to use the amount. You may say, oh, this other person will be the one that will benefit. So morally and socially, the cancer patient does not have any obligation to you. Rather, it's actually helping you to get yourself screened, preventing cancer. At the same time, we are curing those that have cancer. So this is not for indigent patients. No. It doesn't say the cost of cancer is off. It only says we are pulling funds from the society, pulling funds from people that have it to support every cancer patient. So at Micure, we say that cancer is no longer a death sentence. Nobody that has cancer should be denied access to the best cancer care. And cost of cancer is no longer a barrier, because with Angel sponsor, with the third force, we can all ensure that cancer is addressed. So together we can fight cancer and we can also beat cancer. Thank you very much. So I'll invite my next colleague, Mr. Fuad Hussain.
Thank you, Dr. Adukunle. Good afternoon, everyone. This is Farhad Hussain. My specialty is actually in PET-based nuclear chemistry and its molecular application techniques. So today I would like to show the reducer how it's become very much reliable standard in oncology diagnostics, and how medical cyclotron and PET-CT and piezotherapeutics work in Micure. Yeah, I'm doing this. Okay, skip. Okay, so first of all, we have to know that what is radiotracer and what is its special feature. So radioactive compound is used for the diagnosis and therapeutic treatments. So in these things, first thing is radionuclide, and second thing is ligand that we can call organic carrier, biomolecules, or bifunctional chelating agents. So this radioactive, the nature of radioactivity is the action of radiotracer by radiation, not by the chemical compositions. Then it should be a trace amount and it should half-life should be shorter, which is less provide us less radiation hazard, but more medical benefits. And it should be a small quantity, but large variety. And a special limitation means is should be used in the licensed hospitals and authorized personnel equipments. And it should be in in-house preparation also, like we are doing in McCure, medical cyclotron based radio research preparations. And then radio should be safe and non-toxic for the human administration. It can be sterile, poison free, and efficacious for the specific indications. So radionuclide production in all worldwide is happening by two way actually. One is the reactor, another one is linear accelerator, or what we can call cyclotron. Then it's become generator and radionuclides as well. Okay, so let me give some examples, just short example for the radionuclide from the reactor. It's neutron rate isotope actually, and it's basically used for therapeutic purposes, and it have very low specific activity. For example, you can keep radioiodine, molybdenum, and rhenium 186 as well. Okay, and radionuclide from the cyclotron. From the cyclotron, which one we are producing is neutron deficient isotope, and it's called beta plus decays. So this is basically most of the radionuclide from the cyclotron is for the diagnosis purposes. Some are also for therapeutics. So its specialty is high specific activities. For example, we can say carbon 11, O15, and N13, then F18. Basically, most widely used radiotracer from the cyclotron is F18. So let me just short history of the cyclotron. In 1932, Ernest Lawrence started that University of California first cyclotron, which was not medical. It was named by first times synchrotron. Anyway, so then in 1941, first medical cyclotron was started, and then 1980, FDC radiotracer, and then PET-CT started. So short-lived radionuclide, we can say this one is beta plus decay, which is very important for the diagnosis protocols. And those beta plus decays can happen by carbon 11 and 13 ammonia, O15 and F18 basically. So this is, let me introduce, I think my CMD already said that about medical cyclotron. Let me focus some special feature of this medical cyclotron in McCure Cancer Center. It's actually shell-filtered negative ion cyclotron, which assure us less radiation hazards. And total acceleration capacity is 9.6 MeV. It can produce basically F18 and carbon 11 and 13 and F15 base, all the radio tracers. So here we can see the carbon 11, sorry. Okay. Carbon 11 and its half-life is only 20 minutes. And 13 half-life is only 10 minutes. And O15 isotope, its half-life is only 2 minutes. And F18 half-life is 110 minutes, which is very ideal and used in PET radiotracer as a PET radiotracer for the most of the cancer imaging by PET-CT scan. This is the first and whole West Africa, I mean, first in Nigeria and whole West Africa. This is the medical cyclotron we have in McCure Cancer Center. Okay, basically cyclotron system is very sensitive one. Personally, I call this one the very beautiful lady with too much ego, because it's run 24/7 with all this system like extraction system, magnetic pole, RF, ion source, and vacuum system. To keep up this vacuum system is very sensitive, and keep up his RF system, we have to run this cyclotron 24/7 on up mode with -6 vacuum, and then proper temperature and humidities, which cost actually for the running the centers. Okay. Now, I will discuss about the tracer production basics. Tracer production actually happen by three ways. First of it is radionuclide production, which is happened by the accelerator or cyclotron. It generates high energy particle. Those high energy particle hits in the target precursor molecule. In the target precursor molecule, we have O18 base and rich O18 water, which is this enriched O18 isotope is bombarded with that photon, which is accelerating the cyclotron and gain energy up to that 19.6, 16.5 MeV. Then it reaches to the oxygen, oxygen O18 water and becomes fluorine 18. Then it goes to the chemistry system for the adding the radio ligand, we can say molecular agent or biomolecules, whatever. Like for example, for FDG, we are adding the deoxyglucose, which is come from the mannose. Okay, so in the particle acceleration, what energy is actually happening here? It gives us threshold level energy to get this nuclear reaction, which is 16.5 MeV, and you can see here the pictures. After production of that radiotracer, for example, APD I am showing basically, then it added with the deoxyglucose, which is the precursor molecule actually for the FDG production. And then after nucleophilic substitution reaction and followed by the alkaline hydrolysis, it become FDG. This is the hot cell where actually our first lab from GE Healthcare is there. It's very specialized one for the production of multiple radiotracers like FDC, PSMA for prostate cancers, then N13 ammonias, then FLT, FMISO, FDOPA for the neurological. These are the quality control lab pictures. Okay, so FDG is a novel tracer for oncology actually. Why it is very novel and very ideal for the cancer detections? Because its half-life is very reasonable half-life. It's 110 minutes and it's excrete faster from the body. So less radiation hazard and more medical benefits. And one of the most important thing is when deoxyglucose, see in the carbon number 2 is a fluorine is tagged in the carbon number 2 of the deoxyglucose. When it is tagged and it goes through the glucose transport protein, I mean the transport chain, transporter, glucose transporter, then it goes to the inside the cell, and then as per the glycolytic channel, it goes to the hexokinase enzyme and is phosphorylated. After phosphorylation, it can't go to the further process for glycolysis. So by this time, we are annihilate the F18 and detected by the PET CT machine, and it becomes the create the PET CT images. So we can say this is the PET CT machines. We can say actually most of the time, FDG is the most important and ideal radiotracer for the cancer detections. This is our GE Discovery IQ Gen 2 PET CT scanner in our Mikio Cancer Center. So PET CT scan, what is its specialty actually? PET CT scan is actually very safe and effective non-invasive diagnostic techniques, which provide us highly detailed image of the whole body. It details vast variety of the cancer, inflammation, and neurological disorders as well. In Mikio, we have GE Discovery IQ Gen 2 PET CT scanner, which specialty is actually it is motion-free and Q-clear reconstruct technology with light burst PET detector, which is provide us uncompromised image quality even for the detection of small lesion. So normally in the CT scan shows the sign of an issue after a disease begins to change the structure of an tissue or the organs. But in the PET CT scan is showing the molecular activities. So it helps the doctors to get the disease detected in the earlier stage. So if cancer is detected in the earlier, so it can save the lives after the treatments. This is very interesting cases for us. She is a physical fitness trainer, and she was done actually excision biopsy of the red blood lump, so and detected as a medullary carcinoma. But she was when she heard that we have PET CT scan in Nigeria, so she visited our site and done PET CT scan as per the her oncologist suggestion, and she was revealed that not only in the right breast, she has also left breast, both breast cancer with right axillary lymph node metastasis. And Mercury is having even PSMA for the prostate cancer detection. But it's actually used for the prostate cancer diagnosis, staging, and recurrence, and the restaging as well. It is advantage of the PSMA PET CT is very sensitive and accurate for the prostate detection. Even it can detect the very tiny and slow growing tumor with high accuracy in the prostate, and there is no any side effect or the known side effect of the PSMA drug. This is the patients who have done FDG and PSMA as well in our centers. You can see here in the PSMA FDG slide, it will show FDG slide is B and D. You can see here it will show the positive focal positive lesion in the prostate, and its submax is only 5.7. But when you see in the PSMA scan, it is showing multifocal conglomerated PSMA avidity defined lesion, and is ensuring us that okay, the spread is actually much and submax is around 31.50. So this is how PSMA is more accurate for the post PSMA scan is more accurate for the prostate cancer patients. And very soon we are starting the sodium fluoride bone scan. This is actually in comparison of the technetium maybe scan. It takes very less time. It takes around 1.5 hours, and even better scan quality. Let me show you the one reference of the images. Oh, sorry. You can see here, the left one is technetium 99 bone scan, and the right one is sodium fluoride bone scan, which is giving us only in the right left one in the technetium bone scan is showing only ribs lesion, but in the PET CT bone scan is showing in other area like the pelvic and the skull bone as well. So our future plan is to become start the FLT and FDOPA and FMI also. Okay. Can I get more last 3-4 minutes more? Then I can discuss the theranostics with very importance. Thank you. Thank you. Yeah, thank you. I will try to do this. So theranostic is the most global interest for the cancer diagnosis. Cancer diagnosis and treatments. So this is the history actually. Theranostic history is over 70 years actually. It started in 1951 in nuclear medicine. So this is the picture of example that one. It was actually happening the thyroid treatment actually. Sorry. Okay. So how we do radionuclide therapy actually? By using radionuclide and then internally by our with carrier or without carrier. So you can see the pictures here, how external radionuclide therapy and radionuclide therapy works. Type of radionuclide in the radionuclide therapy is the 3 types. First is alpha emitters, then is beta emitters and auger emitters. most of the times is alpha emitter works very well and Auger emitter is very well. But the thing is alpha emitter is very expensive and beta emitter is a little bit cheaper than alpha emitters. And Auger emitter is working very less in length. Let me show you the next slide. Yeah, you can see here how it is penetrated in the cell, alpha and beta and the Auger emitter. These are native nuclide used in therapy. I just highlight 4 or 5 here. Actually, there is so many. So why I highlight this one? We have planned for these things in future in Micure. So iodine 131, everyone knows about this is using for the grave disease. And lutetium is very interesting one. It was used for the, you can use for the prostate cancer treatments and as well as the neuroendocrine tumor treatments. Okay, and the alpha, one of the alpha emitter is they are very. Let me finish one more thing about lutetium. Lutetium is already FDA approved drugs. I mean, FDA approved nucleotide, which is used for the radionuclide therapy. And alpha emitter actinium is already ongoing process. It will be very soon, maybe FDA approved for the FDA approval. It is also very more effective than the lutetium for the advanced metastatic castration-resistant prostate cancer treatment. Let me show you the one more slide. This is the actinium therapies. Actually, this was happening in Bangladesh for the what I can say the research purpose. So luckily, I was the part of that. They are calling me, Porat, come and be part of us, so you can enjoy this. So this is very important, and this one is presented in Journal of Nuclear Medicines. One of my senior teachers, I can say, or my boss. So it was actually first patient was done. Sorry, patient was done PSMA CT scan, PET CT scan first. Then it was that time it was PSO was very high. Then patient was given 3 cycle of the actinium PSMA therapy. After that, did another PSMA scan, prostate scan. And then PSA it become 0.6 nanogram per ml. And then for the after 2 months of one additional consolidation therapy, patient become cured. So this is most very interesting even for me. I am just for the research purpose, it was part of me, but I am still now interested to work on it for the chance. Thank you, everyone. Thank you so much for giving the opportunity to me.
Good evening, everybody, and thank you to the Micure team. We've had 2 presentations thus far. Dr. Salako had a brilliant and talked about the brilliance and the innovation of the Oncopadi app as it solves the problem of access to medical care across Nigeria. And also we saw a video from the team, including Dr. Zadigboiga and Dr. Joseph. Many thanks for your presentation. And the Micure team just recently finished their presentation led by Dr. Adeniji. They are helping us redefine cancer care by providing the first PET CT scan in Nigeria, making a much needed diagnostic aid available to patients. And this is a big win for us in Nigeria. And also, they have several corporate social responsibilities that make this treatment even more accessible to patients, which we can all target. So we're going to take 1 or 2 questions very briefly. You'll state the question directly and you just give them 1 second. We'll just give them a few minutes to answer because we're really out of time. I see 2 hands up already, 3 hands up. We're not taking any more than that. 1, 2, 3. In the interest of time, please. Dr. Bello, who has can we have the microphone? Thank you. We'll take all the 3 questions. Please take note of the questions that are directed to you. Thank you.
So thank you very much to the Mecure team, led by the Chief Medical Director, Dr. Adeni. My question to you directly is that you have a cyclotron. So what is stopping you from treatment, theranostics? When can you start, especially PSMA lutetium treatments? Direct question.
Okay, please take note of that question. There was a second hand up here, over there, and then a lady at the other end of the room. Oh,
so much.
I'm sorry, Madam President, I didn't see your hand up, sorry. Go ahead, please.
Okay, thank you so much to the nuclear Mecure team for the great presentations. And I really want to commend you for actually having somebody else, aside from a clinical oncologist and somebody doing nuclear physics, nuclear medicine in your team. My question is actually directed to our community medicine colleague. I've always come at cancer care, optimizing cancer care in Nigeria from a health systems perspective. And I really want to thank you for your presentation. We really looked at some of the factors that you think would change the health-seeking behaviors of our patients in Nigeria. I mean, I understand it's a no-brainer really for us here in Nigeria to think that funding will be a major problem in really promoting early detection. But I just want to ask that perhaps you might want to consider other things in your theory of change, because we do see that I'm from University of Nigeria Teaching Hospital, which is one of the sites for the CHF. So patients get credited with 1 million naira in their wallet to access care. And we have patients, despite having that fund available, not wanting to take up care. So I think that apart from looking at financing as being one of the challenges, I know they are multifactorial, but when you're considering the theory of change in trying to promote early detection, I think that there are other issues that you might want to consider. Before I let go, I know you're a community physician. One of the things you might be thinking is that the indigent patients and their socioeconomic status, and we know that there's a close link with low health-seeking behavior in people with low socioeconomic status. But we see this even with those that are also higher up in the economic ladder. Thank you.
One question from the end of the room. Thank you, Madam President. Please keep noting the questions. Yes.
Thank you very much. My name is Dr. Ahmed. I'm a nuclear physician from National Hospital. Unfortunately, the two speakers have taken away two of my questions, but the third one, what is your plan for gallium-68? Do you have any in near future? Gallium-68.
Gallium-68?
Yes.
Okay.
And then the second one is not a comment, rather, sorry, it's not a question, rather a comment to our colleagues, the oncologists, just to say that we have nuclear medicine departments, at least 3 in the countries. Now that we have PET-CT available in the country, it is time for us to open up the discussion. When are we going to send patients for this PET-CT, and which patients would benefit from which type of therapy? Thank you very much.
Thank you very much. And then there's the last lady at the end of the room over there. Can I have your hand up, please? Let's quickly get that question, and then we will chop have very quick answers from your team. Thank you, sir.
Good afternoon, everyone. My name is Gloria Ojinwajogo. I am the president of Network of People Impacted by Cancer in Nigeria, and I'm a patient advocate. And I really want to appreciate Mecure for what you're doing. It's, in fact, it's a huge relief. It's a huge relief for we, the patients. But I actually want to clarify some things. Like you were talking about the angel sponsors, and I would want to know who is recruiting the sponsors. Is it the patient or is it Mecure? I'm saying that because for the patient who is not even in the right frame of mind to go and then seek for this, it's already a barrier. Then secondly, we have discovered that in Nigeria, many people, let me not just say more, many people still believe that cancer is a death sentence. So unless you have one big distended arm, people will always assume when you go to them to make contribution that you're going to die anyway. So I'm telling you what happens to us. We face it every time. So it's either they think that you're going to die anyway because the case is so bad. And then when the case is not obvious on you, it is assumed you want to scam them. So the patients doing that, it's already a very difficult, is already in a very difficult position. But if MICURE as a body can do that, meet corporate organizations and, present this to them, I think it will be more credible because it will be better, it will be easier, and I think the catch will be more. That's a suggestion. I don't know who does the recruitment anyway, so I would like to know that. Thank you.
Okay, thank you very much, Dr. Adeniji. Who is answering what? Let's just go ahead. Thank you.
Thank you very much. So I'll quickly answer the question from Dr. Bello. Just to go straight to the point, the whole idea is to establish the diagnostic path, which we are already on. For example, we're going to move, we started PSMA recently from FDG 18, and we're going to move to other part of the diagnosis. And also we know on our list that there is a place for the therapy also. That's the therapeutic part of having cyclotron, and which we're already looking into. So very soon we're going to come up with therapy, especially for prostate cancer. And when we get to that point, we will let you know fully. So I'll pass to Mr. Fuad Hussein to answer the other question. Thank you.
Okay. So thank you for your questions, actually. I heard you asked about the gallium issues, correct? See, normally gallium, if we buy one gallium generator, the M68 generator, then we can do both, like for the diagnostics of the prostate cancer as well as the treatments also. So gallium PSA, PSMA, we can do even for PET CT scan, and PSMA 617 we can use for the treatments. So your main intervention is why I'm looking for lutetium, not gallium. Huh?
When?
So
When?
can I
At
suggest
what
that
time?
you have a
Okay,
conversation
you are talking about the
after
timeline.
now?
Okay, thank you. Thank
Because we're really pressed for time. I'm terribly sorry. I'm sure you have an interesting agenda. Please, could you quickly answer your question?
Okay, thank you very much. I'd like to correct an impression. The MICURE 2080 Beat My Cancer project is not a CSR. It's actually meant for every cancer patient. Now, for cancer treatment, you're not just looking at the PET-CT, which is the PET-CT-based treatment plan that we've started. You're looking at the chemo, you're looking at radiotherapy, you're looking at surgery. At the end of the day, to treat cancer in one patient, you're talking about 4 to 5 million. Most people, even the average Nigerians, cannot afford. So it's not a CSR. It is for every cancer patient. You want to have a targeted therapy. It's more expensive. So we are looking at making sure that cost is no longer a barrier, and then the patient can focus on getting the treatment, while we also focus on making sure that the money to treat the patient is there. Now, back to your question, ma'am. Treatment of cancer is multifactorial. There are so many other barriers. In the social determinant of health, socioeconomy forms 40% of the determinants. The lifestyle and behavior of the people forms 30%. Access to health care forms 20%. And environment forms 10%. Now, we are not just doing this in isolation. We are working with so many other organizations. We work with NGOs. We work with every other person, every company that is available. But we focus on these social determinants, which is the social economy. And when we talk about social economy, it's inability to pay. Their willingness to pay is in terms of how much do they have. The average government worker that is unfortunate to come down with cancer, how much is the annual salary? How many of them can afford to part with 5 million for cancer treatment? So it is a major cause of the poverty, illness, poverty syndrome. So it is not a CSR, it's actually, we believe this is the solution that we can afford for ensuring that every cancer patient have access. The universal health coverage talks about the access to care that the patient needs. If the patient needs to be at the cancer center to have a radiotherapy done, that patient must have it. Then the last question, who is responsible for getting the angels?
Can we do that very briefly, please? Thank you. I'm so sorry. I'm under pressure myself.
Thank you. Who's responsible? The patient knows his family. The patient knows his colleagues. The patient knows his classmates. So we are saying, bring all your network together. The only barrier to the patient is his ability to speak. If you can talk to the next person beside you, he will support you. Because the person is not actually helping you. You are the one helping the person. It's unfortunate that the patient has cancer, maybe due to one reason or the other. He may not even be the cause of it. A child that came down with cancer, what's the cause of the cancer? What behavior has the child done in early age? So we are saying that, look, just talk to the next person. In actual fact, you are helping the population to start preventing cancer. Every woman that comes down with breast cancer, it is known that there's a familiar history that the family of that woman, every woman in that family should be screened regularly because they are also at risk of having breast cancer. So that woman can talk to all the women in our network. Please, unfortunate I have this, but help me. But in helping me, you're actually helping yourself to get yourself screened on regular basis. So when we are talking about primary prevention, early detection, this is the solution that we have. Because we also leverage on our infrastructure as a brand, as Mikio brand, we have one of the biggest diagnosis centers in Nigeria. So we are saying, come to our center, support the cancer patients to have the treatment done. Come to our center, get yourself screened.
Right. Thank you so much, sir. Thank you. I'm sure you can seek further clarification from the Mikio team if you're interested in learning more about the angel sponsors. Let's give a big round of applause for the Mikio team. Thank you for such excellent presentation. We've been educated, and I will rapidly move on. Before we do so, I would like to speak to everyone that is standing outside behind the podium. Madam President, am I going to have your permission to elect a class prefect that is going to be selecting the name of noisemakers? Because we're getting a lot of noise from the back of the auditorium. I'm hoping you can all hear me, that there is so much noise from the back of the auditorium, and we're hoping that we can bring this down a little bit. Thank you. Let's put our hands. You've been a fabulous audience. Thank you so much. Put your hands together for yourself and warm up a little as we move forward now very quickly. No, I have that. Should that keep me? So the next presentation is by the AstraZeneca group, and it's on the use of Zoladex in the management of premenopausal women with locally advanced hormone receptor positive breast cancer, a non-inferiority analysis comparing clinical efficacy of Zoladex of varying dosages, the prestige study. And to take us further, I'm going to be inviting Mr. Aki. I had your name written on a piece of paper and I didn't bring it up with me. So I apologize tremendously. You please introduce yourself. Clinical liaison for AstraZeneca. Please put your hands together for him. Thank you.
Good afternoon. Good afternoon, everybody. Good afternoon. all protocols observed. My name is Akitunde Akirobola, Clinical Science Liaison. I work with AstraZeneca. So I'd like to introduce to us the reason why we're here. We're here to touch on the use of buserelin in the management of premenopausal women in locally advanced hormone receptor positive breast cancer patients. We will be sharing the Prestige study, which is a non-inferiority analysis comparing the clinical efficacy of buserelin across our varying dosages. So please join me in welcoming our panel members. So first, I'd like to call on Professor Sunday Adewi. It's a round of applause for him as he comes forward. Also, I'll be calling on Dr. Isaiah Intekim. And also from AZ, we have two of our colleagues present here. First is our country manager, Maurice Nyako, and product manager, Eric Ojuki. So our slot is in 3 phases. We have the presentation, which will be driven by Professor Sunday Adewi, is the Professor Clinical and Radiation Oncology, Ahmadu Bello University, Zaria, also Chief Consultant at the Teaching Hospital. And then we have a panel discussion / question and answer session, which will be driven by Dr. Isaiah Intekim. Dr. Isaiah is the head of Department, Radiation and Clinical Oncology, University College Hospital, Ibadan. And then we have Maurice, who will be talking to us about the role of AZ within the oncology space. So without further ado, join me in welcoming Professor Sunday Adewi to take us on our presentation.
Thank you very much. Can you hear me clear and loud? Yeah, we'll be talking about, can I have my slides, please? I'm Sunday Adewi. I will be discussing the use of Soladex in the management of premenopausal hormone positive, locally advanced breast cancer. The study is to show the non-inferiority of use of 10.8 milligram of buserelin compared to the 3.6 milligram of buserelin. Second one. I have nothing to disclose, please. At the end of this discussion, I expect us to have a clear understanding for the indication and use of buserelin with respect to early breast cancer and locally advanced breast cancer that are hormone positive, and to see the use of the 10.8 gram buserelin as an alternative. I mean, that is a 3-monthly injection, as an alternative to the monthly 3.6 milligram injection, because the Prestige trial revealed a non-inferiority. So this is how I'm going to present briefly the introduction, the relevance of understanding tumor biology, and then the usage of buserelin and the Prestige study. Time's against us, so I'll move fast a bit. We all know that conventionally, I'm sure Dr. Paul Jibrin is here, that those days before we study immunohistochemistry, based on the fact that 2/3 of breast cancers are said to be estrogen positive, we virtually give all our patients tamoxifen. But with the new era, it is criminal and unethical to just give patients hormonal therapy without doing the immunohistochemistry to ascertain their status. So now that we can do immunohistochemistry, we're specifically talking to patients that are ER positive based on your immunohistochemistry or your FISH or your whatever method you are using. Approximately 2/3 of patients diagnosed with breast cancer have hormone receptor. That can be contested in some environment, but definitely less than 80% are ER positive. And estradiol is the main source of estrogen in premenopausal women, and it's synthesized in the ovary through the luteinizing hormone pathway. So there are many options on how to ablate the ovary to knock off the estradiol production. One is the surgical use. You can just go and remove the two ovaries in premenopausal patients. The other one is use of radiation therapy. And now we have the use of drugs. Even chemotherapy, the CMF regimen, was found to have the highest impact on inducing menopause in breast cancer patients compared to any combination chemotherapy that we use, the CMF regimen. But we also have the ovarian suppression, function suppression, in which we can use the goserelin, the luteinizing hormone releasing hormone agonists, which is reversible, which we have used severally in early breast cancer, early stage, that we want them to have children. We give them this goserelin, allow them to be treated for some years, depending on the stage, 2 plus the stage of the disease. So if it's stage 1, it takes the therapy for 3 years. Stage 2, it takes it for 4 years to 5 years. Then you withdraw and allow the woman to have baby if she so desire. But now it's also having relevance in locally advanced. Now you understand that in locally advanced breast cancer patient, node positive, there is high risk of recurrence. There is high risk of progression and metastasis. And the use of goserelin has also been established in this locally advanced breast cancer. So ovarian ablation or suppression has been shown to impede the estradiol production, thereby inhibiting estrogen-dependent tumor growth. Because in the ER positive tumor, the initiation, progression, metastasis pathway of this cancer is said to be controlled by the estrogen. Unlike in the triple negative, that other pathways other than the ER, PR, and the HL2 are responsible. So if that is what is making the tumor to grow, to progress, to metastasize, so there is logic in cutting off the pathway, cutting off the supply of estradiol, and then try to control the tumor. And this has been established many years before, so it's not new to us. Okay, and we have found out that the use of this goserelin reduces ovarian E2 production. And unlike ovarian ablation, its effect is reversed because it's a function suppression. And that's why when you are using goserelin, we are advising the patient also to use condom. Otherwise, the fact that the patient is not menstruated or something, cannot get pregnant because you are only suppressing the hormone function of the ovary. You are not totally actually inhibiting the possibility of getting pregnant. Goserelin has demonstrated efficacy for the adjuvant treatment of premenopausal women with ER breast cancer with equivalent disease-free survival to cytotoxic chemotherapy, especially when you are talking of the one that has the highest impact on inducing menopause, and that is the CMF regimen. And when you compare their safety profile, they are similar. So the monthly goserelin 3.6, I must say also that we have been used to the 10.8 milligram goserelin in prostate cancer. The only thing is that we are not trying to show that we can also use this 10.8 goserelin in our locally advanced breast cancer that are ER prostate. And that is not inferior to the one that we are used to, the 3.6 milligram. So monthly goserelin 3.6 milligram dosing suppresses the estradiol production and has proven efficacy. I've established this already. And the efficacy, safety, and endocrine effects of monthly 3.6 milligram with or without the use of tamoxifen in pre- and perimenopausal women with ER post-advanced breast cancer is well documented. That's also been saying that's what we mean by the non-inferiority. That is to say, the one is not inferior to the other. They are on the same platform. They are whatever you have assessed, the overall response rate, the progression-free survival rate, whatever it is, their result or the safety profile are all similar. And that's what we mean by non-inferiority. Furthermore, the combination of LHRH agonists with tamoxifen has been shown to be more effective than each treatment alone, depending on the guidelines you are using. There are guidelines that you can combine that emphasize the use. I will show you a small and nice guideline that you can combine the use of goserelin with tamoxifen, and the one you can use goserelin alone or tamoxifen alone. And how long do you treat this patient? So why is ovarian function suppression a key part of the treatment plan for premenopausal women at higher risk of disease recurrence? Academically, we know that the long survival status of breast cancer patient is determined to some extent by the presence of nodal involvement. Amongst other factors in tumor biology, age factors, and other factors, we know that once a patient has nodal involvement, the chances of recurrence is very high. 10-year survival decreases significantly. The second thing is a young woman. You know that this woman has a long life expectancy and is having an advanced stage disease. Definitely, in view of that long life expectancy, recurrence can take place. So all those things, I wish you can see the nice guidelines there. Any pointer here? Okay, it's too tiny for me to see on this screen, but you can see that the nice guidelines offer the use of this therapy for 5 years. The latest publication have shown that you can even use them up to 10 years because the fear of endometrial hyperplasia, endometrial cancer, and some other side effects have not been proven to increase. Okay, but whichever guideline you use, there is relevance of ovarian function suppression with use of goserelin. So what I mean by a phase 3 means this drug has been established to be relevant in a particular disease. And now you want to now try that particular drug to look at those other factors that probably the phase 2 has not been able to establish. So a phase 3, this specific study is a phase 3 open label randomized study comparing 3 monthly with monthly goserelin. And the essence is to see whether one is better than the other. Okay, in women that are having estrogen receptor positive advanced breast cancer. In this context, node positive breast cancer. It was designed to evaluate whether 3 monthly goserelin, that is a 10.8 milligrams subcutaneous, is non-inferior to the monthly goserelin that we're used to. These randomized open label phase 3 control trials compared primary goals, progression-free survival in premenopausal women after 24 weeks. So this patient that has T2N2 or less, and then you have treated them, you want to see what happens. Those that are receiving 3.6 and those that are receiving 10.8. Which one has more events in terms of safety profile, in terms of recurrence of the disease, in terms of unexpected findings. So that is a primary goal. But again, in addition to that, there are secondary outcomes, and that is overall response rate. And the results of the primary efficacy analysis found that goserelin 10.8 milligram demonstrated non-inferiority to goserelin 3.6. That is in every aspect that this study is aimed to look at. So do not discuss or do not look at the result outside the context of the study, the goals. So based on what we are talking about, progression-free survival, safety profile, and all those things, there was no difference. Okay? Secondary outcomes such as overall response rate were also similar between the treatment groups, suggesting that the similarities seen between the 2 dosing regimens are consistent across several efficacy parameters, progression-free survival rate and overall response rate, both numerically higher in Japanese study, although this sample size is a bit small, okay? So, and that is how the study was. About 222 patients divided into 2 groups. Both of them received tamoxifen 20 milligram. Really? And then one group is receiving 10.8 subcutaneous goserelin, and the other one 3.6. All other parameters the same. Okay, the stage of the disease, the ER receptor status, and everything. And the primary endpoint I've mentioned is progression-free survival at 24 months, 24 weeks, please. Now look at it. The results, the first one we're showing, which is progression-free survival, shows similar results. 61.5 in the group that is taking 10.8 milligram compared to 60.2 in those that are receiving 3.6 milligram. No difference statistically, okay? Even though when you look at it, it still favor the use of 10.8 milligram goserelin. Contraindication similar to, based on this, the patency given to goserelin is contraindicated in pregnancy. I don't have to talk about that because we know the estradiol needs to sustain pregnancy. And when you cut it off, definitely there is high risk of fetal loss and all those accompanying other side effects. Solades is excreted through the breast milk, so it's not allowed, it's not advised to give breastfeeding mothers. Other ones are all the same, decrease in bone density and everything. That's why it's combined with tamoxifen, because we know that tamoxifen tends to protect bone in premenopausal patients. So all the various safety profiles, very common. The ones that are common are similar in both groups. There is no major differences. There is no major differences. So a long-standing trusted treatment option reinforced by recent clinical data. That is to say the prestige study. We know there is a lot of ongoing studies in breast cancer. And so we're not looking at breast cancer in its entirety. Okay, we're only looking at an aspect of comparing 10.8 milligram with 3.6 milligram. And they has found that this use has gotten additional data from this prestige study that justify the use of goserelin 10.8 milligram in locally advanced breast cancer patients with or without tamoxifen. I know that we have been using 3.6 in our early stage young premenopausal women with ER positive breast cancer. But we're saying again now 10.8 can be used as we're doing in prostate cancer. So, goserelin can be used as a major drug for you to suppress ovarian function. The advantage again is that it's reversible. What you do is that when you are done with the use, especially in early breast cancer, that you want to give the patient the chances of having a child, you withdraw the drugs for about 6 months for a washout period. After 6 months, menses tends to come back and the patient can conceive. After conceiving and delivering, you give the patient additional 6 months to breastfeed, then you commence the drug again, and then you suppress the ovarian. I've emphasized use of goserelin does not stop pregnancy. You have to advise the patient, especially if they are not taking tamoxifen, advise the patient to use family planning, especially condoms. So with this, I'm sure we're used to injecting goserelin. There's nothing to teach you about there. And then thank you for this presentation. So now, thank you for clapping for me, but all the questions should be directed to Dr. Atara. He has all the knowledge that it requires to answer your question. As a presenter, I don't answer questions. Dr. Atara, is your headache now? Any question, please?
Thank you very much once again, Professor Sunday Adewi. A round of applause for him. So we'll be moving into the next phase, which is a panel discussion / question and answer session. We have a few questions here already, but I'm sure that some of us have questions to ask. And so you can please share your questions with my other colleague, Andrew, whom just waved his hands. So starting with the first question, I think this is addressed to Professor Adewi. So in terms of survival benefits as discussed in the prestige study, so the question is, did goserelin 10.8 milligrams offer superior benefits than 3.6? And also, were there any peculiar safety concerns? I think this has been addressed in the slides, but I'd like to shed more light, sir.
Yes, the study aim was to check whether it is inferior to the established 3.6. And that has been proven that it is not inferior. Even though when you look at the hazard ratio effect, are you getting me? It's in favor of 10.8 milligram of the goserelin. And the Japanese study also favors. Are you getting me? But we should not go out of the purpose of the study. The goal of the study is to establish the non-inferiority of the 10.8 compared to the 3.6. Secondly, the safety profile are the same. The mechanism of action is the same. It's a depot. It's a depot drug, it is released gradually. It's not as if you are loading the body at the same time. So it's released gradually over that period. So the safety profile basically as a result of the suppression of estradiol or other either based on the function of the ovary or some other secondary function of the estradiol on the bone. That we know that the bone aspect of the bone integrity of a woman is dependent on estradiol. That's why when a patient becomes menopausal, the bone integrity, the bone density rapidly decreases about 7% per year. Now, on a patient that is receiving additional therapy, hormone suppression, it becomes higher than that. Then, if, God forbid, they now have chemotherapy, radiotherapy, that's what we call treatment-related bone loss. Chemotherapy-induced bone loss, radiotherapy-induced bone loss. So it becomes cumulative. But when you look at it alone, these are phase 3.6 and 10.8 doses. There is no difference. And there are no different things, new safety concerns that we need to be worried about. We'll be using in prostate.
Thank you very much, sir, for doing justice to the question. So the second one actually is directed to Dr. Intekim. So putting into our local context on the use of goserelin in ovarian function suppression, can you please share your experience on how this has impacted your practice and the life of your patients?
Yeah, thank you very much. And good afternoon, everyone. Now, for the use of goserelin in breast cancer, we've had some few experience. Actually, up to like 2 years ago, the label stated that it's only 3.8 formulation that could be used for breast cancer. And so we wanted to design the study because as at then, the data showed that the experience with 10.8 milligram wasn't present yet. So we were actually planning to start a study on that to see how it will work in our population. But before then, we were told that NAFDAC has approved the 10.8 milligram use in Nigeria. And so we now decided to make it as a real world data in order to be able to see how it works. Now we've had about 8 patients now on it. Now what the criteria for selecting those patients is that they are premenopausal with the HER2 positive breast cancer. And we start them on goserelin. Actually, not all our patients that are able to afford it yet, but those who can afford, we give it to them. Now, for our experience now, we start at least 2 weeks before we expect the next effect that we are expecting. So 2 weeks before the start of either chemotherapy or other medications, we have to start goserelin because it takes about 2 weeks to start having its own effect. And then thereafter, after the first month, in one patient, we saw that there was like a breakthrough bleeding after the second week. And so that is explained by the fact that they could be due to acute withdrawal of estrogen, but others, by the end of the first month, their menses have stopped. And so we feel that at that stage, the estrogen level has now reached the menopausal level. So from that time onwards, they will not see their menses again. And then we continue every three months. So it has been quite very uneventful. Now, the other thing we have is that we've also had some side effects following it. Now, prominent, we had one patient that had some mood disorders, and so which we co-managed with the psychiatrist. And then they just give her psychotherapy. It wasn't really on medication, just some activities, and then to explain the cause to the patient as well. Now, the other few events that we had has been maybe now feeling of hot flushes in just one patient. That was after using it for like 5 times. And we also had one patient that had the difficulty with sexuality, let me put it so. The mood, the feelings were not actually there possibly because of the withdrawal of estrogen. And so we haven't had any issues now with the injection sites. All of them have been very fine. And then it's very convenient for the patient. Instead of them to come every month, they come every three months, and that is very, very convenient. And we are still assessing them, still monitoring their blood pressure and everything. So up to now, we don't have any event at all. Thank you.
Thank you very much, sir, for addressing this question. Okay, so I have some questions from the audience already. So the first question is, should goserelin be used for all cases of early hormone receptor positive breast cancer patients? And then the next question is, what is the recommended duration for use?
Yeah, for the recommended duration is minimum of at least 5 years. We could use goserelin for those patients. Now, in the very early stage, like T1 stage disease, we may not actually need to add goserelin because of the side effects that we are expecting, especially in addition to tamoxifen, which we know. So if the disease is very early, we may spare the patients from adding goserelin to tamoxifen. Thank you.
All right, thank you very much, sir. Okay. Would you
Yeah.
want to?
I think we advise people to stick to whatever guidelines, because there are a lot of guidelines in the market or available that people can use. But we have justified the use. If the question says the use of goserelin in early stage, I would prefer goserelin than tamoxifen, especially in a patient that wants to have pregnancy in future. Like I said, there's a working formula. And this is limited to only stage 1, stage 2. You cannot justify use of, encourage a woman with stage 3, stage 4 disease to carry pregnancy. It's not justified because she may not be able to carry that pregnancy and survive. So the essence is for stage 1, stage 2 that wants to get this pregnancy. The 5-year rule that I mentioned, which is general rule, may not be fulfilled, but for stage 1, purely assessed with stage 1, that period must take for at least 3 years. And for stage 2, that period must take at least 4 to 5 years to ensure that the risk of relapse, are you getting me, has been minimized. Because the danger zone for progression is figured after 24 months. Are you getting me? So we ensure that, and then patients can be given. So goserelin in early breast cancer for women that wants early stage, is my priority. But in advanced stage disease, depending on what you want to do, combination with tamoxifen is a good option. It's the cost that hinders us from using goserelin with tamoxifen. Are you getting me? Otherwise, I think the NICE and the ESMO protocol justify the use of the two. And maybe we will come to a level where the cost of goserelin will drastically reduce. I'm not interested in the cost for those that can afford it. But when I talk of the generality of the people, then the cost becomes very important. For those that can afford it, thumbs up. But for the generality of the people, I think we have to factor in the cost and sustainability of this treatment over 5 years and beyond.
Okay. Thank you very much, sir. So we have another question here. Okay, can you comment on the use of LHRH antagonists as compared to goserelin in terms of suppression of testicular function? If this addresses prostate CA.
I didn't get your question.
Can you comment on the use of LHRH antagonists antagonists as compared to goserelin in terms of suppression of testicular function?
Yes, you see, the antagonist, Abralix, or Decarelis, Pharmagon, in a situation where you want to crash the level of testosterone within 24 hours, that is your choice. You go for the antagonist because they don't have clear effect. And then your testosterone levels crash within 24 hours, especially in patients that have imminent cord compression and all those things. But when you want to use in prostate cancer, goserelin, which is an agonist, he has explained it takes about 2 weeks to 4 weeks for the level of testosterone to begin to drop. And if there is cord compression or imminent cord compression, there will be worsening at that level. And that is not a good time. And that is why we start with bicalutamide first, before we go into the goserelin, to minimize this flare effect and worsening of symptoms that may apparently make it a bad market for you. Because the patient will just have worsening of symptoms and it will be on your head. So if you have a situation where you must crash the testosterone level within 24 hours, the Decarelis, Pharmagon, Abralix is your option, the antagonist. When you do not have that scenario, are you getting me? You can go for a goserelin. I hope I answered the question.
Yes, sir, you did. Thank you so much. I wouldn't know if Dr. Intekim has any additions to make to that question.
No, I think that is the position. It's just for quick action. Let me put it so.
Okay, thank you very much. So I think one of the questions yet to be addressed will be around cost for the patient. I think that is where my colleague Morris comes in for adventure.
So thank you very much, Akin. It's a question that anybody would anticipate. I think even beyond the pricing of Zoladex, one of the biggest challenges we have had has been the erratic nature of the brand in the country. And I think I'm proud to say that for the past 2 years, there's never been any incidents of out of stock situation of the brand in Nigeria, which is a plus. Now on the price, if you go to purchase any pack of Zoladex today, it is at least 65% of what it was last year. So we've taken a bit of concession on the price as well. Now there's a bit around access, which we are currently driving. So for those special patients or those special institutions that need a bit of preferential pricing, there are avenues to be able to leverage some preferential pricing for them as well. And should you meet anybody within the team, they would be able to assist in this regard. I think ultimately when it comes to pricing, it's really about the CAP program. We are not there yet, but I think I can share that we're currently working with the Federal Ministry of Health, as well as a couple of other partners to ensure that we have the brand on the CAP program. Give or take, probably by next year, first quarter or second quarter, we should be able to have this on the CAP program, hopefully, to make it available to a wider population of patients. Thank you.
All right, thank you very much, Morris. So I hear that there's a question online. So can you please share on the screen? Okay, so the question is, can goserelin be given together with chemotherapy? Yes.
That have some other adverse characteristics. For instance, vascular invasion, lymph node positivity, and other aggressive features as such. So in such cases, goserelin can be given with chemotherapy without any issue. Actually, in our patients that we are treating, we give them with chemotherapy. And it can also be given with tamoxifen because the use of goserelin in HER2 positive breast cancer was actually recommended after a study, the SOFT study, that actually compared using tamoxifen alone or using tamoxifen with goserelin. And it was found out that there was an 8% increase in the disease-free survival. And so that was like 6 years ago. And that was when we started advocating the use of goserelin with the tamoxifen. Now, in some practice, with the cost of goserelin, some people were now actually using oophorectomy in addition to tamoxifen because it was found out that tamoxifen cannot completely suppress the estrogen. So there was a need for an additional modality to be able to get more or less a zero level of estrogen, especially in those that are premenopausal. So yes, goserelin can be given with tamoxifen. It can also be given with chemotherapy in patients that have some more aggressive features. Thank you.
All right, thank you very much, sir.
Just a minute. You see, there is a lot of changes in the way we are managing breast cancer. And now there is a very big room for the use of neoadjuvant therapies in breast cancer. So when you are using as a neoadjuvant therapy, before then, we usually maximize the benefit of ovarian ablation, first by waiting for surgery to happen, then the effect of chemotherapy, after chemotherapy, hormonal therapy, the concept of cumulative effects after sequential treatment. But with the area of neoadjuvant, there's only stopping you if a patient is ER positive to use the hormonal therapy as part of your neoadjuvant treatment before surgery. That is combining with chemotherapy, like I said. There is nothing that stops you because now neoadjuvant has become a major way of downstaging and improving survival in breast cancer. And now we see a lot of pathological complete remission when we treat in my own center, when we treat with neoadjuvant therapy. So there's no contraindication to that.
Thank you very much, sir. In the absence of any more questions, I'd like to say that we give a round of applause to our panel members. And so I'll be calling on my other colleague, Eric Ojuki, to give his final word. Round of applause for him.
Good afternoon, everyone. My name is Eric Ojuki. I come from Kenya. I'm the brand manager oncology for Sub-Saharan Africa, and the brand manager for Zoladex. Okay. So mine will just be very simple, and to let the key opinion leaders present in this room to know that we are officially launching Zoladex 10.8 in management of breast cancer. I understand that most of the key opinion leaders were using it off-label, but this is already approved. So what we are trying to work on is just to improve the compliance of our patients and also to reduce the monthly injections of the Zoladex 3.6. And also I hope this will really improve the DOT of our patients who are receiving Zoladex treatment. Otherwise, we are very grateful for the partnership with Akon, and we are looking forward to many more. Thank you very much.
Thank you so much. Thank you so much, AstraZeneca team. Thank you, Professor. We've learned a lot and we're really, 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 really educated now. I had assumed there was going to be an official launch. I don't know if I missed it, but we'll move forward very briefly, very quickly, I mean. And I know that it gets to that point where our glucose level is going low, but unfortunately, we didn't start as early as we ought to. And we're just craving your indulgence to finish this last session while you replenish some of the glucose with the candy that has been provided. I know it will not make up for it, but please just hang in there, and in a very short while, we'll be having a most delightful lunch. And so let's just go forward with the Pfizer presentation. I hope they are ready for their presentation. I'm wondering if it's online because I see Dr. Jimo's name, and I haven't seen him in the hall. So okay, so we have cancer immunohistochemistry test conducted in Nigerian teaching hospitals. This is a presentation by Dr. Jibril Paul, and it's for 15 minutes, I guess. 15 minutes. Dr. Jibril Paul is a pathologist at the National Hospital, Abuja, and this session is being sponsored by Pfizer. We're going to put your hands together for Dr. Jibril Paul. So the Pfizer team has come on, but Ame Ignatius is marketing manager for Pfizer. Am I right, sir? Okay, so I'm just going to hand over to him so that we can very quickly finish this presentation and then we'll go for our lunch break. So put your hands together for the Pfizer team. Ame Ignatius, over to you.
Thank you very much. Good afternoon, ladies and gentlemen. The ARCOM presidents and all the LOC. Pfizer is proud to partner with you and to join you on this conference. I would like to invite my colleague, Chioma Ozomena, to join us here. And at the same time, I will introduce Dr. Jibri to do justice to the first topic. Thank you very much.
Good afternoon. It's a privilege to be among you. I'm talking about immunohistochemistry in Nigeria. Immunohistochemistry, I think when immunohistochemistry started in Nigeria before 2006, immunohistochemistry used to be, I'm coming. It's not working now. Before 2006, we know immunohistochemistry is only in Ibadan. IMRAT, they are the only one doing ER and PR receptor. And I think it was sponsored by one of the prominent oncologists in US, Professor Lakade. By 2006, and that one, I still remember I was a resident in Calabar then. You send specimen to them, report will not even come back to you. So around 2006, that is when we started the routine immunohistochemistry services in this country in public hospital at National Hospital. Kudos to our pioneer CMD. I can see him sitting down here. So 2008, we have the placements of automated machine at National Hospital and LUT. But up till now, we are still, immunohistochemistry is automated in National Hospital. As today, there are many testing centers, both in public and private hospitals. And 2018, issue of quality assurance and quality control was initiated by Roche. And they subscribed National Hospital to UK NEQUAS. We were just looking at the ER. It's not everything that is brand that is positive. And so quality issue is very, very important. Currently, we have in place a national quality assurance program anchored by Roche and then West African Division of International Academy of Pathology. What is immunohistochemistry? Just the localization of antigen in tissue section by use of a label antibody. The principle is based on antigen-antibody reaction. And immunohistochemistry is nothing more than the combination of immunological principle, biochemical technique with histological method in tissue diagnosis. And actually it started with microbiology. Immunohistochemistry is a technique used to identify cellular or tissue antigen using antibody. Brief history, the theory has been in existence since 1930, and we are just starting 2006 routinely. And Kuhn introduced the immunofluorescent to label antibody. 1942, that is when a published article about the recognition of pneumococcal antigen using immunohistochemistry. So it's microbiology that gave birth to it, and we have taken it over. Because of the short time I have, the principle of immunohistochemistry is nothing more than antibody-antigen binding, and then localization and visualization of the immune complex by markers. You can use fluorescent dye, you can use enzyme and radioactive substances. Method of immunohistochemistry, we have direct method. The label antibody react directly to the antigen. Indirect method, The label antibody react with antigen through the bridge of the primary antibody. Peroxidase, anti-peroxidase method, PAP method, and this is what we call the direct method. You could see the antigen in the tissue and the antibody that is labeled. The label is what is recognized. What are the advantages of the direct method? The procedure is short and quick. It's used for rapid, quick, and diagnostic testing. The procedure is insensitive, and because of the antibody concentration may not be detected by light microscope, and is rarely used now. What we are using now is the indirect method. You have a primary antibody that is developed against the tissue antigen, and you now have the secondary antibody that is developed against the primary antibody. It's a secondary antibody that is labeled by a marker, which is most of the time enzyme. That enzyme, you now put a substrate. When there is binding, the enzyme will act on the substrate and give you a color coding, which is what we, the pathology, look at and give you the report. It is sensitive, is greater, sensitivity is greater than the direct method. The cheaper secondary antibody is labeled preventing wastage of primary antibody. And secondary antibody can be from different animal species. The procedure is laborious and it takes some time. Application of immunohistochemistry can be used in diagnosis, especially in metastatic tumor of unknown origin. And determination of the primary site of the metastatic tumor is also prognostic, just like Adewuyi was talking about ERPR. I didn't want to. ERPR now is not just the ERPR are divided into, their prognostic index is divided into 4. ER/PR positive and ER positive and PR positive is different from ER positive and PR negative. It's also different from PR negative and PR positive and ER negative. It's also different from the one that have what we call Ki-67 index. And so, yeah, immunohistochemistry can be used for prognosis and then predictive factor for treatment response. Then theranostic markers. There are so many of them you know of, apart from the HER2, your GIST. We have Ki-117 that is used to determine whether the patient will respond to your the diagnostic power of any immunohistochemical procedure is not greater than the wisdom of the pathology interpreting it. So the gold standard in diagnosis is your histological. It is very, very important. So we want to look at the role of immunohistochemistry in the management of breast cancer. I won't bore you with all this, but breast cancer is the most common female malignancy and is the second leading cause of mortality among female. The etiology of breast cancer is still largely unknown, and risk factors are genetic, hormonal, environmental, and socio-biological and physiological factors. So the management of breast cancer is multidisciplinary, involving the surgeon, the radiologist, the cytopathologist, the histopathologist, the radiotherapist, the oncology, and the physiotherapist. And so in treatment planning, you have to get all of them together. Early detection is the strongest predictor of overall survival. What is the story in Africa? I was wondering, can you still risk treating a patient with only hormone receptor? Because in our own environment here, most of the time your patient present with more than 5 mm, about 60% of the patients that present to you in the clinic, the size of the tumor is more than 5 cm. And about 75% of the patients that present in most of our clinic here, they are in stage 3 and 4. And you cannot afford to use monotherapy for them. So this is just the histologic and the molecular subtype. We know that the triple negative, they constitute about 15 to 20%. There is no receptor expression. The histologic grade, the triple negative most of the time are grade 3 tumor, high grade tumor. Their prognosis is very poor. Even the triple negative can also be classified into 4 using even your immunohistochemistry. You have the one that is called androgen receptor positive. They are also luminal type of the triple negative. If you can, if your pathology give you triple negative, please insist that it should do AR for you, and your patient will benefit from what you use in treatment of your cancer of the prostate. And then the response to medical therapy, apart from chemotherapy. HER2 is still 10 to 15%. There's expression of the HER2 gene and amplification too, which can also be determined by immunohistochemistry. Histologic grade is most of the time high grade. And the HER2 type can also have hormone receptor enriched. And so they belong to a group that is called luminal B. And then the hormone receptors, they are divided into A and B. ER/PR positive are luminal A. Now in a center where you do real immunohistochemistry, it is important for you to have Ki67. Any ER/PR positive tumor that is Ki67 low, it belongs to luminal A. Their prognosis is very good. But any ER/PR receptor that is Ki67 high belongs to luminal B. And also any ER/PR receptor positive tumor that is HER2 has been separated already into a HER2 group that is hormone receptor rich. And those are the ones that you can consider the combined treatments. So in breast cancer, diagnosis is a key. And so you can't do without a pathology. 10 minutes more. It's okay. I'm coming. So this is a classification I was just talking to you about. The treatment options are there for you to see. They had 2 in breast cancers. In the 80s, that is when HER2 expression, overexpression was identified. It's a prognostic factor. So HER2 is very, very important prognostic factor that correlates with worse outcome. But in nodal positive, to those that are 3+ or 2+ that have gene amplification, the survival with your Herceptin is very, very good. So it is also a predictive marker because of the targeted therapy. And HER2, I don't want to bother you with the time again. So, but you know, immunohistochemistry is very, very important. And since it's very important, it has become an established integral part of diagnostic process since its introduction into the routine histopathology since 1980. IHC is now able to provide prognostic and predictive information, such as likely response to specific treatments and pharmacodiagnostic marker like estrogen, progesterone, HER2 overexpression. You can see your CD117, the c-kit, and then CD20 for MAPTERA. Because of this increasing diagnostic and prognostic role played by immunohistochemistry, which may directly impact on patient care pathway, it is vital that this investigative procedure are properly controlled by monitoring quality, both internally and externally. We started immunohistochemistry in experimental basis before 1960, in 2006. We routine laboratory testing started around 2006, and now we have many centers that are doing immunohistochemistry. But I want to say it's not all that is brand that is positive. There are a lot of quality issues that can be responsible. If you look at some of the publications from Nigeria, for some time now, they will tell you that ER/PR is very low in Nigeria. It is not true. It's because of the pre-analytical issue. And so that is why I am not advocating every center to have immunohistochemistry. For now, because of the quality issue and regulation, I think it is better for us to have a regional lab that you will have as an oncology for you to take a report of a pathology. How many of the HER2 is he seeing per day? If you are not seeing up to 5 per day, I will take it with a pinch of salt. So proficiency testing and the amount that you are seeing. And then if you are not subscribing to external quality control or internal quality control, but there's nothing like that in the country for now. There is no organization that is responsible for that. And so because of that, for now, I still believe that we should restrict our immunohistochemistry to regional center to where people will see enough and then have some proficiency. There are so many issues that are responsible for quality control. It's not only in the lab alone. Like I said in the morning, the reason why we have a lot of triple negative is because of cold ischemic period. The surgeon will remove the tumor and then leave it on the table. It will take more than 1 hour before they put it in the formalin. And this antigen we are talking about is protein. There'll be antigen degradation. Anything more than 1 hour, I'm not sure what you are going to get. Do you understand? For most of the membrane antigen and nuclear antigen. And that is one of the reasons why the delay in fixation and the type of fixative that you use are responsible for, no problem, are responsible for the triple negative that we think is high in this country. If triple negative is high, it's just because of the demographic, the population. We have younger population. The triple negative are commonly seen in younger people. So when you now see older people, triple negative, and then you look at the histology, 2 black carcinoma, triple negative, you, the oncologist, should asterisk it and ask for a repeat. So there are so many issues affecting the staining quality, like your fixation, the quality of fixative. The recommended fixative is neutral buffer, 10% formal saline. But what is commonly seen in most of the lab is 10% formal saline. And in some places, I have, even within Abuja here, you see a surgeon sending a specimen to you in saline alone. And when you get it, of course, you are going to give the patient a triple negative. So most of our triple negative are not triple negative. And so, I don't have time, but the standardization of immunohistochemistry protocol in Nigeria is very, very important. Multidisciplinary approach by all the stakeholders, the surgeon, the oncologist, the pathology, and the lab scientists. The standardization of the pre-analytic and analytic issues, and even the reagent. A lot of unqualified vendors are bringing reagent. You don't know whether it's Ventana, BioCare, or all kinds of. Please, it is very, very important. This especially had to imagine you are going to give a report to a patient that is going to spend almost 6 million for Herceptin. You must be sure of what you are doing. And so standardization is very, very important. Regular review of the process and the product, establishments of national quality assurance scheme, currently midwife by Roche, regional and referral lab for prognostic markers, external quality assurance and proficiency testing program are invaluable to maintain a standard. IAC protocol, so this is just immunohistochemistry stain to evaluate the overall percentage of the cancer in sample, reporting this is post-analytical issue that will not bother you with. And then these are the staining. Yes, I have just 2 minutes more. So recommendation, finally, multidisciplinary approach is the most important thing. From patient, the surgeon, even the ward attendant. Some of them will take sample from the theater, will go and forget it somewhere before sending it to the pathology. So for now, I will advocate the regional testing, especially for prognostic marker, and continuous education and training of the pathology staff. Automation of the regional center to take care of the quality control issue. And all new products of the antibody should be sent to a regional center for post-marketing validation before use as much as possible. Streamline the product for uniformity. If our patient must benefit, we need more unity at the working environment. Telepathology for life experience sharing among the pathology is very, very important. Time too short. Thank you very much for listening to me.
Thank you very much, Dr. Jibri, for doing this nice justice to this topic. I want to apologize on behalf of Dr. Jimo. He was supposed to be taking the second topic, but is away for another event. And we will be substituting that lecture with our Pfizer presentation. We'll be doing much on Ibrance today, palbociclib, which you all know about. But we'll just look at just few things on it, and then we'll follow it up with our patients affordability program. Dr. Jibri just talked about cost of a product, and we know these things are not really easy. Pfizer is finding a way out. I want to specially recognize the presence of my regional manager, Arome Obaje, is here very present with us, and the medical manager, Dr. Solomon Obepa.
In a normal cell, progression through the cell cycle is controlled by an intricate molecular system. Conceptually, we look at this regulation in terms of distinct phases of the cell cycle. In cancer cells, this cycle is not regulated, leading to an absence or loss of proliferative controls. Within the cell, growth factors stimulate multiple signaling pathways. These pathways converge downstream in the nucleus, activating cyclin-dependent kinases or CDKs. When activated by cyclin D1, CDKs 4 and 6 play an important role in driving cell cycle progression. They initiate phosphorylation of the retinoblastoma protein, or RB, which allows passage through a critical checkpoint where cells commit to progression through the G1 phase of the cell cycle. After passing through the checkpoint, E2F transcription factors are activated, driving gene expression. Entry into the S phase triggers DNA synthesis and commits cells to completing the remaining cell cycle phases required for cell proliferation. In a number of cancers, the dysregulation of CDK4 and 6 has been associated with loss of proliferative control. Preclinical studies demonstrate that inhibiting CDKs 4 and 6 in tumor cells blocks RB phosphorylation and therefore cell proliferation. The selective inhibition of CDKs 4 and 6 and the role it may play in restoring cell cycle control in cancer is a vital area of study at Pfizer.
Thank you. That is a brief mechanism of action of Ibrance palbociclib. Thank you very much. So briefly, we'll look at Ibrance, and the indication for Ibrance is for hormone receptor positive and human epidermal growth factor 2 negative. Ibrance can be combined with aromatase inhibitor as an initial endocrine-based therapy or fulvestrant in patients with disease progression following endocrine therapy. Ibrance come in a dosage form of 75 milligram, 100 milligram, and 125 milligram. A randomized double-blind placebo-controlled phase 3 efficacy trial was carried on this very product. And in this trial, postmenopausal women with HER2 negative advanced breast cancer were used with no prior treatment from advanced disease. The number considered in this case was about 666, and other stratification factors include disease site and DFI metastatic. Ibrance was used in combination with letrozole, 125 milligram to 2.5 milligram daily. And it was compared with letrozole with a placebo. This is done for Ibrance and letrozole for 28-day cycle, while letrozole was being done for continuous once daily for a month. And then for the other group, letrozole and placebo, 1 week off for 3 weeks. The primary endpoint the investigator took into consideration was the progression-free survivor, and other secondary endpoints considered include overall survivor, objective response rate, duration of response, pharmacokinetic effect, among other like biomarker assessment. Ibrance in Paloma 2 trial was carried out for about 37 months. And from this trial, 35.7 months of mean progression-free survival was recorded with Ibrance and letrozole, while about 19.5 months with placebo and letrozole compared to Ibrance and letrozole. My time is already knocking at the door, so I have to move faster. There's improved tumor responses for visceral metastasis, 55.1 of Ibrance and letrozole compared to 40 of letrozole with placebo when you consider the objective response rates. Also, reduction in risk of disease progression about 38%. And in bone-only disease, we have about 30.4 months median progression-free survival rate for Ibrance and letrozole compared with 16.5 months of placebo with letrozole. I will have to move faster. Ibrance is the only CDK6 inhibitor with over 4 years of real-world experience that complement the weight of robust clinical data. As we can see from 2 large pivotal phase 3 randomized trial, Paloma 2 and 3, over 1,000 patients with H2 positive and HER2 negative metastatic breast cancer were enrolled. FDA have approved, since FDA approved in 2015, over 16,000 prescribers worldwide have chosen Ibrance over other brands. About 225,000 patients Ibrance have been prescribed for since 2015, and it has been approved in over 84 countries, according to the real-world evidence. Now, Ibrance is convenient as a once daily pill, and you take for 21 days with a 7 days resting period while you continue with letrozole. And depending on the response of the patient with Ibrance, there can be modification from 125 milligram to 100 milligram and to 75 milligrams as the case may be. Pfizer as a company have this objective to bring breakthrough that change patients' life. And we have come about this innovative brand, which have powerful clinical efficacy, real-world experience, patient-reported outcome, established safety profiles, warm monitoring provision, and again, 1P, 1 daily. Eye brands have been recommended by international guidelines like the NCCN guidelines 2019 and the ASO and ESMO guideline of 2018 have supported the use of eye brands as a CDK4 and 6 inhibitor. I will now invite my colleague to walk you through in 5 minutes our affordability program. Chioma, please come up. Please.
Thank you so much, Ambe. My name is Chioma Ozemena. Please permit me to stand on the existing protocol. Thank you for the opportunity given to us to have this presentation. So I want to say that Pfizer on. Okay. So we are having an access program for eye brands and other of our innovative molecules because Pfizer is a patient-centric organization. Whenever we launch innovative brands, we launch alongside an access program. We understand that cost has been a challenge when it comes to managing our patients, and we also understand the place of cost in oncology management. We've heard a lot about bridging the gap, closing the gap to ensure that our patients have the best. So we have our access program by Pfizer, where patients can get discounted prices for our molecules, and they can also get free medications when they are enrolled on this program. And they can also have opportunity to pay instrumentally, when they are on this program. We have partners who are partnering with us to ensure that patients are able to get those benefits. So what are the objectives of this program? What do we want to achieve? We are looking at ensuring that this project helps our patients who need eye brands. We also have other of our molecules on this program, to assess those life-saving medications. And third, we are improving the access to treatment by looking at improving access to treatment to our patients, ensuring these products are made available, bridging health inequality as well, because we want all patients to have access to our innovative molecules. So this is already running. We have it in Nigeria. The program is already ongoing in Nigeria in our different centers. We have our representatives over there. So when patients get an eye brand prescription, those patients are encouraged to be enrolled on the access program. They can pay instrumentally and they can get some free packs, as they are enrolled. This is what Pfizer is known for. We've not just done that for our oncology brand. We have made such impact also in our anti-infective portfolio, where we can have our Meronem, brand of Meropenem, being enrolled in the National Health Insurance, and Pfizer is giving 50% discount, on that program. So Meronem that should have been sold for 8,000 for the 1 gram, we have patients picked it at the rate of, should be sold for 15,000, patient getting it for 7,000, and it's still something we are doing here, where our patients can get eye brands at a reduced, cost. So these are the broad range of patients that we are talking about. Our premenopausal patients, our frail elderly patients with bone-only disease, our patients that have visceral disease, and those patients who are heavily pretreated, with that has visceral disease. These are the categories of patients we are looking at, that can be enrolled in this access program. Pfizer does not want us to keep losing patients because of cost. We don't want our patients to die because they don't have access to innovative brands. That's one of the reasons we are introducing this project, so that we can have more patients come on board, save life, improve the quality of life of our patients. Okay, so this is what it looks like all over the globe. The project is ongoing. Nigeria, we have Ghana, African countries, and we also have our accord programs where Pfizer gives out free molecules, free products to ensure that, low-income countries and developing countries can have access to medications. Those are the part of things that Pfizer is doing, as a patient-centric organization. So how does it work? Pfizer is coming as the giving financial support. We're working in collaboration with our doctors, our physicians. So as those patients are enrolled, they go through our partners to get them fill the form, which the doctors will also sign. And the form gets back to the partners. They're being assessed to know what category we should place those patients on. There are patients that can buy 1 pack of Ibrance and they get 3 free packs. Those 3 free packs is about 3 million thereabouts. So Pfizer is giving out 3 million naira for just 1 patient that can be enrolled on the access program. And some patients can get 2, 1, depending on the eligibility. So this is what we are doing. And we want our doctors, to partner with us so that we can improve, the well-being of our patients. Okay. This is about the access program. And we have success stories. On the screen, we could see patients who have been referred, patients who have been enrolled, and patients who are benefiting already from the program. So there are numbers of patients in our different centers, who are already benefiting from this access program since July last year. We started 2020, so we've been having increase from there to there. And we could see our HCP that are already engaged, our doctors who are prescribing those molecules, and our patients who are also benefiting from those brands. So this is what Pfizer is doing. This is the brand Ibrance. We have the 125 milligram, the 100, and the 75 milligram. And all these products are available in the market. So I want to appreciate you for this opportunity. And I hope that we'll work together to ensure our patients have the best of our medication. Thank you.
So thank you very much for listening to Pfizer. We'll give just a few minutes for questions. If you have any question for Dr. Jibri or the Pfizer team, please, you can go ahead.
Any question, please? Any question for Pfizer? And you can actually meet Pfizer in their booth. If you have any concern, concerning the access program at any point. So thank you. Since there is no question, we thank you most sincerely for what you are doing. And so give a round of applause to Pfizer. Thank you. Thank you so much. So pick one, lunch is served. It's when you step outside, there is a staircase, just climb on your right-hand side. Please carry your tag because they are going to be scanning you as you go in to have lunch, because we have a lot of gate crashes, and we want to be sure that after wasting so much time, you are able to eat a sumptuous meal. So please carry your tag so that they can scan the barcode. Thank you. We will resume in an hour, please. In an hour. Thank you.
Good afternoon, everyone. Thank you for coming from lunch for the next session, the last session for the day. We'll be having some presentations by ASIUCO, NSH, and HCG. And we have a presenter online that is supposed to talk to us about some issues around psycho-oncology. For this session, I'll be calling the moderators, Dr. Samuel Otene, a consultant radiation oncologist with the Federal Medical Center, Makurdi, and Dr. Jimeta. Thank you, Dr. Otene, for accepting to moderate this session. I'll leave it for you. So any presenter that comes. Okay, he said he's online. They are trying to talk to him. He's not responding. So you can call, ask you for people to come. What I do? What you want to invite your people?
From here to here. From here to
Professor Sheikh is supposed to talk to us about psychology before this. They said he's online, but he's not responding. So you can call your people. I will try to set you up.
just my people I'm telling.
Yes. We are called, okay, should we, no, we can't call all of them. Say they're not from the same. They're not really here. So let us see if they come up.
So I just call my people.
Yes.
All right. Good afternoon, ladies and gentlemen. The hall is now, we are very few here. Usually when you do anything postprandially is like this. I hope a lot of people will not sleep off before the end of this session. Quickly, we will go into the session after the lunch break. That is the one that has to do with, just like Dr. Madu mentioned, psycho-oncology and the presentation from ASIUPO. Particularly, okay, you see, that's what happens when you are a JJC. We want to call on the presenters from ASIUPO. Okay, I think it's not a panel presentation, so it's a singular person I would call. I have the singular honor of requesting that Dr. Sekina Abiola Adewale steps forward. She is a consultant radiation and clinical oncologist. She is actually my head of department currently at ASIUPO Comprehensive Cancer Center in Calabar. She will be speaking to us on shaping the future of cancer care in Nigeria, the ASIUPO experience. You're very welcome, Dr. Adewale. Okay, you have just 20 minutes to talk, but we'll be very glad if you could even shorten it to 10 or 15. Thank you.
Right. All right, so all right. So just good afternoon, everybody, my senior colleagues, and everybody around. All protocols duly observed. My name is Abiola Adewale, and I am one of the radiation and clinical oncologists that practice at ASIUPO Comprehensive Cancer Center in Calabar. I bring you greetings from my executive director, Mr. Yegwa Uko, and the chief medical director, Dr. Benga Kajobola, who is a consultant radiologist. I'll be speaking this afternoon about what ASIUPO is doing in shaping the future of cancer in Nigeria. Now, I wouldn't talk. Okay. Now, there is no ASIUPO Comprehensive Cancer Center without mentioning our late chairman, General Anthony Stephen Ikaba Uko. Now, this man, he is not a doctor, neither is he in the medical field in any form, but he saw a need and he fulfilled it. Far back as in 2013, there was an history which happened. A young man was involved in a road traffic accident and he had an head injury. He was supposed to have been taken to the theater, but the neurosurgeons needed just a CT scan to be done to decipher what was the intervention which they were going to do. But there was nowhere in that region where they could get a CT scan done. Then running around to get an air ambulance to fly this young man to UCH took quite a long length of time. Now they got the man to UCH, but you can imagine what the outcome could be. And then this is just an example of how we are losing our brains. We are losing the young ones. We are losing a lot to us not having what we should have in each region. So this man decided in 2013 to start a diagnostic center. So even up until today, many people look at Asiuko as still a diagnostic center because actually it started as a diagnostic center. What do we have in the diagnosis? It ranges from the pathology aspect, including but not just the histopathology. We have chemical pathology, there is hematology, and then going forward also, we have the diagnostic radiology, which includes a CT scan, MRI scan, we have 4D mammogram, we have 4D ultrasound. Now, also, he also has a modular lab, a modular theater, such that if we do have these cases, this patient would not need to travel for their surgeries again. Then he looked forward after this diagnostic center to make it a full-fledged hospital. So he moved from being a diagnostic center to being a full-fledged hospital. And then the newest kid, which is the Comprehensive Cancer Center. Now, our late chairman is also a survivor, a cancer survivor. And also he has some siblings which he also lost to cancer. Now, looking at what they went through to get diagnosed, to get treated, he says he must bring this nearer home. Now, when the Asuko Comprehensive Cancer Center started last year, this is what we met. The diagnosis of cancer can be devastating. That is what the patients tell you. Now, they say, if you hear the word cancer, it's a death sentence. So the diagnosis can be devastating. The patients are usually at the mercy of their emotions because what they say is, oh, madam, your husband has cancer. We have to send you to UCH in Ibadan. Now, by the time a doctor starts sending you to some other doctor to treat, it means, oh, does it mean that this man cannot treat me? Does it mean that there is no hope anywhere? So the patients are left at the mercy of their emotions. But at Asiuko, we have the first-hand experience of the influence of survivor testimonials on the emotional well-being of patients. And I'm really going to run through this afternoon. Now, but before I go there to talk about our patient testimonials, I just quickly want to briefly talk about our equipment. We are equipped with a linear accelerator, which is Electra Synergy. It has agility head, 3 photon energies, and we have 5 electron energies. They've got the largest CT simulator in West Africa, and we have a Flexitron hydrospheric brachytherapy machine. These are some of the dosimetry kits that we have: a PTW beam scan, which is motorized water phantom. CT SIM is specifically dedicated to radiotherapy. So we don't need to say, oh yes, we have diagnostic patients, we cannot simulate our patient. It's a simulation specific for radiotherapy. I think I talked about that the CT SIM is a 90 cm largest bore CT machine in sub-Saharan Africa. It's very useful because it can accommodate any patient position. So the patients are actually comfortable during simulation, and then they're able to go through treatment. It provides comfort and safety for patients of all sizes, and it provides optimum CT imaging for treatment planning. This is the image of the Cannonball CT simulator, and that's our agility head Electra Synergies linear accelerator. Okay, there's so many things that have been said about this today. All right, I'm going to briefly talk about this young girl because the story actually is peculiar. It's a 12-year-old girl that was diagnosed with poorly differentiated nasopharyngeal carcinoma. She was referred from another state to Calabar. Now, this young patient was diagnosed about 2 years ago, but they could not afford treatment. Now, the mom is just a petty trader, and the father is a security guard. So once they got this diagnosis, what they meant was, okay, yes, let's carry this girl to the house and let's watch her until whatever is going to happen happens. But the mother could not take it again because the disease kept progressing. and then the child gets more debilitated. She couldn't take it again. So she decided to go back to the hospital to seek for help. What then happens to her is that she got doctors like us paying for our treatment until she came to Calabar. This is our high-dose rate brachytherapy machine, 40 applicator channels intracavitary for an interstitial. We have, it's fast, it's efficient, and it's safe for patient treatment. Now, I'm going to go back to that girl's story. Now, this girl was sent to our center because people were able to fund our treatment. Now, by the time she was in the center, our mom just said, okay, what she needed was just that this girl should stop being in pain and then she'll go back home. But when she came in, we needed to do confirmation of our diagnosis because the histology report that she came was neither here nor there. So we had to send for a second opinion to really confirm that it is NPC, it is laryngeal cancer that she had, and actually polydifferentiated. And then also needed to send for the EBV testing. The St. Jude Cancer Center was actually very helpful for us, children cancers in the States. They were actually helping us in our treatment plan. So we confirmed that diagnosis, and then we sent these patients with the mom and her sister for counseling. So the counseling was done by us, the oncologists and the nurses. Then after the counseling was done, the mom was now said, he mentioned something. And so, oh, does it mean that my daughter can get well? That all she wanted was that she shouldn't be in pain again until whatever will happen happens. So after the counseling, our fear was allayed a bit. So we prepared her for treatment. She had a CT simulation done, and then we contoured. Then the treatment planning was done. We did the dosimetric check, and then she started her treatment. And then she continued with weekly reviews. Now, this is the protocol that we have added at ASIOCO, because we know that there is the psychosocial distress, which is so much so associated with cancer diagnosis. It is so real, and it is very, very palpable. We cannot separate it from cancer treatments. Now, we have so many innovations now. We have stereotactic body radiotherapy. We have so many things, but we cannot go away from these patients. So that is why we decided to add this to our protocol. The ASIOCO protocol is, as it has come to be known, adds a new layer to the conventional protocol of cancer treatment. It actually leverages on the emotional, the psychosocial management for better treatment outcome. The protocol includes a joyous patient celebration held at the end of every patient treatment. Now that's the young girl. See, when she came in, she could barely walk. There was huge tumor here. She always had to wear something to cover herself up like a ninja. That is her at the end of treatment in our the joyous patient forum celebration. So because of this, we did a quick cross-sectional study on a few patients that we saw then. And I'm going to share with us the outcome of this study. The patient or relatives, they may volunteer to give a brief testimony of their journey from their first symptom to misdiagnosis, because that's always what we have in many of the cases, to proper diagnosis, and then finally to referral to ASIOCO Comprehensive Cancer Center for treatment. The occasion actually holds for a few minutes, okay, at the hospital reception in the presence of both old and new patients. Now, so these were the questions that we did ask them. Does the end justify the beginning? Do these end of treatment forums encourage patient perspective to accept to begin their cancer treatment? Because many of them would rather say their former doctor told them that their diagnosis is leading to death, there's no treatment. But this end of patient forum has actually helped many of them to actually want to undergo treatment because they know that there is light at the end of the tunnel. So these were their responses. So on a scale of 1 to 5, we asked them whether they wanted actually to participate. And then we had 68 to 84% of them said end of treatment forum helped them in going through their treatment. So yeah, so more people were influenced by fellow patient testimonials than the clinical staff counseling. You see, like I said earlier on, that I would counsel, the nurses would counsel. But then the patient said, we are just doing our profession. Our counseling, they didn't believe that. Oh, it's just part of your profession. You doctors say it's just something. But when they hear from, like they call themselves my classmates, when they hear from their colleagues, when they hear from their classmates, they are more reassured that there is hope for them getting treated. So would you love to have a similar session at the end of your treatment? So many of them said, 95% of them look forward to an end of treatment forum. 62% of this, they want to dance. 33% do not want to dance. So we just go with their preferences. Those that want us to really celebrate them and let them dance, they dance. So that just want no dancing, they do not dance. So what am I saying? The ASUPO protocol of the patient's treatment forum has changed the following perspectives. It gives them hope. The survivor's approach to face life ahead. Now, before, the patients think once they are diagnosed with cancer, they're just going to die, but they have hope now. They are hopeful for the future. They are hopeful to see the next day and the next day and to do what they want to do in their life. And then many of them they are courageous now. The patient in waiting, they are encouraged to look forward to the treatment with confidence and tenacity to start and to complete treatment. Now, it also gave them emotional stability. The counseling sessions, they have been made much easier because by the time they had heard from their colleagues, like they call themselves, so by the time you're counseling them, they say, okay, yes, so doctor, I know, okay, so what's for this stage of the cancer that they have, what are the treatment options? And they are ready to work with you through their treatments. So in conclusion, it is important for every cancer care provider to intentionally test and incorporate different approaches to address the psychosocial needs of cancer patients. At ASI Uko Comprehensive Cancer Center, we pride ourselves that our patients' testaments as being one of holistic clinical management, diagnostic, therapeutic, and most importantly, psychosocial. So I would leave us with this. ASI Uko Comprehensive Cancer Center, the first cancer center in the South Nigeria, is fully operational. We are going to have an official opening on the 6th of October. That is Thursday next week, 10 a.m. prompt. You're all cordially invited. Thank you.
Thank you very much, Dr. Adewale. I don't think there will be questions for this session. And I think we are happy that there are no questions for this session, right? All right, thank you very much. I think we will proceed. The thing is that she's available now. Thank you very much. The person that was supposed to speak first, we had to skip then because he was not online. He is actually one of my teachers, Professor Sheikh. We just call him TL Sheikh. Professor of Psychiatry, Department of Psychiatry, ABU, Zaria. He will be talking to us about redefining cancer care. Cancer is not a death sentence. It is time we move beyond lip service. So he will be telling us something that has to do with psycho-oncology, which is a very, very essential component of cancer care. Our IT people up and about. Are we good to go? Or do we have to skip it again for a while? Okay. I've been told that we should hold on. There is hope that we could link up with Professor
I'm here with you. I don't know if you can hear me. I don't know if you can hear me. Let me know if you can hear me. Can you hear me?
Okay.
Hello, can you hear me?
Okay. Thank you very much, Prof.
Can you hear me?
We can hear you. Is he visible from the screen?
He's somewhere because of this postponement. I'm actually in Tanzania. I'm facilitating a training for Africa CDC. So we just completed today's session and I had to move out because where I'd wanted to use before is now very noisy. But can you hear me? I think that's
we
the
can
most
hear you
important
very
thing.
well, Prof. It's just that we can't see you very clearly. The place seems to be a bit dark. We just hope that when you do share your screen,
let me see what
you'll
I
be
can
more
do.
visible. Aha,
Yes.
this is much better.
Can you see me now?
Yeah, now I can see the face of my teacher. Thank you very much, Prof. You are in a good place.
Okay,
so we
thank
hand
you.
we hand the screen over to you, Prof.
Smuggle myself somewhere.
Correct. Thank you, sir. Over to you. We
Do
will
you
have
want me
just
to run
20
my
minutes
slides
to
or
give us this
somebody will
talk.
be running the slides? Do you want me to run my slides or somebody will be doing that?
Okay, he should run. Okay. Prof, we will prefer it if you run the slides yourself. So you
okay,
could
just give me the sharing rights so I can.
You have the sharing rights as it is.
You have the sharing rights
already.
So let me see.
All right.
Okay. Fine. Great.
Prof, just to remind you, you have just 20 minutes for this presentation, sir. Thank you.
Well, you kept me waiting for 3 hours.
With all apologies, Prof. Thank you, sir. Thank you, sir.
So I'm going to remove my video just to reduce the bandwidth, sorry. To reduce the bandwidth, I'll remove my video so it will not be cracking. So you can hear me now? Can you hear me? I want people to respond if you are hearing me. Hello? Hello? Hello?
Yes, Prof, you are very loud and clear, sir.
Okay, fine, thank you. So I want to thank Akon for inviting me to give this talk. For quite a long time, we've been thinking of this, and until recently, I've seen that there is a lot of interest on psycho-oncology. So I'm going to, give my talk based on this outline. I will introduce psycho-oncology, then I'll present a work that we did in Zaria on cancer patients, and then I'll conclude within the 20 minutes. You see, the fact is that to be confronted with the diagnosis of cancer, or we all know that it can be very stressful and traumatic for both the patient and the caregiver. And it can be characterized by loss and serious crisis. The treatment available for cancer is no less stressful. We all know that. And both situations are associated with life-threatening experiences, and the implications of the pronouncement of the diagnosis to most patients is synonymous with death. A large majority of the patients with cancer suffer emotional problems, which may span from impoverished life satisfaction, loss of self-esteem, to mood changes, and substantial minority may even have clinical depression. Some may even, within that condition, contemplate suicide. So what is psycho-oncology itself? Well, what are we talking about? Psycho-oncology is a subspecialty of oncology that addresses the emotional issues and concerns of individuals and their families touched by cancer. It is also known as psychiatric oncology or psychosocial oncology. Researchers and practitioners in the field are concerned with aspects of individuals' experience with cancer beyond medical treatment, beyond what you can see. We are now talking about psyche, your emotions. The integration of psycho-oncology into routine oncologic care represents a major step forward in terms of holistic care for the patient and support for the caregiver. Psycho-oncology relies on the biopsychosocial model of care, a now universally holistic approach to patient care across all disciplines of medical practice and research, not only in oncology. This is more holistic. It takes the body in wholesome. Now, we conducted a study in Zaria, and the study I conducted together with Dr. Zainab Suleiman, predictors of post-traumatic stress disorder among patients diagnosed with cancer attending Ahmadu Bello University Teaching Hospital in northern Nigeria. What did we do? Our main objectives of the study was to determine the prevalence of PTSD, to determine the predictors of PTSD, to determine the prevalence of psychological distress, and to determine the prevalence of depression among patients diagnosed with cancer at Abut. We conducted a cross-sectional descriptive study, and among 300 patients aged between 18 and 65 with various cancer types diagnosed within 1 year. Participants were recruited by systematic random sampling, and all participants were administered the social demographic questionnaire, the Oslo social support scale, the general health questionnaire, major depressive disorder, and PTSD modules of the mini diagnostic questionnaire. What did we find? You will see that I put psychological distress in red. We found that almost all the patients exhibited psychological distress. And it's very important that we understand what is psychological distress. Psychological distress is a state that is in between a syndromic mental illness and normality. The individual feels uncomfortable. The individual knows that things are not right, but you are not down with a syndromic illness. And this is where psychosocial intervention comes in, which means that virtually every patient that has cancer needs one form of psychosocial intervention or the other. And this psychosocial intervention is not something that is reserved for the psychiatrist. It is something that virtually anybody can be trained to deliver. So I'll go on to talk about that, but this is very important. Almost all patients who are diagnosed with cancer needs one form of psychosocial intervention or the other. They don't have to come down with syndromic depression, PTSD, anxiety, or psychotic disorders. We found that 44% of patients were depressed, and 31.5% of them actually had post-traumatic stress disorder. Now, when we diagnose people with life-threatening medical conditions such as cancer, that is often perceived as being synonymous to death sentence, it could predispose them to developing mental and psychosocial problems. Health professionals providing oncology services must understand this challenge, accept the reality, move beyond lip service, and embrace biopsychosocial model of care. WHO has mandated health professionals providing oncology services to take courses in psycho-oncology through the International Psycho-Oncology Society. It will equip them with the skill to recognize mental health and psychosocial problems and provide appropriate intervention and referral to specialists when necessary. Today, the International Psycho-Oncology Society is offering courses, and presently there is a training that is going on in Africa. About 50 participants are in this training. I am part of this training. I saw the advert. I joined the training not because I want to learn something new, but I want to know what is being done. What are they teaching people? And I'm very impressed with the way it is going. So I will recommend that all professionals providing oncology services should enroll in the IPOS, International Psycho-Oncology Society training, so that they can improve their skill. The way they talk to patients will change. The way they see patients will change. Many a times, the way the health professional talks to the patient in itself is a death sentence. You have to speak to the patient with some level of empathy and compassion. So if you undergo this training, then it will further help you to be able to understand how to recognize when a patient is distressed. You don't have to wait until the patient comes in with a syndromic mental condition. And you'll also be equipped with the skill to be able to intervene. You don't have to refer the patient to the psychiatrist, except when they have a syndromic mental illness. So like I said, WHO mandated health professionals providing these oncology services to undergo this training through International Psycho-Oncology Society. And this is what that will do. So for the time you have given me, I think this is just okay for us to be able to discuss, for people to be able to ask me questions and for me to be able to answer them. Thank you very much. Hello? 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 Am I speaking to myself?
Hello, Prof. Yes, we can hear you loud and clear, Prof. Thank
So
you
I
so
made it
much for
very
your
brief so
presentation.
that I can
Hello,
give
Prof.
time. I can give enough time for people to be able to ask questions.
Can you hear me, Prof?
I can hear you. I hope you can hear me too.
Yes, sir. So,
So
this will give
I made
time
it
for
quite
two questions,
so
sir.
that people can ask questions.
Yes, sir. We're doing just that, sir.
Yes.
So do we have questions from the audience? We'll take just two questions, please. So Prof had a 20 minutes presentation on redefining cancer care. Well, as we know, psycho-oncology is actually an aspect of oncology that hasn't really been well developed. So we thank Prof, for this presentation. So there's a question there behind. So there's one question. Do we have another, or we just take it? Go ahead with your question, sir.
I can't hear anything.
Hello? Hello.
Now I can hear. Yes, thank you.
Prof.
Good
My name is,
afternoon.
yes, my name is Pharmacist Nuruddin Aminu Bakuri, the head of Oncology Pharmacy Unit, National Ear Care Center, Kaduna. Sir, I have
Yes, Dr.
listened
Nuruddin.
attentively to your presentation, and it's really educative. What I will be asking from you, Prof. Sir, sorry, you made mention that caregivers of this oncology patients should be able to at least assess a link. The International Society, the International Psychology, if I get it correct, Psycho-Oncology Society. Please, sir, can you help us with the link so that we can actually go and receive the training even while we are?
Yes, yes. I'll provide you with the link for IPOS, International Psycho-Oncology Society. And we also have African Psycho-Oncology Society. And until I joined the program, before I knew that we even have Nigerian Psycho-Oncology Society. I discovered that very recently. And in the training, there are about 50 people from Africa, and most of them who are from Nigeria are from Ibadan. So it's just seated there, and it's not going around the entire country. So I'll send you the link. It's very important that you have the link.
Thank you, Prof, for that. Any more questions? Okay, so I was just about saying, to encourage us that, just as Prof said, the WHO has, they've mandated that we should try as much as possible to take interest in psycho-oncology courses. They are available, and we should try to do them. So the next presentation would be by Professor Dr. Salem Yanek. She is a consultant radiation oncologist from the American Board of Radiation Oncology. You're welcome, ma'am. She will be taking us on a 20-minute presentation on cyberknife precision radiotherapy. Over to you, ma'am. This one forward and this a pointer? Yes. This forward. Okay, no problem.
Good afternoon. Hopefully everyone will be connected, not disconnected after after your lunch. Anyhow, we'll try to make it easy and simple and understandable by everyone. I know from the previous talks, it looks like a lot of people mention what I have to mention at this time about CyberKnife, but I might, emphasize some subjects maybe is still questionable for everyone. So basically, I will talk about intracranial CyberKnife radiotherapy. Is it moving? The one in the bottom? Are you sure? Oh, okay. Okay. Stereotactic radiotherapy, it's a very precise conformal of high dose of fraction. The beauty of about SRS and SBRTs is the steep peripheral dose gradient. What I mean by this, like when we have our target dose around the target, within 1 millimeter or 2 millimeter, there's a steep gradient of the isodose that's protecting the surrounding tissue. Is my voice very high? Good, okay. So it's been done, stereotactic radiotherapy more than 50 years, but in the last 5 to 10 years, it's been really the most trend oncology radiotherapy being done, in the last advanced technology of oncology treatment. Is actually coming to the point to change a lot of the standard and the first lines of the treatment, especially for small lesions that's unable for the surgery to deal with it. Stereotaxy comes from the Greek languages, is like a stereo, taxis, which is orientation in the space. That's mean there is a certain point in the body, and that's using with the 3-dimensional from all directions to get the high dose targeting that area. What the difference between stereotactic radiotherapy and stereotactic radiosurgery? They are the same technique and the same idea, but having stereotactic radiotherapy does mean having multiple fractions of stereotactic radiosurgery. Why we're doing this? Because we have to protect the organs at risk surrounding that area. Sometimes it's very hard to give a very high dose to small spot and without making a damage to the surroundings area. So that's the beauty of the CyberKnife machine that's able for us to give stereotactic radiosurgery in the way of stereotactic radiotherapy. What the radiobiological rationale of stereotactic radiosurgery is having high dose of radiation to the tumor, or if it's benign or cancer or any condition, that's mean damage to the cancer cell. At the same time, it will damage the normal cell. But having the technology with the CyberKnife or any machines giving stereotactic radiosurgery is breaking that equation. That's mean the high dose of radiation kill only the target and to preserve the normal tissue. And this is what is the technology about. What the advantage of a stereotactic radiotherapy? Definitely, is decreasing the length of the stay for the treatments. It only takes about 30 minutes of the treatments, and the patient comes walking in his feet to the clinic and having treatment, go back home walking, even driving, and go back to his daily activities. The decreasing cost, definitely comparing to the surgery needs operation room, needs anesthesia team, needs staying in the hospital for recovery, and if there's no complications, if there's complications, needs longer stay, and that's cost a lot of money. The patient after treatment able to go back to work even in the same day of the treatment. There is no need for recovery. What the indication, we can do benign tumors, we can do cancer, malignant tumors, and also we can do some conditions is not related to the cancer, such as AVM and some functional neurologic symptoms, such as trigeminal neuralgia and Parkinson's, tremors, seizures. All this kind of condition can be done with the stereotactic radiosurgery. This is a CyberKnife machine. And the beauty about this machine is the robotic head is robotic and can be able to move around the patients from all directions. You know, if I can point, you know, here. Oh, there. Oh, so how can I point? Anyhow, if you look to the head is the linear accelerator that has cones or MLCs. You know, we can use both way in the treatment plan. If you see in the top of the picture, there's 2 cameras. Those very important for real-time tracking of the treatments, which is not available in any other machines such as Gamma Knife or even a TrueBeam. This images is continuously happened during the treatment. So any movement, like the patient sneeze or for some reason he moved 1 millimeter, the machine is stop and correct the position again and continues with the treatment after correction the right position. This is the beauty about this machine, is not available in any other machines later on. See, the table also is robotic and follow all this direction. And we have those tracking system, you know, depends what we need to track, is not exist in these pictures. They call it as a sensor for the breathing movement up and down. And you know, the benefits of CyberKnife is everyone mentioned it, is like, you know, non-invasive, non-painless, no pain, is fast and can be done in multi-fractionation instead of one time of a treatments. And the treatment can be done quickly. The patient continues with his normal life as normal. Of course, no anesthesia, no blood loss, no recovery time. Trying to go fast, you know, with these. The beauty about the CyberKnife machine is can give angles of the beams more than 1400. And with the new machines, we have actually more than 2000 angles. The Gamma Knife has only up to 200 angles. So we are more free and more flexible to give more beams from all directions comparing to the other machines. This is a difference because this every patient comes to us, he asks me what the difference between CyberKnife and Gamma Knife. This is, you can see in the pictures, even now and these days, you know, the new Gamma Knife, they get rid of the rigid frame, but originally that's what the rigid frame was for the Gamma Knife. Also, Gamma Knife is precise to the brain tumors only and the upper cervical spine. Gamma Knife cannot treat the other part of the bodies like CyberKnife. And it was before invasive because of the rigid frame, you know, this needs to have some local anesthesia to put the screws, you know, of the rigid frame, but not anymore because of the new machines of the Gamma Knife is changing to like a frameless mask. But before, that's what we used to do. And the angles inside the dome is limited to the 200 beamless angles comparing to the CyberKnife. CyberKnife is really non-invasive. The mask can be done within 20 minutes, and frameless, non-invasive, the images can be done one day. The treatment can be done after 1 week. For the Gamma Knife, the whole thing should be done in 1 day, and they are not really flexible with the fractionation of the SRS like the CyberKnife. So we can use up to 5 treatments in different time. We're free. We use the same mask every treatment. I'm gonna talk about some disease that we usually treat a lot with the CyberKnife or any, SRS machine being done. The first one is acoustic neuroma. Acoustic neuroma is a benign tumor, and it's it's like schwannomas, develops in the 8 cranial nerves. The 8 cranial nerves has 2 sides, vestibular and acoustic side. So most of the patient, when they come with the symptoms, they have hearing loss unilateral, and the other symptoms is dizziness because it's affecting the vestibular part. And sometimes they come with the headache. This is the most common side effects. How do we know this is acoustic neuroma? From the symptoms is unilateral, and the shape of the tumor and the MRI, they call it ice cream cone, is well-known shape because of diastole cause intracannular extension. The side of the ice cream side is like when they had the pressure in the brainstem, and the cone when it goes inside the cannula. Those kind of tumors, they grow very slow, and maybe the patient living with this tumor for a long time, but when he start to have symptoms, he like comes from his wife or his family, come on, why you cannot hear us, when we sit in your right side, and the patient tells you, why I feel dizzy, and maybe I have vertigo, it could be viral infection. So he goes to the doctor, he give him some vertigo medication, he got the drowsy, whatever, but this continues for more than 2 months. And then finally they do the MRI and they find, there's some tumor growing in the 8 nerves. How it looks, in the MRI for the T1 without contrast is like a blonde, non-hypertense is like hypotense lesion. With the T1 with the contrast is very vivid and very bright. With the T2 also very bright and hyper intense. So this is the features like to compare this tumor from the meningioma. This is the way it looks. The first from the left side, this is the T1 without contrast. You see is similar to the brain tissue. And the other side, is bright because this is T2 images. And the third one is with the contrast, also bright. You can see this is like black spots, inside the tumor is very common in the schwannomas and acoustic neuroma to have cystic component inside the tumor. Why it happens, acoustic neuroma, most of the cases are sporadic. It happens. When it's sporadic, it comes unilateral. And that's, very common to be unilateral in one side. The other one is genetic. Have anyone seen a case of neurofibromatosis type 2 from any physician? You saw it? It's very common. When you see it one time, you will never forget it the rest of your life. They come with the rubbery, small neurofibromas covering all his bodies, even inside the buccal mucosa of their mouths. It's really not painful, but the patient has miserable life because the way it looks, in their body. And those patients, they come very common to have bilateral acoustic neuroma. They come with the hearing loss on both sides. Those are a good candidate for CyberKnife, not for surgery, because you're preserving their hearing. That's the options of the treatment, wash and wait and wash, when it has no problem. Accidentally, they found there's acoustic neuroma. Some people, they said, okay, we don't have to touch it since, it's causing no problem. Surgery, when it's so big, especially when you have a lot of pressure in the brainstem, surgery is a good indication for this. But the first line of the treatment is stereotactic radiosurgery because it's safe, and the complication from the surgery having facial nerve, because the proximity of the tumor to the facial nerve causing damage and Bell palsy for a long time. Sometimes it takes 1 year or 2 years, sometimes it's permanent. So that's why the patient now afraid to go through the surgery, and they go for stereotactic radiosurgery. This is a way we treat, with the stereotactic radiosurgery, we contour only the tumor itself, and should be like a small tumor, or is good, to have if there's residual after the surgical incision, is good to have, the treatment with the CyberKnife. I will go fast, since, I have only 5 minutes to go. This is the acoustic neuroma. And this is the way, this is the ice cream cone, having, when you have acoustic neuroma very large in the size, is good to have with the fractionated, not only one dose of radiosurgery. The reason for that, having a reaction to the one dose with the big size of the tumor, it might cause more symptoms to the patients and suffering, and also damage to the surrounding cranial nerves. So it's good to go with the fractionated. That's what I do all the time. When we have a larger tumor, I go 5 times instead of 1. And this is, the results after after 1 year, shrinking in the size of the tumor. And this is after 2 years. You can see there's a shrinking in the size of the tumor. Even, they feel like, this is improving in the symptoms within actually 1 month. But the shrinking in the size, it takes time sometimes. Trigeminal neuralgia, also, this is indication for CyberKnife treatments. I will go through further. Trigeminal neuralgia is well-known symptoms, is really very sensitive, unilateral, comes around the forehead, the cheek, and the jaw, even, chewing their teeth, their food, brushing their teeth, even the air from the AC, it hurts them a lot. So it's like a typical, painful trigeminal neuralgia. And there's many way to deal with it. Most of it is surgical intervention, especially the percutaneous frequency rhizotomy. This is really a very invasive procedure. They go with the probe inside the nose up to the root, and having this frequency, and sometimes it works, sometimes doesn't work. So it's good to have a stereotactic radiosurgery, is painless. And we go to the small area at the root of the trigeminal nerve, is about like 4 by 4 millimeter. And we are trying to avoid the motor side of the nerve, and having a very high dose treatment to this area. We have to follow very strict dose constraint to be sure it's safe for the patient and not having any damage after this treatment. This is another plan. And this is for the AVM, being mentioned before. I will go through, fast. I just want to mention about the AVM treatments. When we have a large AVM, is not good to have one dose of treatment with the SRS. The reason for that, having edema and bleeding for the large AVM and one fractions is not good. I have 2 options to do this, like having fractionated up to 5, and within like every other day, or divide the AVM to how many nidus, including there, and having a treatment to 1 nidus. After 6 months, repeat and give the another nidus treatment. That will save the patient a lot of complications. It's very slow, I'm sorry. The meningioma is really important also. I will go faster. Everyone is familiar with it. You know, of meningioma, 75% they are benign, 20% they are atypical, and 2 to 4% they are anaplastic. And depends on the location. It's similar to acoustic neuroma. But it's, I just want to mention this really important. The meningiomas doesn't arise from the dura, as everyone's saying. This is arise from arachnoid capsule, where that's mean why all the meningiomas are very vascular and tend to bleed. When they do surgical resection, there's a big complications happen after the resection to have a bleeding. So most of the cases, they do embolization before the surgery to prevent kind of a bleeding. The areas, you know, in the base of the skull of meningioma is good to be treated with the stereotactic radiosurgery to avoid any complications related to the resection. And also I will go, the grade, you know, of symptoms is really important to know if the patient needs the treatment after the surgery. Trying to go fast, I'm sorry. We can do SRS or SRT, depends on the size of the tumor and the location. I have a case came with the suprasellar case, which is encasing the optic nerves bilateral and putting a pressure in the optic chiasm. This lady, I went with the fractionated, I give her 5 fractions of the treatments because I don't want her symptoms to get worse. She had diplopia in both eyes, you know, because of this pressure. And amazingly, you know, after 1 week of the treatment, all her vision been improved because of this treatment. And she didn't need surgery. Even the surgeon, the neurosurgeon, they said, we cannot touch you because of the cranial nerve surrounding this tumor. I want to mention something about, you know, the meningiomas. There is very important for the radiation oncologists when we have, I'm sorry, but this is really important, you know, for the dura tail. The dura tail, not every meningioma has a dura tail. And the question is, this dura tail has cancer in it, has meningeal cell in it. And when you do the volume, do you have to include the dura tail with your volume? The question about, they found out, you know, from RTOG, there's only 70% of the dura tail has contained some meningeal cell. So what do you need to include? Sometimes the dura tail comes all the way around, you know, the tumor. Do you have to include all this area in your volume? The question is, you know, they found there's a study being European and RTOG, they found you need to be in the safe side, the thick area of the dura tail, the liner thin area, you don't have to include it in the volume. And that's, you know, sometimes you have what they call in-block treatment when the meningioma infiltrate, you know, in the bones, you have to include the whole bone with your volume when you do stereotactic radiosurgery. I cannot finish the brain mets? Okay, that's okay. This is, you know, how we can tour the tumor. Okay, I have to stop it because everyone, they said me, time off. Any question?
Okay, hello, okay. So
No
thank you.
questions?
Yeah, there will be questions, but after the next presentation, then we would have questions for, yeah. So ma'am, you may have a seat whilst we call in the next presenter. So thank you so much for your presentation. Professor Yanek, you did justice to the topic. Thank you so much. Well, you took us through the indications of cyberknife, and I think what's clear to us is that it's not just limited to malignant tumors, but to non-malignant tumors as well. So we would quickly call on the next presenter. He is Professor Sridhar from the HCG hospitals. He is a professor of radiation oncology and a specialist in cancer care, of course. So he will be taking us very quickly through new dimensions in management in oligometastasis, CBRC cyberknife. So Professor Sridhar, the floor is for you. Are you here? Okay, all right.
Thank you. It's both.
Yeah.
That's for the down. So for going back, this one. Yeah, I'm just going back. Got it, got it. Good evening, everyone. And yeah, I'm Dr. Sridhar. At the outset, it's pleasure to be here on OurCon 5th conference. And I'm so delighted to be here because Dr. Bello is organizing this. And our association goes for almost around more than 2010, 2009, 2010. So it's very happy to see a lot of colleagues among us. We are grown together. So that is one of the things, like when you come to a radiation oncology conference and you see a lot of your colleagues and how we are developed over a period of time. So I'm going to talk about oligometastasis. So that is totally a different subject. We are talking in the morning, since morning, about how to treat a small tumor and how to treat in a different manner. So our precision oncology has made a lot of difference. So now changing gears, I'm going to talk about oligometastasis, a new tool. It's actually new definitions as such, we can call it as. Let's see what is there. So I'm going to talk about the introduction as overall, what is the definition of oligomets, role of SBRT in oligometastasis, and our experience. So it's always important to show your experience, what is there over a period of time, how innovatively you are done, and what you did it 10 years back is actually the one what we are following now. So this is cancer facts of Nigeria and across the world. If you see, like the top 5 to 7 cancers in Nigeria, the breast cancer is still the number one. And if it is, and the lung, as I'm telling that, the colorectal, prostate, liver, and breast and lung. These are the top 5 cancers, which is definitely making a lot of contribution. And these are the things, if you just see 1 decade back, a lung cancer, when you see, we always tell that that's a death sentence. Same with the liver cancer. Same with the breast cancer. But now we have evolved in such a way that definitely we made a dent in terms of overall oncology is concerned. So this is the fact we see around, this is for the Nigeria. So we are around 1.24 lakhs cancer patients, new cancer patients. That's a good contribution. And most of them, if you see, it's a breast cancer. Prostate cancer is definitely the one which is making a lot of difference, and a lot of patients, which is one of the definitive or a curative intent cancers, we can definitely extend the life of the patient. So coming to what is oligometastasis, if anybody, any residents are in the crowd, this is definitely an examination question. Oligometastasis is definitely the one which is examination question now. So this is originally like it's defined by Hellman and Wishelbaum, an intermediate state between local and systemic disease, where radical or local treatment of the primary cancer and all metastatic lesions might have a curative potential. So we underline here is a curative potential. If you see a breast cancer with a single vertebral lesion, a small lesion with a vertebral lesion, it is segregated as a stage 4 cancer, and she's pushed to the stage of stage 4 and a palliative intent. Same with the lung cancer, same with the colon cancers. So now actually definitely there's a change. We have seen that in our clinical practice, treating these lesions aggressively had definitely made a dent. So what is oligometastasis definitions? It has evolved over a period of time. Now, if you see what is oligometastatic disease, it is keeping into the mind. So there are some of the things we had to keep in mind is outcome of the disease burden, disease type, and there's an alternative hypothesis. So outcome is, it's an intermediate state in which local or treated metastasis control may yield improved systemic control. So that is, we are talked many things about abscopal effect and the systemic treatment because of the radiation. Disease burden. So limited number of metastases. This has started with, especially with the prostate cancer, 3 to 5 lesions. The volume of the disease we defined into two high volume disease and a low volume disease. Same thing is extended to the lung and the liver and the colon. Limited number of sites or regions, single or limited number of organs, limited number of metastasis and sites, limited number of distant metastatic region that contain the primary tumor. Disease type, more indolent disease. The radiobiology of cancer is still actually we're redefining ourselves. By knowing more and more, we come to know that how little we know about overall cancer. So definitely these indolent cancer types and the aggressive types has to be differentiated. So there's specifically certain organs. So they have an affinity for certain organs, like a prostate cancer going into the bone, or prostate cancer, the breast cancer going to the bone, or as colon cancer going to the liver. So these are some of the things that has made a lot of difference. Alternative hypothesis is oligometastatic represents the transition between a localized and a widespread systemic disease. So this is a window period, what we are talking, where if you treat them aggressively, probably we are looking for a definitive or a curative intent. That is the one, what we are looking at. So that has made a definitely different changes. Then we talk about synchronous oligometastatic disease. That is actually de novo oligometastatic disease. This terminology is very important. We cannot just group every patient of metastatic disease into palliative care. So that is the one we are looking for a definitive intent. Metachronous, yes. So oligometastasis within 3 months is the period, even if there is a new lesions coming, where potentially a small lesion can be treated with a definitive intent, makes a lot of difference. So oligoprogression is another terminology where we see that you are given the treatment with the primary is under control and there is a new lesion which has come. Or after some times, one particular metastatic disease progresses slowly, but overall there is a systemic control. So these are the patients actually, if you go and treat only that area, still continue the systemic treatment had made a lot of difference. So that is called what we call it as oligoprogression. Oligopersistence. There is a multiple metastasis. You give full treatment, systemic treatment on all the lesions are under control or reduced. Probably the primary or the one metastasis or two metastasis, limited metastatic disease is persistent. So that is called oligopersistent disease. So this is how look the prostate cancer. In prostate cancer with a metastatic disease, if you go back to the ASCO 2015 paper, the limited versus the high volume or the low volume disease, addition of chemotherapy to in these things, there was a survival advantage. So in the same period, I started the SBRT to the primary and the oligometastatic way back in 2010. So that is afterwards they found that definitely addition of the treatment to the local site and the metastatic disease, not only like progression-free survival, it has shown a survival advantage over a period of time. So here, this is a natural history of oligometastatic disease. We are aware that we are not here to make a patient immortal. There is going to be a case, the progression of the disease, but how long to postpone the goalpost? Remove as much as possible. That is what the end results, what we are looking in oligometastatic disease. So that definitely before going into polymetastatic state, so oligometastasis treatment can be done effectively. There are a lot of theories which is why this oligometastatic occurs. So there is the most widely accepted is seed and soil. That is, there should be a seed and soil, both primary and the metastatic site should be favorable to like acquire the particular disease. So this is how it shows, and there is a lot of work. This is the oncology right now is in a very, very peak, and actually there is so many things are coming up, and we have to get into these integrities of the patient areas. The biology of oligomets in as we see that one cancer cell gone and don't be there as a part of the lung or the other one because of the slough, versus the progression of the disease. Treating primary in any of these oligometastatic disease made a lot of difference. There's a big debate, and we are already incorporated in our treatment schedule. That is same holds good for lung cancer. Lung cancer, because of the newer things, newer molecular targets available, immunotherapy is coming in a big way. We have seen a very good response. I won't call any stage, any lung cancer as less than, in the past 2 years, survival was not even 20% before the gemcitabine was there. So now we are talking about minimum of stage 4 disease of minimum of like 5 to 10 years. 10 years survival reached to our own patients, almost around like 60 to 70% of the patients, even with brain metastasis, is reaching to the 10 years. So these are the some of the terminology we should know about that. See, same thing in case of breast cancer. So this in case of lung cancer, that's we need to find that sweet spot, like where we can target the primary lesion, target the metastatic disease, and get a clear-cut increase. Same with the polymetastatic disease in case of breast cancers. I'm going to take 5 more extra minutes. So primary, in case of breast cancer, we are seeing that breast cancer is gone into a totally different stage where we are looking at definitely a very, very high load of disease. So the oligometastatic presentations, definitely we have made a breast cancer into a really chronic disease. Immunotherapy, how to treat this oligometastatic disease? We have chemotherapy, we have biological agents, we have immunotherapy. The newer things is definitely immunotherapy, which is now we are looking at a cold tumor, hot tumor, alternate like ordinary tumors. So how to stimulate the cold tumor into hot tumor? That's on one of the things which is going on, making a cold into hot. The radiation is going to be that. Synergism between the immunotherapy and the radiation is in a big way now. These are the 4 cases, 4 areas we are concentrating more: breast cancer, lung, prostate, and colon cancer, and miscellaneous. There are trials where we are talking even in array tumors with oligometastatic disease, we are seeing a difference, and we are like extending the life of the patients. There is enough literature available. There are a lot of trials going on right now. In case of combination of oligometastatic disease, in case of prostate cancer, we are seeing progression-free survival and overall survival data is also there. And addition of the primary treatment to the prostate cancer has made a difference. You can go through this. I don't want to go in detail. So with the limited toxicity, that is what is the key. And there is, in case of like NSCLCs, there's always a trial. There is a lot of trials going on, even in case of brain metastasis. So this is with breast cancer. Breast cancer is going to be the more interesting. The data is like upcoming, and we see that a lot of 60 to 70% of our breast cancers are presenting with triple negative breast cancers going into metastatic disease at presentation. How we do it? History and clinical examination is very important as much as possible. Like it's biopsy is a mandatory. Like whenever the biopsy is done, please keep the IHC and the genomic study intact, or keep the tissues intact so that it may be required for the future. So we do routinely PET-CT radiotherapy planning and MRI brain. Routinely, we do it for lung cancer and triple negative breast cancer. We don't want to miss those and say sorry. Sorry is a very, very bad word in oncology. Multiple, there's a MDT. The MDT discussion is a mandatory. Everybody should know that how much to do, how much to contribute for the patient. Then coming to SBRT, we all see about the type of SBRTs, what we are doing. So I don't want to go in detail. What we are looking is a small target. That's how the definition started. Now there is nothing like a size criteria. If your gadgets are good and the man behind the machine is like how risk we are taking, vis-a-vis with the results what we are looking at. The motion management is the key. And the case selection is definitely the one of the important, keeping it in mind the side effects. So radiobiological aspect of hyperfraction is already done. I don't want to go back into that. Definitely the dose fractionation schedule is one of the key. I believe in anything between 5 to 8 gray per fractions. Anything going more than 10 gray per fraction. So going up to 12 into 560, that fancy type of, definitely the dose increasing probably may not be a very good idea, because we lose that systemic effect of radiation, the ablative doses, what we are looking at as an immunomodulatory effect. These are the SRS SBRT platforms, what we do. I use CyberKnife as the main thing. So coming to the CyberKnife, so there are 3 videos, because like since morning, everybody is talking about CyberKnife. This is very important. This video makes it more understanding. We have to observe the immobilization device, what we use, it is very, very minimal here. You have a strong imaging system. We do the PET CT scan. You should be very, very I'm very happy to see that the Mercure has got the PET CT scan. I use PET CT scan simulation for all our patients on treatment platform. So when the patient lies on the couch, we plan we plan the patients. There are DRRs are generated in 6 directions. And the difference of about the normal radiation versus the LINAC is the CyberKnife is you have an option of 6 degree of rotations, 6 degree of changes in case of the table. And also there is a more than half a globe of freedom of entry to the particular point what we are looking. Here there are important things. They have XD skull track, 60 skull tracking, XID spine, XID lung, spine tracking, and also the fiducial tracking for soft tissues involvement. And as you see that, there is definitely the lung tumors which moves with the respirations are tracked very well. For all these areas, I don't give any margins. PET CT scan, MRI is based planning what we do it. And the accuracy of the treatment compared to other systems, the CyberKnife scores, because you're going to continuously tracking, the margins are very, very less. Practically, I don't give margin. So it's an high precision tracking, motion management, high dose delivery, rapid dose pulse, and patient friendly. You can stop at any time, go and take a break and come back and restart the treatment from the same time. So that is the beauty of the CyberKnife. So the indications we already know about that. SBRT for oligometastasis. Now we'll concentrate on SBRT for treat mets alone. There are different theories. In many of the trials, they treated only metastasis, don't touch the primary. Even though among ourselves as an oncologist, a lot of times says that don't touch the primary. No, I think the things are changing. So we may have to consider for treating the primary, that because we always say that I want to know how is the response to chemotherapy, how it responds. I don't think so it's the right idea. Treat the primary is definitely one, or treat both primary and mets. That's what I do it routinely. So the immunogenic cells, we've already seen that the radiation injury by the SBRT is not even the local. It is always a systemic now. The antigens produced or immunity, what we develop, acts as a cancer vaccine, and the systemic treatment is very much effective in these things. And that is what we are seeing. In combination with the immunotherapy has made a lot of difference. Both of them act synergistically. Even hyperthermia is acts as a synergistic with SBRT. We use this in some of the cases. So advantages of SBRT for oligomets is only a 5-day treatment and accurate focused high dose radiation, radiobiological advantages, no delay in systemic treatment. That is what we worried. And local control equivalent to surgery, immune stimulation of the tumor. That is what we are looking in a bigger way now. Synergistic effect with immunotherapy is some of the examples I'm going to show that. No repair in between the fractions. No repopulation, vascular damage is one of the things what we are looking. No distribution and immune stimulation. So the comet stays, if you know about this particular one, I don't want to go too much in terms of literature. SABR Comet is the first one. They treated the oligometastatic lesion, not the primary. So they see that there is an advantage along with the immunotherapy. They saw that there is a 41 months advantage in case of lung. The treatment-related side effects are very, very low. So then this is, again, I'm showing that because that changing to immune to cold tumors to hot tumors, addition of SBRT is the best method to make it hot tumor. There is enough literature to say that there is a survival advantage, local control in the form of almost around 75 to 80. In some cases, it may reach to more than 90%. So there is already there are a lot of trials going on in case of one. SBRT, the primary, yes, this is the advantages. We have a multiple pathways to consider. And prostate, there's already trial going on and show that Stampede trial. So treating the primary and the metastatic disease in whatever the form has shown the survival advantage in this subset of patients. In combination with the hormonal continuation of the things made a lot of difference. So what is the future? What is happening now? Comet 10, SABR5, oligo rare. So these are some of the trials where combination of the SBRT alone, SBRT plus immunotherapy, vis-a-vis with the other treatments is going on. Definitely, we are going to see a lot of difference. We are contributed some of our cases to the literature. This is SBRT with immunotherapy and SBRT in case of NSCLC and the primary and the metastatic side. Here, we actually included the brain metastasis. Any of the studies, usually they exclude the brain metastasis. We have seen definitely a survival advantage and the progression-free survival in this subset of patients. There is also how to assess that immune markers. Is there immune markers can be a surrogate marker in this particular case? Which patient is going to be representing or responding? Which particular treatment? We are in the process of that. Do the immune markers before and after SBRT with or without immunotherapy is ongoing. We are already published a small part of it. And some of this, our colleagues from here is also a contributor for these studies. SBRT, prostate with hormone treatment, treating primary and oligometastasis. This one I started almost 2009, 2010, before the Stampede trial started actually. So this is definitely our strength. We are seeing the 5-year survival rate was 87.5%, and the overall survival was 117. It is reaching almost 10 years. These are metastatic disease, all the metastatic prostate cancers. Depending on the size and the site of if it is a multiple metastasis, we always give hormone treatment, wait for 3 to 6 months. When it becomes downstage, go and treat the primary and the oligometastatic because it's very, very safe to deliver. Addition of hyperthermia and hepatocellular carcinoma with metastasis, we have seen even in the liver mets, we've seen some of the advantages. Actually, hyperthermia is one thing, probably is an alternative to the poor man's immunotherapy. So if the immunotherapy cannot be afforded, definitely hyperthermia can be added to the liver metastasis. So SBRT in case of metastatic HCCs. This is our responses. I'll rush through some of the case scenarios. So the CyberKnife, we have done almost from 2009. So now we are reaching around 4,744 cases, and total is my contribution is almost around 3,092, like almost around 60% of the patients, 60 to 70% of the patients are more. Thank you. So some of the things, actually my contribution in terms of one, I think there was, it's become black. So the different types of tumors, what we have done, 60 skull is around 1,400, this excite spine 625, 428 and 527. So this is some of the metastatic directed therapy for different areas. So like if you can change the color of the background, like is it possible? Now in this slide itself. Okay, no issues. So those are the number of metastatics, different sites of what we have treated. And somebody was talking about how to manage, like I'm going to concentrate on brain, lung, liver, and spine. The brain metastasis, up to 5 lesions, less than 5 centimeter, we can go and do SBRT to do these lesions. There was a lot of discussion is going on. If you want to start an SBRT program, we are always there to help you on a normal LINAC. The best thing is to start is in case of like it's treat the lung metastasis, single mets, give 3 to 5 millimeter, treat 5 to 5, you will get the confidence. Same is with in case of one, somebody was talking about whole brain RT with hippocampal sparing. There is nothing like a rocket science in that. You need to discuss with your physicist. We are ready to help them. And actually that shows a lot of good thing too for that. So immunotherapy followed by SBRT and this. So oligometastasis with solitary brain mets at presentation. So I'll take only 1 minute. So this is the responses, what you see. There is almost a complete response is almost 3 years now. And this is a hippocampal sparing with followed by vertebral metastasis in even the multiple areas can be treated. And there's a squamous cell carcinoma lung, the bigger lesions. There was always a question that how big. I've treated up to 12 to 15 centimeters sometimes with a good response. This is one. This is SBRT with immunotherapy for breast cancer. The multiple brain metastasis treated with SBRT. Colon with liver metastasis. This is a huge lesion of around only the 10% of the liver was there, but it started 2018. We started SBRT with immunotherapy. Is still doing absolutely fine. So to conclude, definition of oligometastasis, low and high volume. We have actually in this year we are presenting polymetastatic disease SBRT in breast cancer. So it is accepted for ASTRO presentation. So we'll be presenting that. We see that as early as possible addition of the metastasis, if it is feasible, go and treat. There are trials which is going up to 20 metastases the people are treating. So SBRT timing and upfront sandwich are consolidated. If the low volume, I prefer to go and treat as early as possible. SBRT to primary site, always I prefer to treat to the primary area along with that. And SBRT dose radical versus palliative. Here, actually situation, there is no dose differences between SBRT. Either I do liver primary, liver metastasis, lung primary, lung metastasis, brain primary, brain metastasis. Dose remains same. Go and treat full. SBRT re-radiation is absolutely possible in these some of the cases. SBRT immunotherapy combination makes a major difference. Thank you. Thank you for your patience.
Thank you, Professor Oshida, for that presentation. Now I see why you needed a second microphone. So thank you so much. And also thank you for giving us an insight on what the likely exam question will be for residents, which is oligometastasis and the treatment option. So very quickly, we will take the questions for Professor Yannick. So she did take us through a CyberKnife precision radiotherapy. So are there any questions for her? We'll take 2 questions, please. Any questions for Professor Yannick? Okay, the gentleman behind.
Thank you very much. My question is about the treatment of using CyberKnife for meningioma. When you mentioned the dura, do we treat the dura or not? Because some people say you treat, some people say we don't treat. The dura is expected to contain some of the cells. So do we treat the dura or not? Then if you've done both, the recurrence rate or the tumor control rate versus the side effects, treating the dura or not, any significant difference? Thank you.
So thank you for that question. Any more? There are 2 questions for her. So I think you can go ahead with the answer. there's a second question. Or would you like to answer this before the second question? I think you can use the mic. You can use the microphone.
Yeah, I think now it's working. If you mean, the dura, as I mentioned before, about 70%, it has some malignant meningeal cell, related to the meningioma. But they found also 30% doesn't have this meningeal cell. So it's just a reaction from the dura to the tumor itself. And now the question, there's 70%, it might have, meningeal cell, and we don't have pathology to know if it's included or not. So now the standard is one, to include the thick area of the dura with your tumor volume. But if you have a linear extension, which is like a thin, reaction from the dura, should not be included the tumor volume for your cyberknife or stereotactic radiosurgery for meningioma. But the thick area should be included, yes. Because there's a bigger chance it has some meningeal cell.
So usually what we do in CyberKnife, you don't have to include the wall of the dura, which is extended. Probably like 2 to 3 millimeter of thick dura, and then it thins out. The thick dura part of it is initially, which is attaching to the tumor side, is enough. That's what we also do it.
What the other question?
Yeah, thank you very much for the beautiful presentations. My question is to the panelists. Well, over the years, until recently, in this country, what we witnessed for some decades, it was all about 2D treatment technique until recently. And when we, now begin to witness the advent of 3D, IMRT, it's obvious from this presentation that many of our patients will benefit from SBRT cyber surgery. So I just want a recommendation from the panelists. Is there, what do we have to do that will take us there as soon as possible? Then secondly, for conventional radiotherapy planning, there is oftentimes a need to fuse images like MRI with CT for better tumor delineation. And then going by this presentation, and as we know, having to deliver high dose of radiation per fraction for SBRT and CyberKnife, the risk of radiation to the contiguous structures or the normal surrounding tissues are there. Okay, are there things you have to do differently in order to limit the risk? Do you have to fuse images, or do you have to employ some other techniques? Thank you.
The first question
I think the question is to both of you.
Eye precision, how to incorporate. Is that right? The first question is from 2D to IMRT or eye precision, how to incorporate fast. Yeah. And see, if I tell my journey, I want a mic, I have to stand. I can't sit here. So I have come from a place where there was no machine in certain time, and the 2D cobalt, then LINAC, and then IMRT or IGRT, gamma knife, cyber knife, hyperthermia, hyperbaric oxygen, everything. Proton is yet to come. I may just like use the proton also. So the biggest, I didn't finish by telling the biggest constraints is you, within you is the one. So like even in oligometastasis, the doctor is the biggest constraint. The second one is the finance. Otherwise, a lot of patients will be required. To answer your question, so there is always a mentor which is there.
you have to go and talk to your physicist and technologist, and you as a team, if you can make it. There's nothing like that. Even in cobalt, we have done the eye precision. The biggest thing is the pituitary adenoma. I'm sure you are treating a pituitary adenoma with a 3-field technique, with a hyperflexion or an extension. So that is the best way of the eye precision, what you have already started. Those type of starting from a 2D, going into IGRT, makes you the best oncologist, because a lot of newer people who are doing, they don't know the anatomical landmark. With the 2D, you have trained very clearly from where it is that, like from far, you will say that your fields are right or wrong. I won't really agree with that. Transition is going to take time. 3 to 6 months, probably. It's going to take time. We are ready to help you at time. I didn't tell, because if you can always contact us in terms of any transition technical issues, starting from the physics, like including the clinical part of it, we are ready to help. You want to come and spend back home, that is absolutely fine. There is already, that's why I started. 2 things are very important. Number one, any brain metastasis or any spine metastasis, you can do a localized treatment, not required of whole brain. Single metastasis, be confident. 2D planning with the CT scan is good enough to plan to this one. MRI is not mandatory all the time. At least if you have a diagnostic MRI to mainly rule out multiple metastases in the brain. So other than that, the prostate, you require only for the, like to see the apex of the prostate. Otherwise, I don't think so. But the transition going into IMRTs, going into the margin of 1 to 2 centimeter, 3 centimeter is absolutely fine. The second question was? The second question was the dose of CyberKnife. The dose, see, actually, madam showed you already. When we are talking about serial and the dose constraints to the normal structures, we so much high doses. Here, when you do SBRT, imaging is a robust and imaging system. You are going to have a continuous. The dose is, sorry? That's not a problem. You don't, image fusion, most of the time, 90 to 95%, whatever the planning system will fuse automatically. But you need to see very clearly the point-to-point fusion. If you see that, it's only 2 hours of job to make you understand. It's not a rocket science. So your CT is the base that is to be robust. Don't rely on too much. If I have a doubt of fusion, mark on your CT, which is your basis for the treatment. The dose of radiation is absolutely, like, as I told you, the dose fall. So dose fall is 30% dose fall is within 3 to 8 millimeter, maximum 1 centimeters. So you are not even looking at the 50%. In cobalt or any LINAC, your 50% comes to the skin. So you don't have to worry much.
So thank you, Professor Sridhar, for your second presentation. So do we have? I think we can take one more question for his presentation. One more question. Do we have any question for Professor Sridhar? All right. So we'll wrap this session. Thank you so much for your lectures. We have benefited a lot. Thank you so much. Thank you so much.
Thank you. Thank you very much.
So we'll call on the next speaker, our LOC chairman, Dr. Bello Abubakar. I know he would deliver this very quickly. Thank you. Thank you so much.
My slides. Hello, thank you very much. This will be the last talk today, and I hope I will render it in 5 minutes or so. So I will be talking on innovative cancer medicine, feasibility and acceptability in limited resource setting. We have 5 minutes more. Okay, thank you. Fair enough. So we've been following this demonstration study trial for the last 4 years. And I'm happy to know that we are going to start it very soon at the National Hospital, where we will be, looking at feasibility really and acceptability of innovative medicine, in particular in nivolumab. So as an outline, we will talk on the rationale of the program, targeted therapies, just to remind you, versus immunotherapies, and then the innovative cancer medicine in Nigeria, next steps, and then questions and discussions. Okay, so what's the rationale? Cancer treatment is LMICs does not make use of all the tools deployed in cancer treatment as is obtained in high income countries. We know that the standard of care in sub-Saharan Africa is seriously constrained because of lack of access to standard surgery, to radiation therapy. We've seen the kind of fantastic work some people are doing with radiation from around the globe, cyber knife, gamma knife, proton therapy today, and people are doing tractography, functional MRIs. So these are things that we hope going forward we'll be able to have them, but at this point, no. Even the chemotherapy that we've been using, there are quite few, and a lot of them are not readily available. Of course, targeted therapies, targeted drugs are rarely available, and immunotherapies until maybe a few weeks ago, one will comfortably say that they are not available at all. But I'm happy to note that some pharmaceutical companies have actually came with a lot of new innovative immunotherapies. So the goal is to ensure that cancer patients can receive the most effective new medicines, which include biologics, immunotherapies, in a timely manner, rather than decades after their introduction in wealthy countries. And that's why we want to do this demonstration trial. We've noticed that most of the treatments that we do have here, we're not involved in any form of trial per se. I note that some of the treatments for, say, for example, prostate cancer, which has the highest prevalence in sub-Saharan Africa, are not actually involving Africans and people of African descent. So we do know this for the sake of residents, what is the difference between targeted therapies and immunotherapies. We know that targeted therapies, they target cancer-specific genes or proteins or the tissue environment that contribute to the cancer growth and survival. While we know that immunotherapies uses substances made by the body or substances made in the lab to improve or restore immune system functions, right? And there are many types of targeted therapies. We have monoclonal antibodies. We have small molecule drugs that, for example, that are used to stop angiogenesis. Of course, when you talk of the type of therapies in immunotherapies, there are quite a number of them. We have monoclonal antibodies and tumor agnostic therapies that target immune checkpoints. So those are the immune checkpoint inhibitors. You have some non-specific immunotherapies as well. We also have some oncolytic virus therapies that some kind of viruses that can be used actually to stimulate the immune response of the body. Of course, we have T-cell therapies as well. We have also cancer vaccines. Of course, we know them. Trastuzumab is an example of a targeted therapy that target the HER2. Rituximab targets CD20 and so on. Nivolumab, of course, is an immunotherapy, and that's the one that we hope we will use. So why do we want to use the innovative cancer medicines in Nigeria? primarily, we are going to be strengthening not only the clinical system, but also laboratory systems through research. So we are going to focus on diagnostics, getting the drugs, and at the end of the day, we are focusing on a particular disease, which is colorectal cancer. So Roche Diagnostics helping us in developing immunohistochemistry by providing reagents and supplies that will enable us to do MSI high, that is microsatellite instability, as well as mismatch repair deficiency. Of course, BMS, a company that produces nivolumab, will be supporting us with the drugs, and the focus of our demonstration trial is actually colorectal cancer. Of course, you know that you can use nivolumab in many other situations. So what do we intend to achieve? First, we want to raise awareness on the use of immunotherapy. We want to also build hospital capacity that others will also learn and be able to introduce innovative medicines. We want to demonstrate the safety and effectiveness of these medicines in a low resource limited settings. We also want to expand patients' access to novel cancer therapies, since these drugs are going to be provided to the patients free of charge. And of course, we will develop regulatory pathways, for bringing innovative cancer medicine into the country. And importantly, we will also be strengthening partnership between cancer hospitals and industry partners, BMI, Roche, and Chai, that is facilitating the whole things. So thank you very much. I hope my 5 minutes is well spent, and I'll be very happy to answer questions on this particular instance. Thank you very much. We hope immediately we get the regulatory approval from NREC. We hope we'll be starting this demonstration trial next month, and we hope that we'll reach out to other oncologists to support us, patients and all that. So thank you very much. I'll be very happy to take questions. No questions? Thank you.
Thank you. Thank you, our LOC chair, for that very brief presentation. Do we have questions for him? Any questions? Okay. So thank you so much, sir, for keeping the time. So I think we'll wrap up. That's our last presentation for today. Thank you all so much for taking the time out to listen to all the presentations. Thank you for the questions. Thank you for making this interactive. So, Madam President, do you have anything to say to us? Okay. Doctor, the Vice President, the VP, is not even. So we encourage us to try to come here tomorrow early. Presentations, we start with the abstract. Yes, we have very, very interesting abstracts for you. We have case reports, and we are going to start here, God willing, 8 a.m., same venue. So we encourage us to be here on time. So I wish us all a good night rest, pleasant night rest. And on your way out, please, visit some of the stands on the way out. So thank you so much. Yes, tomorrow, 8 a.m. 8 a.m.